All right, good morning, everybody. People will be trickling in as we're starting this conference. I want to welcome everybody to our third now Advances in Comprehensive Stroke Care annual conference. It's been quite the ride trying to organize these conferences, especially in the setting of a pandemic. It's now our third conference, and unfortunately, because of the amount of participants, we had to go again remote this year. We have a really exciting lineup of panelists for you, and the whole meeting is broken up into two sessions. The morning session will be the ischemic stroke session, and the afternoon session will be the hemorrhagic stroke session, and we're going to finish the conference with a round table from our emergency room experts from all our sister facilities. As people keep trickling in, as I can see, we will start, and it's my great pleasure to welcome Dr. Jake Olbin, who is our Assistant Chief Medical Officer, and he's new to this role, but not new to Catholic Health, and he's been leading quality for a very long time, and we've been working together on a lot of projects from that aspect, and I'm very excited that he's leading our initiatives now as a Chief Medical Officer, and I'm going to let him speak, and the first session will be co-hosted by me and the Chairman of Neurosciences for Catholic Health, Dr. Mearson, who you will be able to hear, maybe see, maybe not see. We'll see. Jay, take it home.
Thank you so much, Dr. Beckless. This is exciting and amazing. I know we have a lot of people on the Zoom call this morning. I do wish we were in person, of course, and hopefully by the time the fourth annual meeting comes, COVID will be hopefully a distant memory, or more of a thorn in our side rather than an overwhelming pandemic. It's a pleasure to be here today. This is so exciting. The menu that will be presented today is really, really remarkable. But first, I want to thank and call out Dr. Beckless. He is he will not brag about himself, but I certainly will. He's got a stack of titles. Most importantly, in my eyes, he's the chairman of Neurointerventional for our system, and he really drives stroke care, not just at Good Samaritan, where we have our comprehensive certified center, but throughout the organization. And I can't thank him enough for his guidance and his leadership. I took 2 seconds and PubMeded him this morning. He's going to chuckle, right? He knows I'm always PubMeding. 137 publications, including up-to-date COVID stuff, which is really, really remarkable despite his clinical duties. So, Kimon, first for you, thank you. Thank you for your leadership and all you do for the organization, and thanks for having me here. And then, as you take a look at the panelists, I'm going to say I like to know a little about stroke and neurocritical care. Dr. Mason has helped me through my neurocritical care boards, but the people who are speaking today know far more and have some pretty extensive knowledge. So let's just run down the list. We have Dr. Donnarumma speaking around medical management of acute stroke. We have endovascular treatment of ischemic stroke by Elizabeth Hogan. Really great stuff. Then we get into some neurosurgical interventions from Dr. Misios. Bruce himself will speak around secondary prevention, right? What is the role of medical management? And then Dr. Beckless will be back talking about carotid revascularization. We have some great seminars, and I'm really pleased to see nursing leadership also speaking. It is really great. We are a comprehensive center throughout the organization. It's not just doctors. This is a team approach, and I love to see Karen Antaki on the docket there, along with Dr. McConnon, who I've been calling for stroke for rehab consults at Good Sam since 2008. Then we get into session 2 in the afternoon, hemorrhagic stroke. I am super pleased, and I know about your collaboration, Dr. Beckless, with Mr. Crawford and the Lisa Colagrassi Foundation. I'm I'm an ABC fan and was a fan of Lisa Colagrassi, and I still remember the morning when they shared that horrible news, and the work that you're doing there and the whole foundation is doing is really, really incredible, and I applaud this collaboration. So thank you for that. Then you have our neuro ICU director, really somebody who's truly an expert in neurocritical care, Dr. Ahmad, talking about critical care management. I certainly won't miss that one. We get into Dr. Palumbo, our chief of neurosurgery, talking about minimally invasive approaches to intracranial hemorrhage. Great stuff. And then, as you said, we get a little bit of a break in the afternoon, and then we really talk about what is what's the role of a dual trained neurosurgeon, really the future of neurosurgery here around management of cerebral aneurysms, saccular devices, again, some really cutting edge stuff by preeminent Thomas Jefferson professor, Dr. Jabbour. I'm pleased to see that you brought him along. And then, what stroke conversation can happen without our emergency room leadership. And it's great to see these leaders who I've worked with them all clinically, not just administratively. And between Dr. Ryan, Georgie, Dr. Bramonti, and Dr. Rayo chairing, this is an incredible, incredible day. So I'm going to say to everybody, settle in. You have to get into your Zoom meeting mode. You have to have your coffee. And you have to be ready for a great, exciting day. So Dr. Beckless, with that, I wish you the best today, and I thank you again for letting me kick off the meeting. Thank you so much.
Jay, thank you. Thank you for your kind words. Thank you for your support. And we're looking forward to a lot more years of these meetings, and obviously a lot more years of trying to advance stroke care in the South Shore of Long Island, Suffolk County, and beyond. With that, I want to kick off the meeting. Welcome again, everybody. Dr. Mearson is, you can see him now. He's back in technology mode. So I'm gonna start with a brief presentation of our program and discuss the advances that this program has achieved in the last few years. And certainly it's been an honor to lead part of this program together with folks like Dr. Mearson, Dr. Donnarumma, Dr. Ahmad, and Dr. Palumbo, and others. I just want to share this excitement and all the new things that are happening at the Stroke and Brain Aneurysm Center at GitSam and beyond across CHS. Our representative from the American Heart Association, who is going to give a short address, unfortunately had a family emergency, so we'll see if they're able to connect later. So our program is a faith-based system. Our system is a faith-based system. We have close to 2,000 hospital beds, a significant component of nursing home beds, almost 20,000 employees and over 4,000 medical staff and 3,000 volunteers, a very strong volunteer service. These are the hospitals that cover the span of Catholic health, 6 hospitals. The Stroke and Brain Aneurysm Center is located in the South Shore of Long Island, like we said before, and it covers a very broad area with referrals from Catholic health hospitals or other hospitals. Good Sam is a 537-bed hospital. We are looking forward to our modernization project in the next few years. And as I said, we're spanning our service area from Massapequa to the west, to Patchogue in the east, and to the Long Island Expressway in the north. This is pretty much the territory that we cover. The yellow is really the immediate area where the Stroke and Brain Aneurysm Center services. Obviously, we offer services to our spoke hospitals when patients are being transferred to us, but this yellow area is approximately 400,000 people, and 75% of our admissions come from that area. The mission of the Stroke and Brain Aneurysm Center is to deliver comprehensive state-of-the-art stroke care that integrates preventative and rehabilitative services to patients with cerebrovascular disease. And we're very faithful to this mission, and I think we'll be able to show you in this presentation and beyond how we realize that mission. Our goals and objectives reflect that mission. And again, our goal is to have good outcomes clinically, reduce complications through quality improvement, and I'm going to talk a little bit about that. We do believe in multidisciplinary teams, and you'll see that on our presentations today. Every component of stroke care is represented, not only physicians, but we have nurses, nurse practitioners, EMS people, and all specialties are represented in that spirit. We do a lot of research, and we do believe in integrating new and innovative interventions that can help patient care. And we do believe in stroke prevention, and we'll talk a little bit about that down the line. We do a lot of education. Part of that education is today. And we also have a very strong survivor program and a very strong support group. Todd Crawford will talk a little bit about our collaboration with the Lisa Foundation later today on our support initiatives. Our scope of services, and that will reflect it also in the presentations today, extend throughout ischemic stroke. And we'll talk about all these issues today. All treatments are available at our comprehensive stroke center for ischemic stroke, including IV TPA and mechanical thrombectomy, and all preventative treatments are also available. On the hemorrhagic side, on the bleeding type of stroke, again, all stroke categories are represented and all causes are being treated here with both open and endovascular treatment. No patient is really shipped out for treatment. As I said before, our system is a multidisciplinary system. At the center of that system is the patient and their family, and you have all these different departments. You'll have folks and representatives from all of these departments at Good Sam and beyond speaking to you later today about how we offer care, but also about what's new when it comes to stroke care, both on the ischemic side and the hemorrhagic side. An important component of what we do is transitions of care. Stroke is a continuum, and people that leave the hospital are at high risk to develop another stroke and come back to the hospital. We're trying to prevent that, not only locally at Good Sam, but across the system. And Dr. Mearson is leading a lot of those initiatives to minimize readmissions and make sure that when somebody leaves the hospital with a stroke, they're followed up appropriately by neurologist services, so that, and also rehabilitative services, and Dr. McCannon is going to talk a little bit about that, to make sure that we do not bring these patients back to the hospital. And the process starts in the neuro-ICU and our stroke unit with care coordinators that get involved early in the care. When the patients leave and go home, they get follow-up phone calls by our stroke coordinators at Good Sam, that's Karen and Taki. That's a very tedious task because it's hundreds, literally hundreds of patients with strokes. Even the most mild stroke, they get a phone call, and we make sure that they follow up, because obviously we don't want them to have a major stroke eventually. We want them to be on their medications. We want them to have all of their follow-ups. And then we do a lot of education in the rehabilitation facilities to make sure that these folks have what they need to offer the services for the stroke patients. As I said before, we function under hub and spoke model. In Suffolk County, Good Sam is the hub of those services. In Nassau County, St. Francis is the hub of those services. And we have patients traveling from St. Catherine's and St. Joe's to Good Sam, but also we often receive referrals and phone calls from other non-CHS facilities. We've had transfers at Good Sam frequently from Brookhaven, from Huntington Hospital, and even from Southside Hospital. So the pillars of the program, we're 4 pillars under which we function. Clinical care is a very important component, and today will be a lot about clinical care and a lot about innovations in clinical care. But I want to share with you a little bit about the quality improvement initiatives that are mainly led by our stroke coordinator at Good Sam, Karen and Taki. And so you'll see a series of meetings. If somebody's into meetings, that's the perfect opportunity. But I don't know a lot of people are. But we ad nauseum examine every stroke case from different avenues and make sure that all the standards are met, both collectively and individually. And we look into processes to make sure that if there is any breakdown in the processes, we're able to make sure that there's no patient harm and there's no repetition of that. And so we frequently, even if you're an EMS provider and you bring patients to our emergency room and you didn't have a good experience, rest assured that we always look at all these cases and this follow-up, and we strive for every time to get better. We wouldn't be able to be certified by the Joint Commission of the American Heart Association and the Department of Health if we didn't do that in a very aggressive way. So we have gap analysis meetings, performance improvement meetings, neurovascular conference, brain aneurysm board for indications. We have quality improvement meetings with our telespecialists, and I'll talk a little bit about Telestroke later. We look at our quality outcomes bi-monthly, and we participate in stroke coordinator meetings across the system. That's very important. Dr. Mearson is my co-host this morning. He participates in those meetings too. That allows for knowledge that gets generated in any hospital across the system to be transmitted across the system to all the hospitals. Say somebody has a stroke survey, St. Catherine's has a stroke survey, we all get together on the call, we communicate knowledge, and that's how standards are being maintained across the system. And we don't have any strugglers, so everybody's kind of participating in these initiatives. We do a lot of patient tracers across the units. Now, Telestroke was an initiative that started at GetSam. It's a Catholic health initiative, and it's spread across the system. And really, the purpose of Telestroke is to be able to bring the neurologist to the bedside within seconds of any stroke. And that's the holy grail of stroke care. You know, you want to cut down time to seconds so that you can save brain, so that you can allow allow patients to receive care. And as you can see, this is obviously a general idea of how we address problems. So we realized that we couldn't have the neurologist at the bedside very quickly, naturally, because in the middle of the night, they're home, you know, they have to call them in and all that stuff. So by creating this teleneurology program within seconds through a computer, the teleneurologists log in, they're able to see the patient, examine the patient remotely with the help of a nurse, and make determinations about IV TPA administration, and obviously able to deliver this treatment within seconds. That dramatically has decreased our intervention times when it comes to thrombolytics, but also mechanical thrombectomy, because it cuts down on a significant component of the care, which is the initial part of stroke care. And that dramatic reduction has been reflected in some spectacular times, with almost all TPA administered at GetSam below 45 minutes, and the majority of it actually being administered below 30 minutes. So it's really, really impressive stuff. And another important component for quality improvement that I really want to point out is the institution of nurse stroke champions across the units in the hospital. That was an initiative that Karen and Taki had, and I think a brilliant initiative where things change in stroke care all the time. We'll talk a lot today about new guidelines and new interventions and new thoughts when it comes to stroke. And the way we get that knowledge to the units is very difficult. You know, we're talking about a 600-bed hospital, multiple units, and stroke transpires units. Stroke is not an emergency room problem or a neuro ICU problem. It's a problem of the entire hospital. So you got to get the knowledge out. So voluntarily, nurses that have interest in stroke are becoming our nurse stroke champions, and they are able to then get that knowledge out to the units. A really phenomenal initiative, and kudos to Karen for leading the charge on that. We have a lot of ongoing research studies, and this is the third pillar of our program, which is research. We've created a population health research institute with the support of the previous chief medical officer of the health system, Dr. Shaughnessy, now our CEO. We've done a lot of studies when it comes to identifying issues in the population and bringing them to the individual. And I know that Dr. Goldman is also very passionate about population health, and so that has been a great synergy. Then we have a lot of clinical trials that involve patient-shared decision-making, like the Option Grid clinical trial, innovative imaging tools like Hyperfine MRI, a project that has to do with following small brain aneurysms that do not need treatment. And most recently, we're participating in a device clinical trial, which is called the Evolve clinical trial. It has to do with a flow diverting stent. As I said, on the population health side, we take large data sets and we try to extrapolate stuff to individuals. We have statisticians, and we have a statistician from Dartmouth that actually is part-time with us and participates in these studies. On the option grid study, really a nice randomized trial looking at the decision between aneurysm clipping or coiling. This is our point of care MRI. As you can see, really, really small, compact machine that is able to help us make determinations about intracranial pathology at the bedside without having to take the patient down for an MRI. Obviously still in its development phase, but now FDA approved, and so really, really good tool. This is the EVOLVE trial, and Elizabeth, who's going to be talking later, is one of the site coordinators for this FDA-approved national trial. We publish a lot when it comes to stroke, and we want to participate in the discussion nationally. You'll see some of our seminal papers initially about the value of angiography in non-traumatic subarachnoid hemorrhage. And we were the first paper to kind of define criteria where you would go straight to angiography without a CTA first. Another conversation about predictive modeling to see how the outcomes are going to be, and that ties into artificial intelligence down the line. More talking about utilization. We're big into utilization. We want to make sure utilization is appropriate. Another paper about utilization published in Radiology, the Journal of American Heart Association, talking about clipping and coiling and the different outcomes. Talking about inpatient versus outpatient treatment or inpatient versus outpatient presentation of ischemic stroke and outcomes. This was our first study nationally looking at the molecular and the genetic profile of brain aneurysms, or when we did surgery in brain aneurysms, we removed the dome and analyzed that in the lab and saw exactly what microRNAs and gene expressions happened at the brain aneurysm level. One of our most impactful papers had to do with primary stroke care, primary stroke centers across the country, and this was published in JAMA. Papers on magnet status and stroke care. As you know, Good Samaritan Hospital recently received again magnet recognition, which is a tremendous achievement. And there's a lot of benefits from magnet recognition down the line, especially when it comes to stroke care, as we've shown in these papers. Other papers where we've collaborated with American Heart Association, the Get With the Guidelines folks, and also talking a lot about carotid revascularization at the British Medical Journal. And lastly, most recently, with a lot of the folks on today, including Dr. Ahmad, Dr. Misios, our study on COVID and stroke and ischemic stroke, which I think was published in Stroke, and it was very impactful. This is, as I said, from our study on primary stroke centers for the first time in the country, mapping those and determining the ideal travel time. This was from the Dartmouth Atlas, which we created for subarachnoid hemorrhage and brain aneurysm treatment across the country. It was the first of its kind atlas that came out. And this is from our study on COVID-19 and stroke. And just a little plug on that, because there's been a lot of misinformation when it comes to the impact of COVID-19 on stroke. This was really the only study published in Stroke, which is the top journal in stroke care, and really it was the only peer-reviewed study at the time, and not sensationalism. What we demonstrated is that, as you can see here, as COVID cases went up in our system, and this is about 3,000 COVID cases, stroke, TIA, and MI cases either stayed stable or went down, really. So we didn't identify a correlation or a causation between stroke or COVID-19 and stroke. Now, if you've had both, if you, for example, you're a COVID patient and are having a stroke, your chances of death were 10 times higher, but there was no causative association. So really a really interesting study. Now, the last pillar of our program is education, and today is part of that education. Obviously, today we're learning together. We're participating in educating physicians, nurses, therapists, EMS providers, and everybody else on anything stroke and any new development. But really, we do a lot when it comes to the community itself. We're out there with the help of the PR team at Good Samaritan Hospital and Catholic Health. And obviously, I want to recognize Justin from the PR team at Good Sam, among others, and Georgine and a bunch of other folks in that department. They're spectacular and they're helping us a lot with these events, but we're also doing a lot of them independently. You'll see a lot of them are remote these days, but we've also started doing some in person. As you can see, there's 2 or 3 a month. So we're out there quite a lot. People are maybe sick and tired of us, but that's what really brings the patients to the hospitals at Good Sam, and this is one of those events. Another great educational initiative is called Hip Hop Stroke. It's a NIH National Institute of Health funded clinical trial, collaborating with Columbia University, and Karen has taken the lead on that. It is a program where using music, you're engaging school children to learn about stroke and transfer that knowledge home and then educate the parents. And so I think it's a tremendous initiative. And it actually was going great before COVID. During COVID, we had to trim it down a little bit because school was not in person anymore, but this certainly will continue going forward. Another great initiative that was mainly driven from Catholic Health, and Karen and Lisa Lasner, I think, was the initial folks that conceived this initiative, was to create a stroke awareness patch for the Girl Scouts of Suffolk County. Again, this was an initiative that kind of took a backseat during COVID, but again, one of our proud achievements, because by engaging children, really what we're trying to achieve is engage the parents, and so I think we've had a lot of success with that. Talking about that, we've done a lot of seminars online, and last year in particular, that we were not able to get out there. We organized webinars with the folks at Jefferson here. You see part of that. That was another one on COVID-19 and stroke. And in that particular webinar, we had folks from our system. We had folks from Stony Brook. We had folks from Mount Sinai. It was really a nice collaboration across the hospitals. And we spoke about this issue, especially when a lot of misinformation was going around. Obviously, this is part of educating the community today. And we do a lot about EMS. We're out there really trying to educate EMS providers. They are spectacular in what they do. It's not easy, obviously. It's a really complex environment of a lot of hospitals, and decisions are really tough. And so we're trying to do our share in educating these folks. And a lot of them are actually voluntary out here in Long Island. And that speaks volumes to the determination and the initiative of these individuals to provide the best care for our patients. This is from an event that was in person. Actually, this year, this event also happened in person. It happened in this hiatus where we were allowed to do big events in person. Now, again, our event today is over 200 people, almost 300 people. And so we were not really, folks thought that it would be more prudent to have this event remotely. So we're out there again, we're trying to spread the word. You'll see us on the radio, on several outlets, trying to spread the word. And this, also with the Spanish community north of us, we're trying to engage and educate, because as we said before, stroke is a continuum. You have to get the word out there. The first component of stroke care is the patient identifies the signs and symptoms of stroke. Without that, everything we do on the back end has no impact. And, I often say, I'm a glorified plumber. So is Bruce, we open blood vessels. That's what we do. But we cannot do that unless the patient comes to us at the right time. And so that's the most important thing. As I said, we believe in supporting survivors. We've supported the National Stroke Association, then American Heart Association, Comeback Trail, or the Heart Walk these days, since 2017. And we have a very active support group that's led by our lead technologist at Good Sam, Jason Wallen. It's really one of a kind support group. We work closely with the Lisa Foundation on that, and Todd will talk a little bit about his experiences on that matter. And we want to obviously focus on education. We want to engage families, not only for our patients, but for patients of other providers that end up walking through our doors. And we're the only support group on Long Island to be affiliated with the Lisa Foundation. And this is with the permission of the patients. And this is a random Tuesday where folks are there and they're all very engaging. We're partnering with a lot of national organizations. We've been honored to give the address at the Lisa Foundation in 2019, just before COVID. We were the last ones in their last in-person event, which is a really, really spectacular event with a lot of TV personality power to spread the word on brain aneurysms, and a lot of star power. And then our other partnership is the Page Elizabeth Keeley Foundation. That's an initiative out of Good Sam, out of Suffolk County, out of up where Bruce is, kind of in the Smithtown area, where Gina Keeley has taken a tremendous personal tragedy involving the death of a child from an AVM and has turned it into a powerhouse, trying to spread the word and move forward with screenings and try to get ahead of this horrible disease. The work of this tremendous team has been recognized by the American Heart Association, by the Long Island Elite, by the National Stroke Association, and obviously by the Joint Commission of the Department of Health recognizes us as a comprehensive stroke center, and recognizing pretty much every hospital in Catholic Health as either a primary stroke center or an advanced primary stroke center. A really phenomenal, spectacular performance by all our hospitals. We're on social media, so feel free to reach out to us. We're trying to get the word out every day. And we're very proud, as I said, about our program. And when we started, obviously down here, there's not a lot of things happening in terms of advanced stroke care. Our sister hospitals really did a phenomenal job back then, seeing a patient, providing primary stroke center services, administering TPA at percentages that were the highest almost in the country. You know, nationally, you see less than 10% of folks presenting in the emergency room getting TPA, and you'd see some tremendous percentages at St. Catherine, St. Joe's. But the missing component was the advanced services. And when we came, a lot of the advanced imaging happened here for the first time, first mechanical thrombectomy, aneurysm coiling, AVM embolization. Very important, our first neuro ICU. We were the first neuro ICU in the South Shore, but also in Suffolk County. And that speaks volumes of the foresight of the leaders when they started the program, that they needed this type of care for these patients. And I think Bruce was instrumental in that, and Laura and Dr. Ahmad. And then a lot of new devices have been implanted at Good Sam. The first Atlas, and now one of the most commonly used stents in the country for brain aneurysm treatment, was implanted for the first time here in New York. We're proctoring new devices across the country, teaching other physicians how to implant them. And as I said, the first and only comprehensive stroke center comprehensive support group, but also comprehensive supports stroke center in the South Shore of Long Island, certified both by the Joint Commission and the Department of Health. And, you know, everything is exciting and great, but, you know, what are we looking forward to in the future? And I would say the thing that we're looking forward to the most is the modernization project of the hospital. As you see, Good Sam is really becoming a hub for advanced care across the system. And you see the new, this is a rendering of the new building that's going to be in the front of Good Sam, with all new operating rooms and all new emergency room, most importantly. And actually, even better, in the emergency room, after a lot of negotiating, we will have a third scanner that's going to be dedicated to stroke, with TPA available in the scanner. And so the teleneurologist will be able to see the patient in the scanner, administer TPA before the patient gets off the table, and then proceeding with advanced studies, CTA, CT perfusion, and then after that, achieving very low times. And from there, going straight through the elevators in the second floor of the new building to receive thrombectomy care in our second neurointerventional room there. So really, really exciting stuff for all of us at Good Sam and CHS. And this is what this room will look like. Really amazing stuff. And this is what we look like today. Again, thank you. I wanted to just give this broad overview of the program. Welcome again, everybody. This is going to be a phenomenal day of speakers. Again, thanks. And Bruce, I assume you don't have any questions on that, but I will, with that, I will see if I can get our Director of Neurology and Stroke at Good Sam, Dr. Donna Rummel.
Kimon?
Yes, Bruce, yes.
If I just might intervene for 1 second, I
Please.
think that Dr. Beckles is obviously very humble in his presentation. I don't think that anybody within our organization really can appreciate the true magnitude of what Kimon has done in such a short period of time. Within a few years, he turned us from a primary stroke center into a comprehensive hub and spoke model. And, Kimon, I just, on behalf of the organization and everybody who works with you, I want you to understand how much we appreciate what you have done and how impressive it is. And really, at the end of the day, how it's impacted patient care. And I think you can see some of that through some of the, the local social networking initiatives that Kimon presented. So I just, without saying too much, I know we're on a short time. Kimon, I think you deserve your due, and I just wanted everyone to appreciate that and understand it. And I am done speaking for now.
In progress.
Thank you, Bruce. Thank you very much. Let's see if we, perfect. Let's see if we have Laura. There she is. Excellent. All right, let's give her another second to connect. Laura, are you there?
Yep, I'm here.
All righty, let me stop sharing my screen if you want to share yours. These meetings are always awkward when it comes to transitions between speakers. And as I said, Laura is our Chief of Neurology at Good Sam and Director of Stroke. She is a powerhouse when it comes to stroke. She came to us to start the program actually from Stony Brook, and we couldn't be happier to have her. All right.
Thank you.
There we go. Perfect. Laura, we see your downloads area.
Okay. Can you see the presentation?
Not yet. Maybe stop sharing and try to reshare if you have it open somewhere else. Otherwise, I can always try on my end. And if you have trouble, I can always try to share my screen with it. I don't have it all open, but I think we'll do the trick.
Can you see the PowerPoint at all?
No, try to share your screen again. I think you stopped sharing. Good. All righty. Let me see. Do you want me to share my screen?
Sure. Let me see if this works. 1 second.
Okay. All right, perfect. Yep, that's excellent. And actually leave it like that, Laura.
Yeah. Okay.
Don't go into presenter mode because I think it's going to be a problem. All right, perfect. Take it home, Laura.
Okay. So hi, I'm Laura Donnarummo. I'm the Director of Stroke and Chief of Neurology at Good Samaritan Hospital. I'd like to thank Dr. Bruce Mearson for his collaboration. He's the Director of Stroke and Chief of Neurology at St. Catherine's of Siena Medical Center, and he's the Chairman of Neurology of the CHS Neuroservices line. I'm just going to talk a little bit today about medical management of acute ischemic stroke. 1 second. Sorry, we have to go slide by slide. So I'll talk a little bit about stroke burden. So stroke is the 5th leading cause of death in the US and the most common cause of serious long-term disability. It's the 2nd leading cause of death globally. There's about 795,000 people in the US who have a stroke per year. 610,000 of them are first or new strokes. And about 185,000 of them, about a quarter, are recurrent strokes. And the risk is approximately 20% in 5 years. So stroke burden is actually significantly high. And people who have stroke, they get a significant degree of morbidity along with mortality. There's usually a complete change of quality of life, loss of independence, loss of ability to work and meet their financial obligations. There's also the cost of long-term care. So what is our goal of acute stroke? Our goal of acute stroke care is to limit the permanent symptoms and disability and lessen that burden. And how's the best way to do that? So essentially, it's early detection of symptoms and administration of IV thrombolytics and/or mechanical thrombectomy. The time of onset to treatment of symptoms is the essence, because the cerebral perfusion therapies that we have are all time dependent, and every minute the brain is deprived of blood flow, it leads to increased likelihood of permanent damage and long-term disability. So just quick general medical management of acute stroke. If someone enters the emergency room, what are the most important things? Obviously, it's quick identification of symptoms. Stroke should be suspected whenever a patient presents with acute onset of a common neurologic symptom, including unilateral hemiparesis, hemisensory loss, slurred speech, language deficits, ataxia, visual field deficits and loss, etc. Calling of a stroke alert or its equivalent overhead. That'll help us get staff to the bed quickly, especially ER physician, nurse, stroke neurologist, either in person or via telemedicine, and get the person to stat imaging, CTA head and neck, so we can make a decision about TPA. So some of the immediate relevant medical history and general physical exam on arrival. One of the most important parts of the history, you want to get the onset of symptoms. The reason for that is less than 4.5 hours, the patient might have to be a candidate for IV TPA. If the symptoms are less than 24 hours, they might be a candidate for thrombectomy. Also less than 4.5 hours, they might be a candidate for both. The other important bit of history to get is the patient on anticoagulation. Sometimes this can exclude a patient from TPA. The next thing is we'll get a quick physical exam, and a stroke scale is the standard. And vitals, especially blood pressure, because the administration of TPA or not the administration of TPA, there's different blood pressure parameters. So the immediate imaging that we want to get on arrival after we get our history and physical is a CT brain without contrast to rule out hemorrhage. Obviously, if there's a hemorrhagic infarct, they're not a candidate for TPA. If there is a completed infarct, the age and volume are important. And it can also help us evaluate for other structural contraindications. Sometimes you can see some vasogenic edema, METs, other contraindications to thrombolytics. Next, we get a CT angio of the brain and neck vessels, and we'll evaluate for a large vessel occlusion and see if there's a possible candidate for thrombectomy. And also of utmost importance to determine about thrombectomy, we need our CT perfusion. So what the CT perfusion does is it allows us to see penumbra and if thrombectomy would be valuable. So the penumbra is the amount of brain tissue that's already compromised and the amount of brain tissue that would be at risk if the clot remained and we didn't restore blood flow. Based on that, we can make decisions whether they'd be a good candidate for mechanical thrombectomy. Additionally, uses MRI brain with diffusion, ADC weighted sequences. That'll give you a stroke volume. However, it's not usually done emergently because it takes too long. It takes much longer than CT. And again, time cost brain. So once all the above's taken place, the history of the physical, the imaging, then we're ready to make a decision on intervention. And some of the options for intervention include IV TPA or some others coming down the pike, like tenecteplase, and or mechanical thrombectomy. So just a little about IV TPA. It's the only proven medical therapy to decrease deficits and long-term disability. The benefit of therapy is time dependent because the time to treatment has such a powerful impact on outcome. IV TPA should not be delayed. So it should not be delayed for extra imaging. It should not be delayed for blood work. It should be given ASAP once we know that the patient doesn't have, they fit the criteria. Be prepared for complications. One of the bigger complications is an intracranial hemorrhage. There's a 6.4% risk, and that must be conveyed to the patient and the family. Doesn't need consent, but for full disclosure, they should be aware. And there's also the risk of angioedema. And the decision to treat is based on the history, the non-contrast head CT for TPA, and then the additional information from the CTA and the perfusion for thrombectomy. So some inclusion criteria for TPA: acute ischemic stroke with a measurable neurologic deficit, onset within 3 to 4.5 hours. There were some added exclusion criteria at the 4.5 hours, but that's really all become kind of relative criteria now. We'll talk about that in a second. Age over 18, and a non-contrast head CT without hemorrhage or a large completed infarct. So some of the exclusion criteria is head trauma or acute ischemic stroke within the last 3 months, symptoms suggesting subarachnoid hemorrhage and bleeding, arterial puncture at a non-compressive vessel site within the past week, prior history of intracranial or intraaxial intracranial neoplasm, blood pressure greater than 185 or 110. That's extremely important to administer TPA. The blood pressure must be less than 185 over 110. We'll talk about that again in a little bit. Also, any recent intracranial or spinal surgery and any active bleeding diathesis, including platelet count less than 100,000, IV heparin use within the past 48 hours and an elevated PTT, anticoagulation and INR greater than 1.7 or PT greater than 15 seconds. This is important because essentially you can have patients on Coumadin, and it's not a contraindication as long as their INR is not greater than 1.7. That's a little different than the NOAC. The NOAC use is an absolute contraindication if it's taken within the past 48 hours. So blood glucose less than 50 is an exclusion. CT of the brain already showing a large completed infarct, and there's high risk of hemorrhagic conversion. And then for the 3 to 4.5 window, there were some relative contraindications: age over 80, and a stroke scale over 25, being maintained on oral anticoagulation regardless of INR, history of a diabetic with a previous stroke. They were only excluded because they weren't included in the study. But at this point in time, they've all kind of become relative, and a lot of those patients are treated. Other relative exclusion criteria: seizure at the onset with possible postictal deficits. In that case, if you have someone who had a seizure disorder and had a breakthrough seizure and has a little bit of Todd's paralysis, you're prudently not going to TPA that person. However, if they don't have a history of seizure and they had a seizure and they have focal neurologic deficits, it would probably be best to treat that type of patient. Major surgery or trauma within the past 14 days, GIG bleeding in the past 21 days, and recent acute MI within the past 3 months. So minor deficits and rapidly improving symptoms. This is usually a big question. And a lot of times you'll see TPA not given because patient's symptoms improved rapidly or rapidly improving. Doesn't always necessarily say they go back to zero, or they had mild symptoms. And these cases are a little difficult. You really have to look at the risk versus the benefits. So do patients with minor deficits benefit from IV TPA? The PRISM trial data in JAMA in 2018 concluded that in patients with minor neurologic deficits, and NIH stroke scale less than 5. Administration of IV TPA was no better than aspirin in increasing the likelihood of a favorable functional outcome at 90 days. However, the study was very limited. It was stopped early, so it's limited generalizability. And really comes down to it's physician dependent. You have to keep in mind, though, that even mild symptoms like numbness of the right hand in a right-handed person can lend to significant morbidity if they can't continue their ADLs. So you really have to look at what the risk of having that becoming permanent versus maybe the chance of having it resolved. IV TPA administration and mechanical thrombectomy. Whether or not the patient has a large vessel occlusion and is a candidate for mechanical thrombectomy, IV TPA should always be administered first if the patient meets the inclusion criteria and that they're a candidate. After TPA administration, patients can easily be brought to CTA to evaluate for a large vessel occlusion. And then if there's penumbra and they're a candidate, then they can go to the angio suite. Patients outside the 4.5-hour window with a documented large vessel occlusion on CTA and a salvageable penumbra should always immediately be brought to the angio suite for mechanical thrombectomy. In carefully selected patients with acute ischemic stroke outside the window for IV TPA, and they have an anterior circulation large vessel occlusion, based on the Dawn and Diffuse 3 trial eligibility criteria, mechanical thrombectomy is recommended. And in selected patients presenting within 16 to 24 hours, when we Dawn criteria, mechanical thrombectomy is reasonable. So a little bit about the administration of TPA. Once they've met the inclusion and the exclusion criteria, the dosing is 0.9 milligrams per kilogram given as a bolus.
Hey, Laura.
Yeah.
Do you want to answer a question that just came on, or you want to do it at the end?
Sure.
Aaron Markey from St. Francis is asking, hey, Aaron, by the way, thank you for participating. What is the concern with MI and TPA within 3 months?
It was just listed as a relative contraindication, and relative kind of means that in the past we maybe were a little bit concerned. The MI patients were usually sometimes had stents, were on dual antiplatelets, but now it's not an absolute contraindication. It's kind of dependent upon the physician making the decision, speaking with the cardiologist in terms of the MI. And then what was the other thing?
That was it, MI and TPA within 3 months. That's perfect. Thank you.
So the IV TPA administration, the dosing is 0.9 milligrams per kilogram to a max of 90 milligrams. It's all given 10% as an IV bolus over 2 minutes, and then the remainder is infused over an hour. Then over the next 24 hours, the most important thing is blood pressure management. You do not want them to spike in blood pressure because you don't have increased risk of hemorrhagic conversion. The blood pressure goal after TPA, you want the systolic blood pressure less than 180 and the diastolic less than 105. The pressure is checked every 15 minutes from the start of the infusion, then every 30 minutes for 6 hours, and then every hour for 16 hours. And these patients aren't given any antiplatelets or anticoagulation for 24 hours after the administration, after which time we repeat a non-contrast head CT. If there's no bleeding on that, then they can start their antiplatelets or anticoagulation, depending on the stroke volume. Just general medical management. Obviously, these people will be on normal saline. Please try to avoid hypotonic fluids such as half NS or D5W because the free water can exacerbate cerebral edema. Again, just to go back to blood pressure management, for patients to be candidates for IV TPA, the blood pressure has to be less than 185 over 110. And that's right before, prior to giving the TPA. After the TPA is administered, the blood pressure must be maintained at less than 180 over 105, basically for the next 24 hours. So you want strict blood pressure control just prior to, during, and after TPA administration, so you can avoid the risk of hemorrhagic conversion. But you don't want strict blood pressure control if you're not intervening and they're not a candidate for TPA or they're not going for thrombectomy. And the reason for this is something called permissive hypertension. So the body's normal response to blockage in a clot, brain ischemia, is to increase the blood pressure so that can increase the cerebral perfusion, get blood flow around the clot, trying to encourage collaterals and maintain blood flow to the area that's essentially starving. Lowering blood pressure acutely can lead to increased ischemic brain injury and neurologic deterioration and long-term deficits. American Heart Association actually recommends that you should not treat a systolic blood pressure less than 220 prior to the CT brain imaging. And blood pressure management, so do not treat acute hypertension unless you really have to. Some of those reasons are concomitant acute coronary ischemia, cardiogenic pulmonary edema, aortic dissection, acute hypertension with end organ damage, including encephalopathy or nephropathy. Obviously, if it goes above the guideline, the American Stroke Association guideline is 220 over 120 max. So if it's above that, you're going to treat it. And obviously, if there's an intracranial hemorrhage, you want to get it way down, less than 150 at that point, the best you can. So acute management of malignant hypertension. So say you're someone up, they just got their TPA and they're staying in the 190s, 200s, or even the other stroke patients are above 220. The best way to treat them was with IV drip medication, nicardipine IV, labetalol IV, clozapine IV. Drips allow for better control aside from pushes. Sometimes the push you get too rapid drop in blood pressure, and then you have to wait, for it to come up. You don't have as strict control as being on a drip. You should also avoid medications like hydralazine, which can elevate the intracranial pressure. So what happens if your stroke patients have rapid AFib, which most of them are, because that's a major cause of acute stroke. Cardizem and verapamil are usually the best because they'll lower the heart rate with a smaller effect on blood pressure. Blood glucose, hypoglycemia with a blood glucose less than 60, that should be treated. Hyperglycemia likewise should be aggressively managed. The target range should be 140 to 160. With close monitoring to avoid hypoglycemia. Hyperglycemia itself has actually been shown in studies to increase apoptosis and lend to a greater stroke volume, meaning that the apoptosis that they're seeing is in the penumbra and those the cells that are kind of struggling to hang on. And so really high blood sugars at the time of acute stroke have led to greater infarct volume. Temperature, essentially, if they have an elevated temperature, you will give them some Tylenol. People ask about the benefits of induced hypothermia. It's really uncertain at this time. We don't do that. Lab work. Don't delay any imaging or treatment while waiting for lab results. The only time the lab work really becomes into play is if somebody has a coagulopathy and they're on anticoagulation. Otherwise, if there's no coagulopathy, there's no anticoagulation on board, you don't need to wait for the PTT or the platelet count. And for the glucose, a finger stick is sufficient. So complications of IV TPA, obviously the most common is intracranial hemorrhage. So if you have your infusion going and if your patient has a change of mental status, severe headache, obviously send him for a stat non-contrast head CT. And if we see intracranial hemorrhage, we stop the infusion of TPA. We check the CBC, the coags, fibrinogen levels, and cross-match. The antidote is cryoprecipitate and tranexamic acid. We also get neurosurgical consult if there's a large bleed, and also a heme consult. The other complication of TPA that we see is angioedema, and that's usually associated with patients that are on ACE inhibitors. If they do get this allergic reaction, then it's important, obviously, for airway protection, use solumedrol, diphenhydramine, ranitidine, and if needed, epinephrine. So what about tenecteplase? So tenecteplase is our new and upcoming fibrinolytic. which is going to give TPA, I think, a run for its money. But so it's a fibrinolytic with higher fibrin specificity and longer half-life than the standard TPA. So it's more specific to fibrin and the half-life is longer. The advantages include lower cost, greater fibrin specificity that causes lower risk of bleeding, a longer half-life, no need for continuous drip after a bolus. It's a one shot and done medication. It's associated with lower rates of non-cerebral hemorrhage and alteplase. And based on meta-analysis of trials comparing tenecteplase to alteplase, there's no significant difference with regard to the neurologic recovery and mortality of either tenecteplase or alteplase. So the endpoint of where patients' recovery is about the same between the two. And tenecteplase and thrombectomy, there was a study in the New England Journal of Medicine in 2018 that concluded that when tenecteplase was administered before mechanical thrombectomy, there was a higher incidence of cerebral reperfusion and better neurologic outcome than alteplase, especially with acute stroke symptoms treated within 4.5 hours of symptom onset. The American Heart Association has recommended, based on the most recent trials, that tenecteplase may be reasonable to choose over alteplase in patients who are eligible for mechanical thrombectomy with early onset presentation. So what happens to our patients who are not TPA or thrombectomy candidates? Usually they get aspirin 81 to 325 milligrams within 48 hours of the onset, usually results in a slightly decreased mortality and or recurrent ischemic stroke rate in the first year. IV anticoagulation with heparin is generally not administered in these patients. It doesn't significantly reduce clot burden, and there's a high risk of hemorrhagic conversion into the acute stroke. Potential exception to the rule are patients with strokes in evolution, those with high-grade large vessel atherosclerosis, those with arterial dissection, crescendo TIAs, and suspected dural VST. So essentially what this means is you have a high-grade stenosis, but you might have getting low blood flow to the brain, but not have actually had them infarct yet or have a large stroke volume. So if you have a high-grade stenosis and you have low or no stroke volume, then the benefit of keeping that artery patent with heparin and maintaining cerebral perfusion to the brain and the tissue at risk outweighs the risk of conversion.
Laura, I have a question coming in from Kathy Videtto out of St. Catharines. Hey, Kathy. She's saying, excellent presentation. Can you address why hydralazine specifically may increase intracranial pressure in the setting of ischemic stroke?
Yeah, it's a intracranial vasodilator, so it increases the intracranial pressure. And you have the increased pressure, and then you have the drop in pressure peripherally, and so you'll get worsening blood flow to the actual stroke.
Great, thank you.
So once these patients are admitted, then what happens? So their BP management is kind of based on whether or not they receive TPA or not. So we adjust our goals that way. If they didn't receive any TPA or intervention, then they're allowed permissive hypertension for 24 hours, and then we try to go to our goal of less than 140. With TPA, we keep the blood pressure less than 180 for the first 24 hours, and then we try to lower it down to less than 140. They get an echo with bubble, rule out thrombus and PFO. We try to manage their risk factors. So we check the lipid panel. We want a goal LDL of less than 70. High dose statin use if it's above 70. We check the hemoglobin A1C, see where they're at their diabetes and if they need stricter glucose control. We encourage smoking cessation. And obviously we get them the services that they need at that point: physical therapy, occupational therapy, speech and swallow therapy. So what are some of the complications that the acute stroke patients have in the hospital itself? Number one is obviously cerebral edema. And with swelling, you can get compression on other brain structures. You can get herniation, death. Generally, it takes about 48 to 72 hours to reach its peak. Use of osmotic therapy with 3% or 23.4% hypertonic. Saline is reasonable. Mannitol is reasonable. Hypothermia or barbiturates are not recommended. Corticosteroids, likewise, are not used for brain edema associated with acute ischemic stroke and cytotoxic edema. So other complications, so if you have this malignant edema, the large MCA infarct, and you're younger, you have not a lot of atrophy, and you're starting to get some compression, then clinically within the 48 hours, a decompressive hemicraniectomy is definitely reasonable. Seizures after stroke, if patients start to seize or go into status after their stroke, we obviously treat them and treat them aggressively. However, it is not recommended that we prophylactically use AED. Anticoagulation, urgent anticoagulation in patients with severe extracarotid or intracranial stenosis is not well established. The usefulness of NOACs in the setting of acute setting is not established. Again, you always worry about conversion, and there's very high risk of hemorrhagic conversion. The label of most of these NOACs say do not start for 2 weeks post-stroke. Urgent anticoagulation with IV or subcu heparin to prevent recurrent stroke acutely or to prevent worsening of acute deficits is not recommended, except for in the situation we talked about with the artery. And that's it. Thank you.
Great. Thank you, Laura. Really comprehensive presentation. I had a couple of questions on tenecteplase. You presented the data very well. What is your personal take? I know we have discussions, and Bruce and I are participating in those about maybe making it available, obviously, system-wide, but would you use it yourself as a neurologist? Would that be your first choice based on the evidence that you've seen?
Yeah, I mean, if it's something, if we have another, tool in the arsenal, everyone's always going to use it. And usually what happens with these new medications is that it comes out, people start to use it slowly, and you kind of see which one is better. From all the data, it seems like tenecteplase is going to be easier to use, maybe a little bit better if it's basically a one-shot deal without worrying about the continuous drip and maybe you're still going to worry about vitals and stuff like that. And it seems to have, work very well with mechanical thrombectomy.
Yeah, and one of the issues that I foresee is that if we have both at the same time, it can be a bit of a problem with, one is a bolus, the other one is not, so then you might have a situation, very high risk for a medical error. So we'll probably kind of have to make a decision. Maybe Bruce, do you want to comment on tenecteplase too?
Yeah, there's been a lot of discussion about tenecteplase over probably the past year now, I would say. And it turns out that tenecteplase is probably going to be the way of the future. I think the biggest hurdle we have right now, or one of the biggest, is obviously it's a complete change of culture from what we do, and everybody's used to using TPA and a lot goes into it. But it's not FDA approved for acute ischemic stroke. It's indicated for acute coronary interventions. But we are actively pursuing getting tenecteplase to be used throughout the system by working with pharmacy and central and trying to sort of change the culture, because tenecteplase, for all the reasons that Laura mentioned, I think is going to be a better drug and in the way of the future. And I think that just in terms of meeting certain guidelines that we need to make when we're treating acute ischemic stroke, when you don't have to worry about hanging an hour-long bolus after you push your loading dose of TPA, I think that we will do better on all those metrics. And finally, Kimon, you and I have discussed that patients who get tenecteplase may do better if they're going for mechanical thrombectomy than those with IV TPA, based on
That's correct. Yeah.
studies, but you know, some limited data, but still, I think it's just going to be much easier, and I think we're going to have to change the culture. But we are actively working on that. I speak with the stroke coordinators at all the hospitals once a month. It keeps coming up. It takes time, but I think a lot of the large academic medical centers are switching, and I think we should too.
Yeah, no, Bruce, I agree, especially on the benefit side for mechanical thrombectomy. You know, and if you think about it, how many times do I get a patient in transfer, TPA still on, and they're on the table, and I have to stop the drip to, start the procedure. So, this, or if they're coming from the emergency room, they start the TPA, and now we've become so efficient that CTA, CTP is done, the team is there, the patient is back, and they've only gotten the bolus of the TPA. And so they haven't gotten the full benefit. Then we start the thrombectomy. Obviously, you have to stop the drip, and you go ahead and you probably are not getting the full benefit of the drug, whereas the tenected place, you administer it, that's it. It can happen in any setting, and then you can do the thrombectomy immediately. You don't have to deal with drip concerns at all. So I think it's a great option. It's been out for a little bit now. It sounds like people are switching.
We're going to continue to work on this aggressively throughout the end of the year. But I'm hoping, next month it's going to their monthly pharmacy meeting at Central. They're going to present the data, and hopefully we'll be able to have an answer. It would be great if we could get it done by the end of the year, but if not, I think by early 2022, the latest. So
yeah, for sure.
That's our goal.
That's excellent. Laura, one more question on wake-up strokes. How do you feel about, the wake-up trials, and also the change of the guidelines maybe a year or two ago that, they would recommend using MRI, diffusion, flare, whatever have you, to determine whether there is salvageable brain and give TPA for patients that are not candidates for large vessel occlusion, or they're not candidates for mechanical thrombectomy because they have small vessel occlusions. Kind of a way to address wake-up strokes with TPA now.
Yeah, and we've talked about that with our team, and we were talking about with MRI and stuff, it takes a little while to go, but getting a CTA head and neck perfusion and looking just at the perfusion to look at the penumbra, look at if it's completed or not, and then making the decision to TPA from there. I think it's definitely beneficial. A lot of the wake-up strokes, they kind of got cheated out of hours because you can't really tell when their last normal was.
Right.
We can tell that a lot better if we have the picture in front of us.
Right, no question. And Bruce, are you considering that also in terms of getting MRI involved early on? I think it's a logistical challenge, especially when there's no 24/7 physical presence of the techs. I mean, they're on call, but
it is hard, and we're going to have to figure out a way to do this, because increasingly, as you can see, stroke is really a disease that the most important factor in treating it, frankly, is time. And I think that we now have the imaging capabilities available to us that we can see where there is still viable brain tissue. We can see where there's penumbra. We can see what's dead. And I think that we can make decisions, especially with regard to mechanical thrombectomy, but even also with intravenous TPA, we can make decisions based on what we're seeing on our imaging, and maybe safely. The main risk once the stroke is done for going in and doing a mechanical thrombectomy, if it's a big stroke, is that you're not going to get the benefit because brain tissue is dead, but you also have the potential for massive hemorrhage when you reperfuse that dead brain. And I think that with the available imaging that we have at this point, I think that in terms of looking at match and mismatch on perfusion CT or diffusion MR versus the flare signal change in MR, we can make a decision as to whether or not it's safe to go back in there and do something outside of our typical window. Wake-up strokes is sort of the prototype of that, because we just don't know when they happen. Did they happen at 11:30 when you fell asleep at 11:25, or did they happen at 6:30, when you woke up? So I think that using the imaging is going to be the most important tool we have to make those decisions, I think, going forward.
I completely agree with you. And, you mentioned time. Time is obviously different for every patient. And I think imaging, obviously, we were going by the absolute time that we know traditionally in stroke care, but time is individualized, and that's why we're able to push, for example, for thrombectomy all the way to 24 hours if the brain is alive. So it's and that tags nicely into what Elizabeth's going to talk about in a second. But time is obviously relative. We need to know the physiologic time of every patient, and I think AJ Berdia from St. Charles is very passionate about real time and physiologic time. We're talking a lot about that in the past. So that's very, very important. Laura, another question, or Bruce, about tenecteplase. I see here, will tenecteplase have the same similar post-infusion monitoring as alteplase in terms of time frame, and I assume also vitals and all the other very intense stuff that are required by the Joint Commission?
I would assume that they definitely would.
Right.
Right.
I don't think they're changing the guidelines
Yeah.
or the monitoring.
No, they're not changing. They won't be changing the guidelines. And I think that when I should say we go to tenecteplase, if we can, I think we're going to need to specifically do things to streamline the issue of post-infusion or post-injection complications, but I don't think they're going to be so dissimilar to what we see already with IV TPA in general.
Thank you. Susan, I saw you sent a question, but I'm not sure it's complete. It says, there you go. Since tenecteplase has longer half-life than alteplase, are there any increased possibilities of hemorrhage with tenecteplase?
Looks like the overall bleeding risk is actually lower.
Okay. All right, that's probably reflective of the specificity of the drug.
Yeah.
For fibrin. All righty, great. We are right on time. Unless you guys have any more questions, we will move to our next speaker. Thank you, Laura, for a great presentation as always.
Thank you guys for having me.
Our pleasure. All right.
Thank you.
And our next speaker before the break, I'm sure everybody's looking forward to a break this morning, but our next speaker before the break is Elizabeth Hogan. Thank you for disconnecting, Laura, that screen. That's perfect. Elizabeth, you want to share your screen? So Elizabeth is our nurse practitioner in the neurointerventional room. We work together very closely and we do a lot of these procedures together. So, Laura spoke a little bit about the acute treatment of ischemic stroke, the medical management of ischemic stroke. And Elizabeth is going to talk a bit about the surgical side, the interventional side. So one was the medical side. Now we're going to talk a little bit about the new developments on the endovascular side when it comes to treatment of stroke, and a lot of the exciting stuff that are happening nationally and also at Good Sam. Elizabeth, thank you.
Hey, everybody.
Sorry about that. You mute yourself? Okay, good. All right, go ahead.
Yeah. No.
Yeah, go ahead.
Okay. Is that gonna work?
Go ahead, yeah.
Okay, so just hopefully everyone can hear me. It's good to be back. So we'll talk again. And we've added some new and exciting stuff here. Like Dr. Beckless just said about new developments in endovascular treatment of ischemic stroke. Amanda Rochelle, PA, is my counterpart here in the neurovascular program at Good Sam. She happens to be out on leave, her brand new little baby. So I'll give the talk this year. Let's get into it here. We do have some new and exciting stuff to share with everyone. So we'll go over the Dawn and Diffuse 3 trials, how they've changed the trajectory of stroke care, and a newer ADAPT trial, which really shows the evolution of thrombectomy over time, the last several years, and new and exciting things at Good Sam that we hope to spread out to the rest of the system once everything gets settled. The role of artificial intelligence in stroke care, which we are one of the first in the area to be using. And then I have some case reports to share with you as well. So starting simple with mechanical thrombectomy for stroke, just some pictures here of kind of simplifying what Dr. Beckless does when we are in the angio suite. You can see a stent retriever there with the clot inside the stent. And then on the other side, you have a catheter aspiration thrombectomy or mechanical thrombectomy. So two different ways here of removing blood clot, one just using suction and one where you actually go in and with that stent you mechanically retrieve that blood clot. A lot of what we're going to talk about today kind of comes from the last one as well. When we're talking about medical treatment for stroke, we're still talking about how much time do we have to intervene for people with regard to mechanical thrombectomy. So we'll talk a lot about that with the studies here. Some of the studies that are pretty popular and pretty well known that you may have heard of here and there. Initially, we're talking about only 0 to 3 and 0 to maybe 4.5 hours if you meet certain parameters for intervention with TPA. So getting that medication, they really need to be, presenting, like Dr. Beckless said, within not that long from the onset of their symptoms. So if you have these patients that are waking up, say, with symptoms, like we just talked a lot about wake up strokes, and you really don't have an exact onset, these people are lost in terms of being able to get medication. So the newer studies have been really great in extending that time where we still can intervene. So we have 5 randomized controlled trials that were all utilizing the stent retriever. So that, basket looking thing that you see there where we go and mechanically remove the clot. Initially, we extended that out to 6 hours. So we gained a couple of hours there since last known well time. When we talk about the Dawn and Diffuse 3 trial, we're extending that much further now, talking about 16 to 24 hours out from last known well time. So we've really extended the amount of patients that we can reach for treatment for acute stroke here, which is great. And then again, we'll talk about the ADAPT trial also after that. So the Dawn trial, 6 to 24 hours. So we're talking 24 hours from last known well, and we're utilizing those imaging studies like we were talking about. So clinical deficit and what it looks like on imaging, how recent was the stroke and how much brain is able to be salvaged. And then the Diffuse 3 trial, we're going out 16 hours and also with use of that perfusion imaging that shows us how much brain is able to be salvaged and how much is already stroked out there. So in the Dawn trial, proximal internal carotid artery or middle cerebral artery stroke, the patient needs to present within 6 to 24 hours of last known well time in order to be included in that trial. And for this one, the clinical deficit actually appears greater than the infarct volume. So there was a NIH score that had to be greater than 10 in order for the patient to be involved in this study. So that's a pretty significant clinical deficit on arrival. The patient had to be 18 years or older, a modified Rankin score of 0 or 1 pre-hospital. So this is somebody who is normal, walkie-talkie, no assistance at all. No evidence of intracranial hemorrhage, and the infarct size. So again, The clinical deficit appears large, but the size of the infarct must be less than 1/3 of the MCA territory. So it can't be on imaging a very large looking stroke. The deficit appears more than the stroke. The thrombectomy in this trial was performed using only the Trevo device. So that's a stent, a retrievable stent that's placed, and then, you know, hopefully the clot comes out with the stent and you remove the stent. The outcomes were better with thrombectomy plus standard care versus standard care alone. So the modified Rankin scores, which you can see on the right side of the screen there, you know, 0 no symptoms and 6 deaths, 5 severe disabilities. So you can see they're looking for, we'll look at another slide in just a bit, where they're looking for scores of really 0 to 2. So very slight disability. And the scores at 90 days were better with thrombectomy than standard care alone. It also showed that similar rates of functional independence with the DAWN trials patients compared to prior trials with treatment administered within 6 hours. So basically saying that even though we're getting longer out in terms of time, the patient had a longer symptom onset, still the results were just as good or better with thrombectomy. Diffuse 3 trial, again, similar to the DAWN trial, occlusion of the internal carotid artery or the proximal MCA. These patients similarly were randomly assigned to thrombectomy plus standard care or standard care alone. They had to be within 16 hours of last known well time as opposed to 24 in the DAWN trial. And the rapid software, which we'll talk a lot more about later, was used to estimate the volume of the ischemic core and penumbral. What that means is how much brain is able to be salvaged, how much brain is already dead, how much brain can we salvage, and that plays into the risk-benefit discussion of if we reopen this blood vessel, is the patient going to benefit from that and have a clinical improvement, or are we going to cause more risk in terms of hemorrhage and things like that? So we'll talk some more and look at some scans in a little bit. This is actually a rendering from the rapid software. So if you look at the ischemic core, that would be pink on the left, there is none. So, you know, essentially what this is saying is you have all of this green area, the penumbra, at risk for stroke, and you have no brain that is getting no blood flow yet. So you really have a good opportunity to save a lot of brain here. So this is somebody that, you know, pretty much almost definitely is going to go for mechanical thrombectomy. In this trial, as opposed to the DAWN trial, the thrombectomy was performed with any FDA-approved device, not just the Trevo stent. And again, the trial was actually terminated early because the thrombectomy patients were doing better in terms of functional outcomes measured by the modified Rankin scale at 90 days out post-stroke. So here's a nice slide that kind of puts that all together for you. So on the left, you can see your last known well time from 6 to 12 hours. And on the right, you're looking at 12 to 24. So your time is getting longer, which is why you see the percentages go down just a little bit. But this is modified Rankin scores of 0 to 2, and 55% of patients are having slight or almost no disability, you know, with thrombectomy within 6 to 12 hours, and 43% of patients 12 to 24 hours. So these are really, really great numbers. In talking in the sense of people that we couldn't even help, you know, going 5-10 years back. If we couldn't treat them past 6 hours, we didn't have anything to offer them, and that's not the case anymore. Another nice slide that kind of puts things in perspective. Numbers needed to treat. So if you look at patients that were in the DAWN trial, for every 2 patients for reduced disability, you're looking at 9 for TPA, 35 for angioplasty for STEMI patients, and 42 patients. So it really shows that this is making a big difference for people. The DAWN versus the Diffuse 3 trial, just the differences of, you know, time, last known well, and what we're looking at in terms of imaging. You could see a plot there on the right. So these are some pictures of perfusion imaging that we look at when we decide if we're going to take patients for a thrombectomy or not. And again, just comparing the trials to each other. Because of the way they did the selection of the patients and the inclusion criteria, 40% of the patients in the Diffuse 3 trial may not have even met criteria to be in the Dawn trial. However, one similarity is that they both utilize this rapid software to measure the volume of the early infarct and the penumbra, so salvageable brain. Now, I mentioned the ADAPT study as well. I wanted to touch on that a little bit because now we're talking about, okay, so we know thrombectomy is better. We know patients are having better outcomes. We know that we can intervene with more patients because we can catch them with a longer time since last known well time. Now we're talking about, so we have 5 randomized controlled trials, which we already discussed. We know that thrombectomy is superior. However, all these trials, majority of them were performed with stent retrievers only. Now we're talking about how do we improve our times? How do we decrease that door-to reperfusion time? How do we keep things safe and effective for the patients and reduce costs? This ADAPT trial is talking about direct aspiration, first pass technique. What that means is basically, you could say a suction thrombectomy. So you go with one catheter, it's a suction catheter, and you suck the clot out. If that doesn't work, then you also have the opportunity to go in with that stent and use a stent retriever. So results and potential benefits that have come from the ADAPT study. TK2B or 3 were achieved in 78% of cases with aspiration alone. And if it was not achieved on the first try there, you still, like I said, can go in with the stent retriever to recanalize that blood vessel. On the right, again, is a very simplified picture of what it might look like when we're up there in the angio suite. You have a suction catheter that you interface to the clot there. And then you pull the catheter out and you hope that the clot comes out with it. If it doesn't, Dr. Beckless can go back up with different catheters and try again, maybe with the stent. The findings have showed that this has decreased procedure time from 30 to 40 minutes, and average time from groin puncture to at least TK2B recanalization was 37 minutes. That's huge when we're talking stroke. And also, markedly reduced costs with the use of a single aspiration catheter and no additional retrieval devices. So we're going to switch gears a little bit. I said we would talk about rapid AI. We have started to implement it. Dr. Beckless here is showing some of the images that we have been starting to utilize to decide again whether we go for mechanical thrombectomy or not. We still have our perfusion studies from the scanner, and rapid AI is another tool that we've added, and it's hopefully, something that's going to become something that's system-wide when we really get a hold of it and get it down with the team. It's really going to help us make treatment decisions quicker. Dr. Beckless can get to the team almost instantaneously. If he looks at a scan and decides this is someone who needs treatment, then the app, has a way to contact us all, whoever's on call, basically immediately to get going and get into the hospital so we can get these people into the angio suite. So it really will improve efficiency of response time in terms of the call team. And all of this, of course, goes back to saving life-saving minutes for the patient when they're having a stroke. So right now, we're the only place in Suffolk County that's utilizing this rapid AI system. And so far, an average of 10 to 20 minutes of time per patient seems to have been saved just by utilizing this software that comes straight over to Dr. Beckless's phone, and he can review images almost immediately when the patient's in the scanner. Another nice slide here. It kind of just shows, talking about those reductions in time, how much quicker things can go. Now there is a caveat here, 2 minutes we're talking about adding on with this rapid CT perfusion. So you're talking about adding on 2 minutes in the scanner in order to use this software and upload the images and that they go where they need to go. But to save, we're talking 12, 15, 30 minutes, 35.5-minute reduction door to groin puncture time. That's worth the 2 minutes for perfusion, I think. So the other thing that we can talk about, because of this, spoken hub model that we do have with the sister hospital sending us many transfers and patients that we do end up intervening with, is the transfers of patients from outside hospitals. So do they need to come or do they not need to come? Can we intervene with these patients there and keep them there and treat them there for stroke, or do they need to come for intervention, which obviously right now is only offered at Good Sam? So rapid eventually hopefully will be able to help us with that and cut down on unnecessary transfers, meaning patients who don't end up requiring mechanical thrombectomy or needing the angio suite. So that's another thing that we're looking towards in the future that will be pretty exciting for the system as a whole, I think. All the way at the bottom right there, you see 52-minute reduction door-to-door decision time for LVO patients. So basically, you're talking about saving almost an hour with certain patients in terms of deciding whether they need to come to the angio suite or not. We can go over some cases together. The first one, 40-something-year-old female, past medical history. She was a positive smoker, but no other real significant history. She did have family history of stroke. She came in with acute onset right hemiparesis and aphasia. She had some developing left MCA infarct on her scan, the initial plain CT, and then she had CTA and perfusion, which showed near occlusion of her left carotid as well as a left M1 occlusion. And she did have significant perfusion deficit in that left MCA region. We took her for mechanical thrombectomy. She had a TP3 reperfusion, which is full reperfusion. And we also placed a left carotid artery stent because she had significant plaque at the origin of the internal carotid artery there that looked unstable. So, the worry is that she may continue to have stroke. So you place a stent there, open up that carotid artery, and she also was reperfused fully in the brain. She had a really nice recovery. She did have some mild persistent expressive aphasia, but definitely improving, and she did very well with speech therapy. And she had some mild persistent right-sided weakness. She went to acute rehab on post-op day number 8. Some of her images, so you can see the carotids on the left there. On the very left side is her right carotid, which is nice and bright and wide open. And next to that, you can see her left carotid is just like a little, that little brightness on the edge there is the only area where she's having blood flow. And then up top, she's totally blocked in the MCA on the right side of the screen. This is her rapid images. I just thought they were interesting to all show together. The next one, has the MRI. So we talked before about the pink area, which is infarcted brain or ischemic core. So we're talking about salvageable brain versus penumbra area, is infarcted brain, versus penumbra or salvageable brain. So you can see the pink versus the green, and we have some numbers there on the bottom that basically there's a calculation that's done, and we look at these numbers and the images, the patient clinically, and Dr. Beckless makes a decision based on all of these things, whether the patient would benefit from thrombectomy. This is a patient that looks like she would definitely benefit from thrombectomy based on all her numbers and her presentation. And then if you look at the MRI, I thought this was pretty interesting as well. In terms of rapid, this is one of my favorite parts of it so far, is the diffusion part of your MRI, where you're looking at what is the stroke burden for this patient, which we usually don't get for a couple of days, maybe a day or two after. That MRI really should closely resemble that ischemic core, the pink part of your rapid images, because, going back, you're talking about this is your infarcted brain. The green part is your penumbra. That's the part you're trying to save. And if you can see on this MRI, it's really pretty close, and it might even be a little bit less than that, what that infarct area looks like. So it's kind of satisfying when you can see this, you match the clinical picture to our, our radiographic images, and we can see kind of the fruits of our labor. And we watch these people walk out of the hospital, and it's pretty satisfying. So another young case, 45-year-old female with obesity, diabetes, hypertension, hyperlipidemia. She was found out at work, and initially they thought maybe she had a seizure. She was born with global aphasia and right hemiparesis. She also was found to have a left internal carotid artery T occlusion. So basically, that's an occlusion way at the end of distally, the ICA going into the MCA, and a very large area of penumbra in the left MCA territory. She also had a TP3 or full reperfusion, status post mechanical thrombectomy, and she had right side venous, which was improving, and also went to acute rehab on post-op day number 15. So her imaging here again, you can see now we're a little bit higher up in the brain. We're looking at the internal carotid arteries on the left. On the left side of the screen, you can see her right. That little circle there is filling nicely. And on the left, you just see a blank hole. There's nothing. Her carotid's totally blocked. And then a little bit higher up, when you're looking at your MCAs, you can see the MCA on the left side of the screen there. And in the circle, there's really nothing. Pretty blocked left MCA. Again, just going over the rapid images again, because I know it's a lot of this at once, but the pink on the left is your infarcted brain. Your green on the right is your salvageable brain that you're trying to save. We look at some calculations of the numbers on the bottom. Definitely this patient looks like a really good candidate for intervention. And when she had her MRI, again, you are hoping that it looks like it matches that pink side and not the green side. And it's pretty close, which is, again, pretty satisfying when you have good outcomes for these people, especially when they're young. I think that's pretty much it for us. If anybody has any questions, or if Dr. Beckless wants to weigh in at all, because there is some new stuff we added this year, but otherwise that's really it.
Elizabeth, thank you. That was great. I mean, it's been a tremendous evolution when it comes to the endovascular treatment. I'm sure Bruce remembers how we went from the endovascular care is not working to becoming the standard of care within a period of a couple of months, and several clinical trials later. Personally, we've evolved a lot in the way we treat these patients. One of the important changes was, from using stents on every single person based on diffuse and dawn, kind of trying to use new stuff and try to engage new technology. Now we have suction catheters that are spectacular. Every new generation we see is able to go higher and higher into the brain, and we can get bigger and bigger catheters inside the brain, which is pretty remarkable if you think kind of how the field has evolved. And more recently now with new technology where the catheter tips are not cut perpendicularly, but in an angle that allows for the same diameter of the catheter, but really because now the face of the catheter is oval because the catheter is beveled, you have a bigger suction area. So you're able to suck even bigger or more forcefully the clot out, and not have a bigger catheter to do that. So really, really remarkable stuff. And I think one of the thoughts, and I don't know what Bruce's experience is on that, but we're pushing the envelope more and more in terms of how distal we go. The clinical trials have been for carotid occlusions or M1 occlusions, really, right? But we do now go into the M2 and sometimes even into the M3 if you see a dominant M3, say, an M3 that goes into give somebody global aphasia or complete weakness on one side. That's a pretty devastating deficit. So in those cases, we entertain going more distal, and catheters have been created for that. Now we have suction catheters that are 0.35 diameter or 0.55, small catheters, so they can go places. And so and smaller stents, 3-4 millimeter stents that we're able to use for that. So that's very, very exciting that way. I don't know, Bruce, if you had any thoughts on that.
Kimon, thank you for aging me by reminding everyone that I recall working when we were denying the efficacy of reperfusion techniques. I appreciate that, number one. Number two, I think to Kimon's point, there's a couple of issues. I think to Kimon's point about the smaller branch vessels, if somebody who is a newscaster, has an M2 or even an M3, occlusion, and they can't speak anymore despite having, a low NIHSS score. Obviously, they're left neurologically devastated. And I think that as far as we can, push to the limit the technology, we should be for these strokes. There was just a study, I think it was in JAMA Neurology last year, about patients, not last year, last month, about patients who presented with acute visual field cuts, which, if that's all you have, your NIHSS scale is going to be very low. But in this study, they showed that it was safe and effective to go not to M2 or M3, but to P2. So I think they're going into the posterior cerebral arteries now, and they're going further than just the P1 segment, because most of the time when we're talking about LVOs, the studies have been done on M1 occlusions. And I just wanted to make one other point that I feel like I muddied earlier, which is that when patients come in within 3 or 4.5 hours of stroke, we don't need any of this advanced imaging to give IVTPA. We give IVTPA, and that's what we do. But in the patients who come in later, whether it's a wake-up stroke or whether it's the 6 to 16 or 6 to 24-hour window, that's when, rather than going from a time-based exclusion to not perform mechanical thrombectomy, we have to go to a imaging base so that we can identify how much brain is viable and how much is dead. And if you look at the screen right now, you can see what the difference is and when it's reasonable after the ordinary time window or for a wake-up stroke to intervene. So going from, again, a time-based decision, clinical decision, to a tissue-based clinical decision, I think that's the point in terms of the wake-ups and these later strokes that we get, and that's what we can do now.
Sorry, I muted myself. Yes, I agree with you, Bruce, entirely. And, especially in this picture, you can see how in the past, so, the benefit of technologies such as Rapid or Viz or all these artificial intelligence softwares, what you get is you get a real quantification of the brain at risk and the core, and which we didn't have in the past. And in the past, we had to make determination, based on what we saw. It looks about a third, it looks about 50% completed, so we, anything over a third, or, we generally try to avoid reperfusion, over 50% maybe, because that's a big core. And, if you look at this fast, you might say, maybe it's a lot of tissue is infarcted, but then you look at the numbers and you see 21 mLs versus 162 mLs. So it's really a tremendous amount of tissue that's still viable and you can perfuse. And so that's very much have value added to the softwares that can quantify. We didn't really have a good way to quantify that. And Rich is asking, hey, Rich, in what setting are you skeptical of the perfusion, and what are the specific limitations, pitfalls? I would say perfusions can be challenging in two settings. One is a technical failure. So if you have a study that's not done technically well, either because the bolus was not given at the right time or because the tech did not choose the right vessel to time the bolus. Sometimes they choose, if they're not experienced, they might choose a vein versus the artery or whatever have you. The patient's cardiac output might be problematic. So if you have heart failure or low EF, you can have a situation where you are completely off in your protocols, because these are protocols that we've created for the average patient. And sometimes we have secondary protocols for patients on CHF that are going slower on the infusions, on the injections. And other similar situation where we can have an issue is the patient's moving a lot. So if the patient's moving a lot, again, these are slow acquisitions, take a little longer. And so if the patient's moving around, you will get a messed up perfusion. So you might have to sedate the patient pretty aggressively to get a good perfusion. And so these are the challenges of perfusion scans. Even if you don't have advanced software technology to quantify how much with a number, how much of the core exists. Very importantly, though, there are some situations where perfusion is key, right? You have somebody 8 hours out. You see maybe some early ischemic changes in the CT. You got to get a good perfusion. So if it means repeating it, you have to repeat it. You got to know if the brain is alive to do an intervention. And there's other cases where a little movement and maybe a degraded image is not the end of the world. It's a clear M1 occlusion. 3 hours later, you got to intervene. When it came to the clinical trials, patients presenting within the initial time frame, perfusion, the 6-hour time frame, perfusion really was not utilized. And so nowadays, and there's no evidence here or there about it, but anecdotally, we frequently see that, as we were talking before, everybody's brain is different, everybody's collateral circulation is different. So somebody can present within an hour of stroke symptoms and the brain might be infarcted already, might be dead if there's no collateral circulation. We've seen it, especially in young patients, unfortunately, because they haven't had any prolonged ischemia, they haven't had any atherosclerosis. So, a big occlusion can be the end for these people. So that's something to consider. Now, the
Kimon, I think your point about the collateral flow, I think, is the key, and maybe everybody listening can't understand. I think you made a great point about young brains versus old brains. It takes a long time for the brain to develop collaterals, and in terms of decades in people who have gradually progressive atherosclerosis. And I think that, the penumbra basically is identifying how well their collateral flow is, and that's going to, I think, wind up being the key in terms of treating these patients later. And it makes sense.
No, I agree with you. Another issue with mechanical or perfusion is the posterior circulation. We have a little bit of a challenge. The posterior circulation, they're kind of way low when it comes to acquiring those images. Now, I don't want to go over time. We are 9:50. And so we got to take about a 10-minute break, 9-minute break. We'll be back at 10:30 if you want to stop sharing. I will, you guys can stay logged in, don't log off, because then it's going to become challenging to get you maybe back on. We're going to go on a short break and we'll be back with Dr. Misios talking about decompressive hemicraniectomy. Stay tuned. We'll see you in almost 10 minutes. Thank you. All right. Hi, everybody. We're back in action. Let me see if Dr. Mearson can join us. All right. Whenever he comes, he comes. There was a question by Kathy. Thanks, Kathy, for the kind words for Elizabeth. The question was about the mismatch ratio. The biggest the mismatch ratio, the bigger the area at risk, the bigger the penumbra, the more area we can save. All righty. Let me get out of this one. Actually, no. How about this one is shared, right? Very good. All righty. So welcome back to the second part of the morning session. And our next speaker is Dr. Misios, my partner. He will be is an expert on all cranial stuff, and he'll be talking about surgery for ischemic stroke. You know, we spoke about medical management, we spoke about endovascular treatment, and now we will talk about surgical treatment. So kind of the three ways we can address ischemic stroke, and he'll discuss the evidence behind the treatment management and best practices as we are applying them in the treatment of ischemic stroke. Bruce, I can see you coming back. Excellent. All right, Simeon, take it home.
Hi, can everybody hear me? Excellent. So thank you for giving me the opportunity to present today. As Dr. Beckley said, we're going to be talking about the role of decompressive craniectomy in the case of ischemic stroke. And we're going to talk about whether it's something that's reasonable to do and whether it's something that works. Next slide, please. So as we have seen, as we have heard multiple times today, stroke is one of the most common causes of death globally, and the most common cause of acquired disability in adults. There's been a lot of advancements over the past few years, including early prevention of stroke, early treatment of stroke, including thrombolysis and endovascular mechanical thrombectomy. But sometimes the patients don't get here in time. Sometimes by the time they get to the hospital, the stroke has already completed. And we're going to talk about a lot about what happens to those patients, what can happen to those patients who unfortunately are not candidates for thrombolysis or endovascular procedures. Patients who have large hemispheric infarctions can evolve to develop increasing intracranial pressure, which, if untreated, can lead to cerebral herniation and death. And this is the concept of the secondary injury. There is the primary injury that takes place because of ischemia, lack of blood flow to an area of the brain. But then once ischemia starts causing edema, there's a secondary injury that happens. And the goal of decompressive craniectomy is to minimize that as much as possible. Next slide, please. Next slide, please. We're going to talk about I think you skipped one. Yeah. So the intracranial hypertension occurs after large hemispheric infarcts, and the brain has compensatory mechanisms to try and deal with mild increases in intracranial pressure. But in the case of a large infarct, the swelling is so much that it can exhaust the compensatory mechanisms that the brain has. And you end up with a vicious cycle where intracranial pressure is so severe that it decreases the perfusion pressure of the brain, which leads to decreased blood flow and decreased oxygenation, which in turn causes the secondary injury, which leads to worse edema, which leads to higher ICP, and the cycle just keeps repeating itself until you end up with brain herniation and brain death. Next slide, please. The Monroe-Kelly doctrine is a very simple way of thinking about the brain and ICP. And if you break the intracranial contents into the very, very basic parts, you have brain, you have blood, and you have CSF. And next slide, please. And in the case of something causing swelling in the brain, in this case, a large stroke, the first thing that the brain tries to do to compensate for the higher intracranial pressure is to decrease CSF. So you will see that the ventricles get compressed if there is increased pressure in the brain. And then if that doesn't work, then the brain is going to try to decrease blood flow, which in turn causes more injury. But obviously that's not good for the brain. Next slide, please. And the relationship between the intracranial pressure and the extra volume in the brain, in this case coming from a large ischemic infarct, is geometric, meaning that the brain can tolerate mild increases in ICP, but then it gets to the point where even a small increase in extra volume will lead to a very large increase in ICP. And the goal is obviously to try and intervene in stages 2 and 3 here before we get to stage 4, where the secondary injury would be devastating. Next slide, please. So decompressive craniectomy is a procedure that involves removing a large part of the skull. It's a procedure that was originally proposed in the beginning of the 20th century. And it's a very common procedure that we do. It's a very safe procedure. A large question mark shaped incision is made on the patient's scalp, and then the large area of skull is removed. The skin is closed over that area, and as strange as it sounds, patients can live like that for many, many months and years without a large area of skull covering an area of the brain. Next slide, please. You can see a CAT scan here of what it looks like. At one, you can see the early radiographic findings of a large right MCA infarct. And then on 2, you can see a few days later, the edema has increased. You can see how compressed the ventricles are. And in 3 and 4, you can see the picture after a craniectomy has been performed. Next slide, please. And here, on a 3D scan, sort of, that's the typical size of a craniectomy that we would do. Again, you can see a very large area of the skull that is missing. Next slide, please. So who is a candidate for this and who would benefit from this? So craniectomy is the removal of a piece of skull to allow the brain to swell. So patients with large infarction of typically the MCA territory, something that we're going to call a malignant MCA infarction. And then patients with strokes in the posterior circulation that affects the cerebellum. And the area where the cerebellum is, it's a very small, very limited area in the skull where there's not a lot of extra room. So if the cerebellum starts swelling, a similar process can happen, and the brainstem is very close to the cerebellum. So those patients will require something called the suboccipital craniectomy. We're going to primarily talk about patients who have infarcts in the MCA territory, and we're going to skip the suboccipital craniectomy patients for this talk. Next slide, please. So how many patients end up running into this? So about 10 to 20% of patients with acute MCA occlusion can develop malignant edema. And again, it involves an area of ischemic tissue that's large enough to start developing edema with subsequent development of increased ICP. And you see that on a CAT scan very easily as it's shown here. There's midline shift, there's compression of the ventricles, and there's a large volume of hypodense tissue, which is infarcted tissue. People have tried to find, what are there any risk factors that put people at risk for developing malignant edema? Obviously, the higher the stroke scale is, the more likely patients will develop this. History of hypertension, female patients, CHF, can also be risk factors. Patients that are younger, which may sound counterintuitive, but young patients have more brain. As patients get older, there's brain atrophy, which creates more potential space and room in the cranium. So these patients are actually a little bit more protected against this. If this is treated conservatively, meaning with hyperosmolar agents and medical treatment, mortality can be as high as 80%. Next slide, please. We're going to talk a lot about outcomes. All the studies we're going to talk about look at outcomes, and you need to have a way to standardize how patients do, and the modified ranking scale serves that purpose. So this is just a reminder for what we're going to be talking about. So modified ranking scale is a scale of outcomes. It goes from 0 to 6. 0 is normal, 6 is dead, and 3 is the main cutoff. Modifying an MRS of 3 means that the patients have some disability, but they can walk on their own. And that's the main cutoff between good and bad. At 4, they need assistance in order to get around. Next slide, please. So people have tried looking at, does decompressive craniectomy in the case of stroke, does it help people? And of course, randomized control trials are the gold standard in trying to answer this question. And there's a lot of randomized control trials. The vast majority of them are out of Europe. And in 2007, the first randomized control trial is the decimal trial out of France. It looked at patients 18 to 55, so younger patients, assigned them to decompressive craniectomy versus best medical care. They were able to accrue only 38 patients over 4 years, and they looked at outcomes. And again, they used that cutoff, the 0 to 3 cutoff in the modified ranking scale. And they did see that 25% of the patients in the craniectomy group had favorable functional outcome versus only 5.6% with best medical treatment. The other thing they saw is there was a significant decrease in mortality in patients who had craniectomy. Next slide, please. At the same time in Germany, next slide. You skipped one. At the same time in Germany, the Destiny trial took place, also in 2007, looked at a similar cohort of patients, 18 to 60, and also assigned them to decompressive craniectomy or best medical treatment. Their primary outcome was not a modified ranking scale, it was mortality at 30 days. Again, a very small number of patients, only 32 patients, but again, they saw that there was a significant benefit to survival with 88% of patients surviving with craniectomy versus only 50% with medical treatment. They looked at outcome as a secondary, they looked at MRS outcome as a secondary outcome, but there was no statistically significant difference. So even the patients who survived compares, they were not necessarily independent. Next slide, please. 2 years later in the Netherlands, similar study, the Hamlet trial, 64 patients, almost twice the number of the previous 2 trials, similar age group, 18 to 60, similar assignment to craniectomy versus best medical care. Again, they looked at favorable functional outcome at 12 months, again, defined as the modified ranking scale 0 to 3, and at 3 years. Again, they saw that the decompressive craniectomy significantly reduced mortality, but there was no significant difference in the rates of favorable outcomes at 1 year or 3 years. Next slide, please. You skipped one. In the US, in 2014, an attempt was made to do a similar study, and that was the Head First trial. It didn't work very well. They had a very complicated enrollment and selection process. They started with screening almost 5,000 patients and ended up with only 26 patients that were randomized to decompressive craniectomy or best medical treatment. There was a lot of crossover, and that's kind of what limited them in selecting more patients. They looked at survival at 21 days. They did see a significant decrease in mortality, 21% versus 40% with best medical therapy. But because their sample size was so small, it was not statistically significant. So the results of this trial, take it with a grain of salt. Next one, please. The big question is what happens with elderly patients, because the majority of patients we see with ischemic infarcts tend to be older than 60. And that question, the Destiny 2 trial came to answer. So this was also, the Destiny 1 was out of Germany, Destiny 2 is out of Germany. This was done in 2014, and it only looked at patients over 60 with a median age of 70 in both groups. A total of 112 patients, again, assigned them to decompressive craniectomy versus best medical therapy. And they looked at, again, favorable functional outcomes. They cheated a little bit. So instead of 0 to 3, they went from, they included as favorable outcome an MRS of 0 to 4 at 6 months. So even patients who couldn't walk on their own, but they could walk with assistance, were considered a favorable outcome. And they did see a difference. 41% of patients who had craniectomy versus 16 who didn't had what they defined as favorable ranking scale at 6 months. Again, they saw a significant decrease in mortality with craniectomy, 43 versus 76%. Now, if you look at their outcomes a little bit more, in a little bit more detail, out of that 41% of patients who had favorable outcomes, how favorable were their outcomes? So no patient had 0 to 2 modified ranking scale, and only 7% had modified ranking scale of 3. So 7% were able to walk independently. So the rest of them, the majority, were modified ranking scale of 4, which means that they're alive, but they need some they need assistance to get around. Next slide, please. 3 large meta-analyses were done looking at combining a lot of different papers and studies, pulling together all the data, trying to answer also this question from a different angle. And again, the consensus is that, again, decompressive craniectomy, there is no doubt that it improves mortality rates. But there is a greater share of patients that survive, but certainly the functional outcome takes a hit. So a greater share of patients that survive with an MRS score of 4 or higher. And the older the patient, the higher the chance that they will have a severe disability. Next slide, please. The other question that we have as surgeons is the timing. When do you do this? If you wait too long, if you wait 48 hours and up to 96 hours after stroke, you may not have any, again, you may save someone's life, but you may not improve their functional outcome at all. So there's always the dilemma. Do you wait until patients clinically deteriorate, which means that some additional brain damage has certainly taken place? Or do you perform craniectomy preemptively, knowing that patients will develop severe edema? And that's it's a rhetorical question. There's no good answer. So that's where discussions with the family play a big role. Patient wishes play a big role, but it certainly is something, it's a discussion that needs to be done early in the process after a very large MCA infarct is identified. The edema peaks on days 2 to 5 after the stroke, but about 70% of these patients deteriorate due to significant edema within 48 hours. So again, it's something, when a patient is identified with a large MCA infarct, this discussion needs to happen right away. And if the patient would want it, if the family would want it, then early craniectomy is certainly preferred. Next slide, please. There is an NIS study. NIS is a very large database, which has a large number of patients, but it's a database, so it does not give you functional outcome data, but they do include disposition data, whether patients end up going to rehab or not. And they looked at close to 1,300 patients who underwent decompressive craniectomy after a stroke, and looked at patients who underwent it within 24, 48, or 72 hours. And there was a higher chance of discharge to rehabilitation the later the decompressive craniectomy is performed. Again, just take it with a grain of salt, but again, just a sign that if you wait too long, higher chance of going to rehab. Next slide, please. And in closing, again, craniectomy is a very common procedure. It's a very safe procedure, but it's not without its risk of complications. I'm just including just a couple of slides just to indicate what can go wrong. Sometimes after craniectomy, you can have the brain swelling out of the craniectomy defect. That's called external cerebral herniation. That can pinch off surface vessels in the brain, especially veins, and it can lead to subsequent infarction. That's why it's preferable to do a big craniectomy to allow more of the brain to swell out uniformly as opposed to out of a small hole. Next slide, please. You can have spinal fluid building up outside the brain, and that's called the subdural hygroma. Very, 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 very common. 50% of the patients will develop that. It's fine, it's tolerated well. Some of these patients may end up needing a shunt. Most of them, this fluid resolves when the bone flap is placed. Next slide, please. Of course, wound healing and infection is an issue. It happens in about 1 to 3-4% of patients who undergo this. These are patients that stay in the ICU for a long time. And next slide. Sorry, I was muted. Next slide.
Sorry, Simon, I was talking to myself. There's a question from the audience. Rich is asking, how long were the patients followed in these landmark trials that you presented?
It varies from trial to trial. Some of them was 6 months, some of them was up to 3 years.
And kind of a follow-up question to that is it possible that they continue to improve in terms of MRS and are simply not followed long enough to ascertain the true benefit?
After a year, very unlikely.
Great, thank you. Sorry for the interruption. Here you go.
Okay, and next slide, please. And sorry, one more, next slide. So in closing, you know, the bottom line is that this is a procedure that it's a life-saving procedure, but it's not a procedure that doesn't come at a cost. And certainly we've gotten much better at saving people's lives, but the functional outcome does take a hit. In summary, if you look at the European randomized controlled trials, about 43% of the patients who underwent this procedure had a very favorable functional outcome. In the elderly group, greater than 60, there's only one study. It's that Destiny 2 trial. Only 7% were functionally independent. So you do improve survival, but it's at the cost of a life with severe disability. And next slide. And again, this is the goal of this procedure is to treat edema, which can be fatal up to 80% of the cases. And again, we do reduce mortality, but we are not that great at reducing disability. Next slide. All right. And again, I'm happy to answer any other questions that you have.
That looks like all my patients. Simeon, you touched upon timing of hemicraniectomy, and I think probably the most important point. What's your take on ultra early hemicraniectomies, which, obviously, and kind of maybe touch on the New England Journal trial on early hemicraniectomies as opposed to later on. And I know that, I guess, consensus really doesn't exist among neurosurgeons. Well, I think the evidence is clear on earlier the better, but what's your practice when it comes to these?
Yeah, there's been even the consensus. There's been a very big shift in the how aggressive surgeons are with craniectomies, certainly over the past 10 years. And the benefit is there. And I think most people would advocate for an early craniectomy. There's a balance, right? If you do very early craniectomy, you're going to end up doing some surgeries that patients may not need it in certain patients, but at the same time, you're preventing patients who would develop that secondary injury. You're improving functional outcomes and certainly survival. So there's a balance, and where do you strike that balance? Again, the discussions with the family are paramount. My preference is obviously patients with an early craniectomy do better. There's no doubt. But we have to be honest with the family and let them know that the goal of the craniectomy is not to reverse the damage that has taken place with a stroke. It's just to prevent additional damage from happening. Overall, it's a life-saving procedure. It's one of the few procedures we do that it can reduce mortality so much. So I'm a big proponent of early craniectomy. But again, obviously it depends on the patient's family wishes, underlying health status, age. So
No, that's a great answer. And Bruce, from a neurology perspective, do you engage neurosurgery early for a hemicraniectomy watch? What's your practice at St. Catherine's? Do you get them on board? Say there's completed stroke, there's no intervention, the patient's in St. Cat's. Do you engage neurosurgery early to follow the patient and probably apply some measures to prevent the hemicrania, or do it early? What's your practice?
I think that the issue of early rather than late is probably settled, and that these patients should have the procedure done very early, preferably before you see this malignant edema in the MCA territory. So I think, again, to Simeon's point, a discussion with the family and the realistic expectations, because they have to be realistic, that we're performing a life-saving treatment here. But as far as the morbidity goes, we may not be as successful. So early, definitely better. These are the patients who have, a thrombus in M1, and they don't get recanalized by Kimon or his colleagues because it was too late, whatever the reason. And I think that they should be done earlier. But as the neurologist on this panel, I can't help but ask my favorite tempting question when it comes to hemicraniectomy in acute malignant MCA infarcts and this is for both Kimon and Simeon, does the brain dominance in the patient factor into your decision as to whether or not to proceed with this? Because the reason I bring it up, just for everyone in the audience, is because patients who have a dominant hemisphere infarction that is associated with that much MCA edema, so much so that they need to have their skull taken out to decompress the brain, are the same patients who are really going to be neurologically devastated. I mean, they're going to be globally aphasic in all likelihood, or minimal, language function, and they're going to be hemiplegic just by definition. So I'm just curious how much of that weighs. I mean, in a non-dominant hemisphere infarct, I think it's, obviously it should be offered in the dominant. It should be offered based on the data. I'm just curious if that goes into your decision making, because I think that's an important question.
It certainly goes into the discussion with the family. It doesn't go into the decision making in the sense of withholding the offer of the procedure to the patient. But again, when we explain the procedure to the family, we let them know that the patient will have hemiplegia and significant language and speech dysfunction. Now, having said that, if you do this procedure long enough, you find exceptions. There are a few patients, they're all young, so in their late 20s and 30s, who have had a left MCA infarct, and they've had this procedure and they've had some recovery of language. Again, they don't speak perfectly, but they speak enough or they understand enough. So even a large left MCA infarct doesn't mean that the patient will 100% not have any language function in certain cases.
Agreed.
Yeah.
I'm just curious if that goes into your decision making. I mean, because frankly, if it were me, and if I ever wind up in your emergency room with this, just let me go.
But hey, as long as your family knows that and they can tell us that, that's fine. But
yeah.
we don't force this procedure on people.
No. I'm just curious if it weighs into your decision making process.
It is,
because
Simeon is right though. It's tough, right? You talk to these families and you tell them, obviously, they're devastated. And he said before, there's no expectation of improvement of the symptoms, although sometimes we do see them. Like Simeon said, we do see improvement despite the fact that there's no expectation for improvement.
Oh, they can definitely improve.
Right.
That's well documented.
But what I think where all of us doing this procedure are very clear is that what we're going to do is going to save their life. Nothing else is on the table. And it might be a very compromised life. It might be a life in a nursing home. It might be a life in with a tracheostomy and a peg tube, and that chance is very high, especially in a left side completed stroke.
Right. Right.
And depending on the age of the patient, actually sometimes even in the older patients, families are kind of, when they're met with the emergency of the situation and the need to make a decision on the spot, very rarely do they say let him go, unless it's somebody who's had cancer and they're terminal and they're palliative. And even in that case, we've had a case, Simeon knows the case very well. They wanted a left side, right, Simeon? They wanted a left-sided hemicraniectomy in a pancreatic cancer patient, terminally ill.
Yep.
So, at that, it's kind of tough on the physician side, because then, we're also liable not to offer that as an option when it is an option. And so.
Yeah, no, I think it has to be offered, and there is obviously a place for it. I mean, there's no question about it.
But I agree with you. Obviously, if I had a left-sided MCA stroke, I don't know that I would want to be around.
And that's actually, that also plays a role. A common question is also, why do we have these randomized control trials out of Europe? And why don't we have more in the United States? Because in Europe, the medical legal system is very different. And in the US, it's very hard in the US to randomize people to a group that may end up having a higher mortality rate.
Yeah,
or
there's
to
lack
our-
of equipoise.
Yeah, if the family says I want everything done, I mean, you can't randomize them to not doing that. And maybe in a socialized healthcare system it's different, but that's one of the reasons why with this we don't see a lot of randomized controlled trials for this specific procedure, coming out of the States.
Perfect. All righty, we're a little 5 minutes over time. Great presentation, great discussion. Thank you,
Thank
Simi.
Thank you.
Bruce, you are up. So
Okay.
my co-host this morning, Dr. Mearson, he will be speaking next. As we said earlier, he is the boss of us all. He's the chairman of neurology at St. Catherine of Siena, but most importantly, he's the chair of neurosciences for Catholic Health. That's the equivalent of king status when it comes to Catholic Health. And so, Bruce, do you want to share your screen, or do you want me to share your slides from here?
Maybe you do it. I don't, I'm rather computer illiterate, so maybe I can just,
No
am
problem.
I able to see my slides?
Yes. Give me 2 seconds and
Sure.
I'll get your slides up. Oops. Sorry about that. Two seconds, Bruce.
Take your time. Take your time.
I just need to get your presentation up. Yes, Dr. Mearson is going to talk about secondary prevention of ischemic stroke. So we talked about primary or medical management, interventional management, surgical management, and now we're going to go into the prevention side after a stroke has happened. And without further ado, all right, can you see them, Bruce?
Great.
All right.
Next.
Here we go.
Next. Okay. Good. Is this the second slide, Kimia? I don't think. I'm not sure if this is. Well, we'll do what we can. There, I made some changes yesterday. I don't know if this.
This is the most recent one.
Because there was a second slide there that just said I have no disclosures, and I don't see it there, so I'm just not sure if it's the most updated one. But if I can go through the. Yeah, you want to just check?
It's not. That's the one I got from you.
Okay, so that's fine. I gave this talk last year, and what I tried to do was make an updated version of it for this year. And there are some interesting things that I'd like to focus on. Back in the day, before we had people like Dr. Bekelis and Dr. Missios, this is the only thing that we could talk about in the management of stroke, was preventing the next one from happening. And thanks to the technology and the hard work of our colleagues, we now are able to talk about the acute treatment of stroke. And this was the classic neurologic in the Stone Age when I was training. This was the classic neurologic diagnose and adios disease, and it obviously has changed dramatically over the past several decades. And I've been lucky to be on the forefront of it with Catholic Health. So this talk is going to focus on the secondary prevention, though, of stroke, meaning after someone has had a stroke, what can we do to prevent a recurrent stroke? Everything up until now has been about the acute treatment of stroke. And so we're going to shift gears here a little bit, and that's just my point. On the average, the annual risk of a recurrent stroke in patients who've had one or a TIA is on the order of 3 to 4%. And a TIA, even though obviously it leaves a patient unimpaired by definition, is just as important as a stroke, in the sense that more serious events need to be prevented, because up to 50% of TIA patients will wind up having a stroke down the road years later. And these strokes occur most commonly within the first 3 months, and even earlier, within the first several weeks after the TIA or the small stroke. As a general sort of blanket term, the preventative management for secondary stroke really hinges on antiplatelet medications, but not more important are your risk factors, especially hypertension, atrial fibrillation, your lipids, some of the other things that are imperative. With blood pressure, definitely being the most significant risk factor that needs to be managed aggressively to prevent a patient from having another stroke. Next. So this slide is just showing the different types of strokes that we see. So broadly classified into large vessel or cortical strokes, which are most commonly secondary to embolism, either cardioembolism or artery to artery embolism, less commonly, and small vessel strokes. And these are the smaller strokes, no less significant though in terms of the morbidity, because a strategically placed, very small stroke in the internal capsule or in the brainstem can leave you neurologically more devastated than the stroke that you see on the right-hand side, which is an MCA branch infarct. So, even though it's small vessel, it's not small beans. And I think that, one of the things we'll try to hammer home here is what can we do to prevent these strokes from recurring. Next, sorry. In general, vascular risk factors are the key. As I said, the most important is hypertension. And, I'll hammer home the medical treatment of blood pressure, which is now recommended to be targeted at less than 130/80. Regardless, I wrote for patients with diabetes, but that's from the old slide. This should be for everyone, especially if they have significant risk factors. Or in those who suffered a small vessel stroke where hypertension is the most significant risk factor. So that target 140 and 90, this is Kimon, I apologize, but this is, I somehow sent you the wrong thing. Any updates I make, I have in a different talk, and we can, if anybody wants copies of it, I have it.
Perfect.
So this was changed, just FYI. Next, sorry. As far as blood pressure goes, it really doesn't much matter what you use to treat the pressure, whether you use an ACE inhibitor, a beta blocker, an ARB. It doesn't really make a difference. The important thing is that the pressure is treated. And however you get there with your primary care doctor or your cardiologist or neurologist is fine. Maybe ACE inhibitors have a protective effect beyond their blood pressure lowering effects. Next. Yeah, I wanted to spend some time talking about lipids, and this is, Kimo, can we hang on for 2 seconds? Because,
of course,
give me 1 second here, because I'm going to see if I can. I made a lot of changes in this. I'm sorry, everybody. This is what happens when you're dealing with someone who's computer illiterate like myself.
I have a PDF. That PDF is probably your most recent presentation.
Okay. So let me do this. Let me
hold on. I can open your PDF instead.
See if you can, just because there are changes that I think are relevant. I'm sorry, everyone.
Yeah, no problem at all. You know what happens is you send me the PDF and the PowerPoint, and maybe the PowerPoint was not the one. We will.
Actually, I didn't send you anything, and that's why this is so messed up. It was my millennial colleagues here in the office who helped me. But I would have loved to.
All right, here we go, Bruce. Hold on a second.
Let's try it.
Yeah, I think it'll be okay. The PDF, I think, is what you want. It's not gonna look as pretty, but still it's gonna be good. All right, so I'm gonna go quickly through here.
Yes, this is the one. Good. Perfect. Good. We got through this. Great. So let's talk about lipids. Sorry, right back into it. Elevation of LDL, triglycerides, low HDL are risk factors for atherosclerosis in general, whether it's coronary artery disease or peripheral vascular disease. And I think it's safe to say that the statins, the HMG-CoA reductase inhibitors, have revolutionized the management of vascular disease, whether it's brain, whether it's heart, whether it's peripheral vascular disease. And for us as stroke people, the most important agents are what are called the high intensity statins, which are the most potent. Atorvastatin, which is Lipitor, or Suvastatin, which is Crestor. And those should be initiated immediately, as early as the antiplatelet therapy is initiated at the time of the index events. And in general, this is probably a change. I don't know if the actual guideline has changed, but it used to be less, the LDL we targeted for less than 100. Now, really, we say less. I say in all my patients who've had an acute ischemic stroke that the target LDL should be less than 70, regardless of whether they have diabetes or not. And next. And this is a little bit of the data to support that, just mentioning the Sparkle trial, which was the the seminal trial when it came to intensive lipid lowering in acute ischemic stroke. Lipitor 80 milligrams, target LDL less than 70. A couple of updates here that I wanted to mention, which I don't think were present before the 2021 guidelines came out, but regardless, high intensity statin and Zadia can be added to high intensity statin if you can't get the LDL below 70 with just that. And in very high risk patients, especially if they have a lot of risk factors and you still can't get the LDL lower, it's reasonable to add one of the PCSK9s. Those are your Repatha drugs, the injectable drugs that are used on a monthly basis. New to the guidelines is that fasting triglycerides should be, well, we always get them in a lipid panel, but they should be treated. And they give you a parameter for 135 to 499 that it's reasonable to start Vascepa, 2 grams twice daily. And you have to be a little careful with patients who have pancreatitis or AFib, because it can potentially trigger that AFib. So, certainly for your small vessel strokes, it's reasonable. Many of your large vessel strokes, if they are due to atrial fibrillation, you might not go this route. Next. Diabetes, all TIA and stroke patients should be screened. Many of these patients have diabetes when they come in. They know it. They just may not be well managed. A lot of people have issues, obviously, managing their sugars, even with medication. Target A1C should be less than 7. Ideally, less than 6 would even be better. And if they have a BMI of greater than 35, they're under age 60, it's reasonable to add metformin to that. And pioglitazone also has been recommended as an update to the guidelines in terms of blood sugar management. Next. Other common risk factors: Mediterranean diet, exercise, weight loss, moderation of alcohol, tobacco, smoking, treatment of obstructive sleep apnea. I think that these all just stand to reason. I think in the year 2021, if you don't realize that you shouldn't be smoking, then you're making your own bed. So next. So let's talk about those smaller vessel events, the TIAs that have an ABCD score of less than, of 5 to 6 or greater, these so-called high-risk TIAs, and the patients who have NIHSS scores of less than 5. Specifically speaking, we're talking about these small vessel infarcts. Those are the little strokes that are nonetheless not or are as important as the large vessel ones in terms of morbidity, because they strategically placed lacunar infarct can be neurologically devastating, as we've all seen. For these patients, in general, antiplatelets are recommended rather than anticoagulation. And we have acceptable options for secondary prevention, including aspirin, Aspirin and dipyridamol has probably fallen, not probably, has certainly fallen out of favor, really just based on one trial. It was an old trial, and patients often get terrible headaches on Agrinox. So I think most of us have switched to clopidogrel with or without aspirin. The question of dual antiplatelets has been a very hot topic, and I'd like to emphasize that the key about the trials that supported dual antiplatelet therapy in with aspirin and clopidogrel were the chance and the point trials. They've both occurred over the past. One was in 2013, I think the other was 2017 or 18. But basically, they do reduce the risk of stroke within the first 90 days without necessarily increasing the risk of hemorrhage, at least in the CHANCE trial. We'll talk a little bit about the THALES trial for ticagrelor. But I think that the key, and what I'd like to start to emphasize more, even in general across our campuses, is that the key with these medications is that they need to be started early for them to be most efficacious in terms of preventing a recurrent stroke. Certainly within, in patients who don't receive IV TPA for these, small vessel type strokes, this should be, given as quickly as one would want to administer TPA in terms of secondary prevention, because that's when it works the best, excuse me. Evidence supports the use of dual antiplatelets within 24 hours of TIA or ischemic stroke. The trials were for 21 days, and this would start with a clopidogrel load and an aspirin load, and then 300 milligrams on the clopidogrel, and then 75 milligrams daily, 81 milligrams of aspirin. After that time period, the 3 weeks, the patients can be reduced back to monotherapy. The risk of bleeding after 90 days on the combination outweighs the risk of benefit in terms of secondary prevention of stroke. What to do between 21 and 90 days is, a little more difficult to know right now. That's sort of a gray area. What I typically do is keep these patients on dual antiplatelet therapy for a month, because a month is easy to remember. But 21 days is the technical thing to do. And if a patient is on aspirin already, then we might just load them with clopidogrel and continue the dual antiplatelet therapy with that combo. If they weren't on any antiplatelet therapy prior to the index event, then aspirin and Plavix or clopidogrel can be started right away with the correct loading doses. Next.
Bruce, quick question from the audience. Do you check Plavix response, I guess P2Y12, for patients with ischemic stroke while on Plavix prior?
So that's a great question.
They're
actually.
already on Plavix and they have a stroke.
These are patients who had an infarct while on Plavix already?
Right, and the question is, are they responders or not? Do you check?
Right. Well, one could argue that they failed if they were on Plavix. One option for them may be what we're going to discuss next, which is the addition of Brilinta ticagrelor. But no, we don't routinely check for that. I think in patient populations where there's a higher level of non-responders, the Asians in particular, up to 50 to 60% of Asians may be non-responders, and those in that population we see more significant intracranial atherosclerosis. So that's a significant issue, but no, not routinely. We would just go to what's the next best thing to do. The trial last year, the THALES trial, which we've talked about in patients with mild
10 minutes. Bruce.
Okay, I'm moving. I'm sorry. Okay. Mild to moderate non-cardioembolic stroke or high-risk TPA. Basically, the combination of aspirin and ticagrelor at 30 days after a loading dose of each, and then a standing dose. Ticagrelor was 80 milligrams up front, and then 90 milligrams twice daily dosing. was less than the risk of stroke or death was less than with aspirin alone. More bleeding was more frequent with ticagrelor, but not necessarily intracranial hemorrhage, devastating intracranial hemorrhages, more GI peripheral bleeding. Next. So that's a brief discussion on these small vessel infarcts. Let's go to cardiogenic embolism, and I put a whole bunch of new things that we didn't look at last year. I'll go back. Yeah, so we know that warfarin is almost never used in patients who have non-valvular atrial fibrillation anymore. Patients with severe mitral stenosis or mechanical heart valves still should be anticoagulated with the old-fashioned warfarin, Coumadin. Patients who have a PAF with a CHADS-2 VASC score greater than 2 need to be chronically anticoagulated. I'm not going to get into how we score that. But it's an easy app you can put on your phone and just calculate for any patient. I often use them to make decisions about whether or not someone needs to be anticoagulated. But obviously, everybody realizes that the direct oral anticoagulants, direct acting thrombin inhibitors and factor Xa inhibitors have obviously revolutionized anticoagulation and in some cases more effective than Coumadin with less risk of bleeding. So I think we're in an era now where most of these patients can be expected to be on one of the novel anticoagulants. Aspirin, really does not likely do anything significantly with regard to secondary stroke prevention in patients who have atrial fibrillation. And I only mention atrial fib because it's the most common reason people have a cardiogenic embolism. In those patients, you might consider a Watchman closure device of the left atrium to block off where most of the clots generally go. Next. Or generally come from. So patients in whom it's contraindicated, the combination of the dual antiplatelet therapy does carry similar risk of bleeding and is not necessarily associated with a decreased risk. In St. Catherine's, we put many patients on dual antiplatelet therapy who weren't candidates for anticoagulation for another reason. Just some of the other potential cardiogenic sources of brain embolism, acute MI and left ventricular thrombus in patients with stroke and TIA should be managed with warfarin 2 to 3 on the target INR, and that should be for at least 3 months. These are the most updated guidelines. In patients with cardiomyopathy with an ejection fraction of less than 35%, it's not clear, but warfarin, aspirin, the combination can all be considered. So I think that's it's a judgment call. Next. Valvular heart disease, rheumatic mitral valve disease. I mentioned mitral stenosis. Those patients should be treated with warfarin, INR 2 to 3, not the new oral anticoagulants. Antiplatelet drugs probably are not useful. In patients without AFib, you can use antiplatelet therapy if it's a non-rheumatic mitral valve disease. Patients with mitral valve prolapse or mitral annular calcification, antiplatelets probably. Patients with prosthetic mechanical heart valves should be not started on one of the newer ones, but should be maintained on Coumadin with a target INR that's higher. Should be around 3 rather than 2.5. If they've had an event while on warfarin, it's not unreasonable to add baby aspirin. Next. As a general rule, we say that antiplatelets should not routinely be added to warfarin, but often in these patients who have concomitant disease, especially coronary artery disease, they do need to be maintained on both. There, to my knowledge, is not a situation in which triple therapy with aspirin and Brilinta or aspirin and clopidogrel should be used concomitantly with anticoagulation. The risk of bleeding is too high with all three. PFO is another potential source of cardioembolism, or maybe paradoxical cardioembolism. Yes, you need. Oh, 5 minutes, he's telling me. Sorry, I thought you were raising your hand. Okay. So I'm going to move antiplatelets and closure options. The guidelines at this point for PFO, and these are relatively updated. Patients under the age of 60 who have what appears to be a cryptogenic stroke, an embolic stroke of uncertain significance, we call them. Closure may be recommended in those patients, and aspirin or anticoagulation may be acceptable, but certainly high-risk PFOs, like patients who have an atrial septal aneurysm or a large atrial or a large PFO or a significant shunting, should probably be closed, especially in the younger patients. Keep in mind that 25% of all of us will have a patent foramen ovale, and so its significance when someone has a stroke, it has to be looked at because it's not clear. We talked about left ventricular thrombus, anticoagulation with warfarin, 3 months is recommended. Left atrial thrombus, same story. Heart tumors, this I don't think we mentioned last year, but another potential source of cardioembolism, non-thrombus cardioembolism is embolic tumor from myxoma or fibroelastoma, and those patients should have surgery, open heart surgery. Next. This is an important one that I wanted to mention. I wanted to emphasize this, the ESUS, which is stands for embolic stroke of undetermined significance. These are your patients who come in with what looks like a large vessel infarct, a branch MCA infarct, who you have a reasonable suspicion that they may be coming in and out of atrial fibrillation, but you're not sure. And when you're seeing them, they're not in AFib. These patients, this was studied recently in 2 big trials, Navigate ESUS and Respect ESUS. And in both of those trials, it was concluded that antiplatelets are preferable to oral anticoagulation or ticagrelor because the decrease in recurrent stroke risk was the same. So I think the results of this are a little bit counterintuitive, and I think that there are from time to time patients who we like to keep on or who we feel like anticoagulating because it looks like an embolic stroke, but based on these trials, that's not the recommendation. So that should be taken case by case. Next. Intracranial stenoses, I'll bang through this quickly. It's a significant risk for recurrent stroke, seen more commonly in Asians, African Americans than Caucasians. WASA trial recommended it showed that in patients with 50 to 99% stenosis, aspirin 325 is recommended in preference to warfarin, so those patients shouldn't be anticoagulated. Blood pressure control, cholesterol, we know about that. The usefulness of angioplasty and stent placement is considered at this point unknown. I think everybody is aware of the Sampras trial. I'm not going to get into that right now. There is a guideline to which one may add silostazol, which is another antiplatelet agent, or clopidogrel in patients who were on aspirin, who may have failed aspirin in moderately 50 to 99% stenoses. Next. So this is just a picture demonstrating that. You can see where the arrows are is indicating these intracranial stenoses, and Sampras. I mean, these are smaller branch vessels, M2 branches of the middle cerebral artery, but the ones that are more proximal to that did not do better with angioplasty and stenting in Sampras than they did with antiplatelets. On the right, you just see a stroke that might result from that, a wedge-shaped infarct, making the likely mechanism of injury artery to artery embolism rather than something that's perfusion-based. Next. This one I put in, but it isn't really about secondary stroke prevention. It's primary. I showed this last year. There was a trial, I think it was in JAMA Neurology, which basically showed that there is a low risk of stroke in patients who have asymptomatic intracranial stenoses, and it does not necessarily increase the risk of having a stroke in those receiving standard medical care. So just a point. It's out of the scope of this talk, but I just thought it was important to mention. Next. That's just a picture of a severe MCA stenosis, proximal MCA stenosis. Next. Carotid stenosis, I'll go through this quickly. Severe stenosis.
Oh, and you know what, Bruce, I'll talk about this in exactly the next talk about extracranial. So if you want to skip.
Okay, so let me just mention extracranial vertebral stenosis. You can talk about carotids. Optimal medical management with risk factors, antiplatelets and lipid lowering agents is recommended. The benefit of stenting a vertebral artery is not well established at this point. Obviously, if all else fails and somebody clearly is having events referable to that vessel, then you may ask Dr. Bekelis at least to consult, but it's not something we do as a standard of care, at least not at Good Samaritan Hospital. We have seen it done elsewhere. Next. Aortic arch athero, antiplatelets and lipids, stands to reason. Next. Then let's just do a couple others quickly. Arterial dissection, antithrombotic therapy, 3 to 6 months is appropriate with aspirin or a combination of dual antiplatelets. Anticoagulation has not been shown to be better than maximal antiplatelet therapy in these patients. On occasion, in a patient who fails medical therapy, stenting may be considered. So keep that in mind. Thrombophilic states, people who have systemic malignancy or antiphospholipid antibody syndrome. Generally, we use antiplatelets in these patients, but I think that part of that will depend on what the mechanism of stroke is that you think. Venous sinus thrombosis, anticoagulation is usually recommended acutely, even if there's an associated cerebral hemorrhage, by the way. That's the exception to the rule that we wouldn't anticoagulate somebody with a stroke acutely. And it's reasonable to consider for, probably 3 to 6 months, and then it can be followed by antiplatelet therapy. Next. Sickle cell disease, I don't think we mentioned this last year. Patients who are at risk for having had a stroke or those who have had a stroke, you can monitor their transcranial Doppler flows, and if they're greater than in the middle cerebral artery 200, they should be transfused, but also if they've had a stroke, they should be transfused for a target hemoglobin of less than 30, a goal of a target hemoglobin S of less than 30. Fibromuscular dysplasia, antiplatelets, antihypertensives, may consider an intervention if they fail conservative treatment. Vertebrobasodolichoectasia, antiplatelets or anticoagulants. I don't know that anticoagulation has been shown to be definitively more effective in secondary stroke prevention. So a lot of those cases we have to take with a grain of salt. Next. Okay.
Perfect. No, Bruce, thank you. This is a great presentation, very comprehensive. We've asked you to do a lot of stuff. Secondary prevention of stroke is a book in and of itself, but it was a great looking through the new stuff that are coming out. I had a couple of questions during the talk. I just want to stay on time, so I will try to push through. I still see we still have a lot of people that haven't quit on us yet. Oh, that's a quick question. Can you address the role of Brilinta? They say, Kathy Videtto is asking if you can address the role of Brilinta in after ischemic stroke. And let's answer this one quick, Bruce, and then we'll move to the next presentation.
So based on the Thales trial, which came out last year, and I'll just make this quick, anybody who's had what's considered a high risk TIA, which means their ABCD squared score is greater than or equal to 6, or if their NIHSS is less than or equal to 5. So these are, mild to moderate strokes and high risk TIAs. Those patients do benefit from the combination of aspirin and ticagrelor with a loading dose of both in the emergency room, and then target dose of aspirin 81 milligrams daily and ticagrelor 90 milligrams twice a day for 21 days. As I said, sometimes I just say a month to make it easier. But that should not be continued indefinitely, because the risk of bleeding after 90 days outweighs the risk of stroke prevention. So this is, again, about very early treatment. This is about preventing another stroke. It's not treating an acute stroke. That already happened. This is a patient who is not going to get TPA for whatever reason, or be anticoagulated for whatever reason. This is how they should be treated. The other option is to do the aspirin and Plavix with the load.
Excellent. Thank you, Bruce. All righty. I'm gonna give the last presentation of the morning session. So we, let me share my screen. We went through, oops, not the screen I wanted to share. So we went through all aspects of stroke treatment. We started with the medical management of stroke. We went into neurointerventional management, surgical management of acute stroke, and then we went into secondary stroke prevention. And when it comes to the medical side, and now the secondary stroke prevention, the surgical side is what I'm going to discuss, and then give everybody a chance to get a little bit of a lunch break. So secondary stroke prevention, I'm going to focus a little bit on the role of carotid revascularization. Maybe there's some discussion about intracranial stenting as another option, or as another mode of secondary stroke prevention. But as Dr. Mearson mentioned, the Sampras trial has put that intervention a bit on the back burner, and we extremely rarely see it performed these days. So in this presentation, I'm going to try to describe the options of carotid revascularization for stroke prevention, discuss the evidence behind its option, and identify the current complex landscape for decision-making, and also demonstrate some innovative ways that we have to empower shared decision-making. So carotid atherosclerosis, everybody's very familiar with it, the buildup of plaque in the carotid bulb that can result in occlusion of the vessel, or a distal embolic event from the vessel, either by plaque rupture, which sends a clot into the brain, or atheroma traveling inside the brain. Two major treatment options these days. One is the carotid endarterectomy, where we open the neck and make a small incision, scoop the plaque out, and suture the vessel together, or carotid artery stenting, where we stretch open the blockage with a balloon and then inflate a stent to keep everything in place. Both great options, and I'm going to present the evidence behind them. Another option is called transcarotid arterial revascularization, where we do a carotid artery stent actually through the carotid itself. The added benefit of this procedure is that it allows us to reverse the flow down into the patient's femoral vein, and that way we don't have any forward flow transmitting emboli into the brain. So you decrease, this is pretty much a carotid stent with decreased risk of distal embolism. So really a spectacular procedure. This is what a carotid endarterectomy looks like. You find the vessel, you select all the components of the common internal and external carotid artery. You can use a shunt. Sometimes we can monitor to see if the patient needs a shunt based on their response from neuromonitoring. This is what the plaque looks like when you remove it from the body. And this is a patient where we have the shunt in and the plaque is removed, and the patient is receiving blood into their brain during the operation. So that's as compared to the stenting side, where you see this is a symptomatic patient. You see the blockage right here. This is after balloon angioplasty and stenting, and this is kind of what the stent looks like, this mesh that comes from the internal carotid all the way down into the common carotid artery. A lot less invasive, obviously, but the choice of the procedure is based on evidence. And I'm going to start talking a little bit about this evidence. So carotid endarterectomy is credited to Dr. DeBakey, a general surgeon. There's obviously, like with any procedure, there's dispute about who did it first and where they did it. Most people believe it was first done in 1953 in Texas, and it became very quickly an extremely popular procedure. And I'm going to talk a little bit about how that has changed over time. So in 2003, over 240,000 carotid endarterectomies were performed in the United States. Now, the evidence behind that procedure is twofold. One, it has to do with symptomatic patients, meaning a stroke referable to the same hemisphere as that perfused by the carotid in question, and asymptomatic patients where we don't have a recent stroke referable to that carotid. So we have level 1 evidence for, on the symptomatic side, over 50% carotid stenosis with a corresponding stroke, and a surge on morbidity and mortality rate during these procedures less than 6%. On the and you can see the trials below. On the asymptomatic side, we have level 1 evidence for over 60% stenosis and surge on morbidity and mortality less than 3%. Now, these numbers to some extent have changed over time, particularly on the asymptomatic side. On the asymptomatic side, without really necessarily clinical trials, but mostly through practice, we've moved that needle closer to 70 to 80% actually for asymptomatic patients. And there's a lot of other factors that come into play there. So we're a lot more conservative when it comes to asymptomatic patients because of the impact of best medical management and all the good things that Bruce and neurologists can do for these patients. So when we compare carotid endarterectomy and carotid artery stenting as options for treatment of symptomatic or asymptomatic patients, there's been multiple trials in the past. They have really innovative names. And so the most important thing from this table is to look at the mortality or I guess mortality and stroke risk from these patients. And you can see in these trials, the risk of stroke has been particularly high. Stroke or death has been particularly high because of the way the trials were designed and who was allowed to participate in those trials. So most of them are actually higher than what the guidelines are for allowing you to do these procedures. So one of the most important trials that actually put carotid artery stenting on the map was Sapphire. And it was the goal of the trial was to demonstrate that stenting is not inferior to carotid endarterectomy. And what it demonstrated on the primary outcome was that carotid endarterectomy was associated with 20% morbidity and mortality versus 12% for carotid artery stenting. And it was the patients that were selected for this type of procedure were high-risk patients. And I'll explain what high risk meant for the Sapphire trial. There's been a lot of criticism, obviously, for this trial when it came out. The major points of criticism were what defined high risk, right? High risk was really not defined as what we would consider high risk these days. 60% of the patients really went to a registry for carotid artery stenting, so recruitment was fairly problematic. MI was included as an endpoint, and initially that was considered as a point of contention. Then it became standard to include MI as an endpoint. And the morbidity and mortality was very high. You know, in the first 30 days, carotid endarterectomies had a 10% morbidity and mortality, really way outside the realm of what's considered acceptable. And there was no medical arm. So this trial got a lot of criticism, but it resulted in FDA approval of carotid artery stenting. And these are the criteria they used for high-risk patients. Now, these days, actually, these are high risk for carotid endarterectomy, and they were fairly arbitrary. Now, these days, we know that age over 80 years old is actually high risk for stent, not carotid endarterectomy. So the way this was done was not ideal. But again, that's how progress is made. It's sometimes messy. So this is the comparison of this trial, Sapphire trial, with the standard trials for asymptomatic carotid disease. intervention, ACST, and you'd see the medical arm of ACST and the surgical arm of ACST, and then you can see the Sapphire trial, and you can see how, with the red, how much more significant were those events from both endarterectomy and or stenting, annual revascularization. So again, this trial was fairly problematic in terms of the ability or the appropriateness of those interventions. As I said, regardless, FDA approved carotid artery stenting based on the results of this trial for over 50% stenosis in folks that are high risk for myocardial infarction. There's a follow-up study to that in 2008 that demonstrated that the secondary endpoints were very similar. The primary endpoints were similar of the long term. In 3 years out, there was really no difference for this trial for carotid endarterectomy and carotid artery stenting. Now, there have been some other trials. So this obviously trial initially said stenting is better. Long term, they're the same. Lots of problems with it. Not a lot of people pay a lot of attention to that anymore. Other trials came out favoring carotid endarterectomy. One was SPACE. The other was EVA-3S. Again, tremendous amount of morbidity and mortality with stenting here. And a lot of the criticism from the endovascular side was, well, you really didn't take into account the technical difficulties of the learning curve for carotid artery stenting, and you let pretty much everybody do it. At the time, it wasn't that routine. So we have to standardize who does those procedures. Put all those trials together. There was, at that time, it demonstrated that carotid artery stenting had a higher 30-day risk of the composite outcome, which included stroke and death as compared to carotid endarterectomy. Now, that murky landscape existed until the CREST trial came about, and that came about a few years back. And what it really, so CREST trial included both symptomatic and asymptomatic patients with the usual criteria. It was a really extensive trial. It recruited over 2,500 patients, and there was credentialing. That was very important. So if you had a center that did carotid artery stenting, and the criticism obviously was that this is a procedure that requires some ability to do and has a learning curve, they require that you had to have done at least 20 patients during the lead-in phase of the trial. So they were monitoring for that lead-in phase, and then you're able to do the regular procedures. And the primary endpoint included MIs, so MI, stroke, or death in 1 month, and eventually at 4 years. And there were a bunch of secondary goals too. One important take-home point from the lead-in phase of the trial that sometimes gets missed in the shuffle is how risky carotid artery stenting is for older patients. So patients over the age of 80, as you can see the risk in this table, you see the risk of the morbidity and mortality. Less than 60 years old is about 1.7%. When you're over 80, it's 12.1%. And if you look into nonagenarians, it was double that. And the reason for that is that, these are patients, as we get older, the vessels become a lot more tortuous. There's a lot more atherosclerosis in the arch, in the ostium of these vessels. It becomes very challenging to do these procedures safely. And these patients suffer a very large number of strokes. So really, the conclusion from the lead-in phase of the CREST trial was that we should not be doing carotid artery stenting in the elderly. Let me see. All right, Susan is asking a question. For patients who are at risk for carotid stenosis and symptomatic, what is the risk for stroke? And why are we waiting till the stenosis is 70%? So the reason 70% has been determined as the cutoff is that these procedures have a certain risk, and that risk is individualized. Obviously, every surgeon has their own case series, they have their own risk profile. As long as they're less than a certain number, 6%, 3%, depending on symptomatic or asymptomatic, then they should be able to do these procedures. Otherwise, obviously, the risk-benefit ratio is not there. In the clinical trials that established those criteria for 70%, for example, was chosen because the risk of complication was a lot less at that level as compared to the risk of stroke. And that's why we're waiting. If somebody has a 10, 20, 30% stenosis and the corresponding stroke, most likely that stroke is not from that carotid artery based on all those clinical trials. So now, based on these results of the lead-in phase of the CREST trial, octogenarians and nonagenarians were excluded further from the trial. And those were the results. As you can see, they're very similar in the composite outcome of stroke, MI, or death, both of them. But then if you look into a little bit of a more granular way, the periprocedural risk of stroke was higher with carotid artery stenting. As you can understand, when you cross a lesion, that's certainly the issue. And the risk of a heart attack was higher with carotid endarterectomy. So they kind of balanced each other out. Now, given the fact that disability is a lot more significant in the setting of a stroke, carotid endarterectomy became the first choice of treatment since this trial across the board, unless there's contraindications that we can talk about. And these would be prior surgery in the neck, radiation, issues that would make an endarterectomy fairly challenging, at which point stenting became the primary treatment option. And that was with the CREST trial. Folks continue to study the issue, and we have two new trials. One is the asymptomatic carotid atherosclerosis trial, ACT1, that demonstrate pretty much equivalence of stenting and endarterectomy in a matter of a year. And this was followed by another trial that was published in The Lancet a couple of months ago, the ACST2 trial. Those both for asymptomatic patients that demonstrated equivalence between stenting and endarterectomy with extremely low complication rates, definitely well below the 3%. We're talking 0.5 to 1.5 or 8% complication rate. So really spectacular evolution in our ability to treat these patients. Now, my criticism for these trials is that we do not, for the asymptomatic side, we do not have a best medical management arm. And best medical management is really, really phenomenal these days. And you can see how we do not have really an agreement about whether how we should treat these asymptomatic. And this is from New England Journal of Medicine. They did a survey of folks. They gave them a theoretical scenario of a 60-year-old male with asymptomatic carotid stenosis and a bunch of other risk factors. And they said, what would you do? And you can see that especially outside of the United States, there's a very strong preference for medical management for this patient. And regardless, I would say in the US, the majority would pick medical management, but in the rest of the world, the evidence wasn't there. So it's really interesting to see how people manage, especially asymptomatic disease. And it comes to show you that we need a clinical trial with a good medical arm, as opposed to the initial medical arms 30 years ago that just had aspirin. Now, regardless of all these trials, what we're seeing in recent years, and this is from a paper we published in the British Medical Journal, we're seeing this dramatic decrease in carotid revascularization. We're not just seeing decrease in carotid endarterectomy, we see decrease in stenting and endarterectomy. There's been a little bump in stenting when it came out, like everything was new and shiny, people tried it, but then whoops, then it followed the same route. And then if you look at it based by specialty, you see that pretty much all specialties are dropping. This is a procedure that's very popular with all specialties: vascular surgery, general surgery, thoracic, neurosurgery, neurointervention, cardiologists sometimes putting carotid artery stenting, radiologists. So everything is kind of dropping, right? So we really have only one trial saying that stenting is better than endarterectomy. Most other trials demonstrated equivalence at best. CREST showed us that there is higher risk of stenting, of stroke with stenting, higher risk of MI with endarterectomy. And so the decision needs to be tailored to the particular patient. And especially if you have the ability to offer both treatments, either in the form of transfemoral stenting or transcarotid stenting and or carotid endarterectomy, I think that's the best issue. Anatomy of the lesion should be considered. The higher the carotid bifurcation or the higher the lesion, the more challenging surgery becomes. Diagnostic angiography can be considered in challenging cases or when there's questions about anatomy. And on asymptomatic patients, as we said, the jury's still out. We really don't know if there is a good medical arm, how the outcome is going to be. CREST-2 is out there, is right now recruiting patients, and there will be a a medical management arm, and we're very much looking forward to that. But how do we guide our patients today in regards to making those decisions? They're not easy decisions. You know, if physicians can really, you know, talk to you for 20 minutes about evidence and not have a clear picture, you know, how do we tell our patients? Well, there's a lot of ways we can do that. We've studied this in the past. We've created predictive models where patients, through the touch of a button, this is from our publication in Stroke, but really we created this app in the past called NeuroRisk, where patients would have their procedure, where they would choose the complication that they would obviously worry about, and then there's a bunch of risk factors, and eventually you would get a number telling you what your risk of that complication is, or a range, and that can to some extent help us individualize those predictions. Obviously, at the end of the day, some procedures will be appropriate for some patients and some will not be for others, and the judgment of the physician gets into play. But I guess, but it's also very important to get patients engaged and get their take on that. And I think that's why apps like these would help. And with that, I want to thank you and see if there's any questions. All righty, excellent. So we will stop the morning session here. For those of you who want to continue, we will go on a bit of a 30-minute lunch break, and then there's another 30 minutes of lunch break seminars. There's going to be 3 breakout rooms with different topics of interest. For those of you who want to stay for the nursing care of the stroke patient, you can remain in this room. Do not log off. If you're interested in neurorehabilitation or identification of stroke in the field, I will put in the chat function, I'll put the 2 links to get to those Zoom meetings. Those are by Dr. McCannon and Dr. Bramante. When you're done with those meetings, click on the link that brought you to this meeting and you'll come back here. I hope this meeting is going to stay on for the duration. And I hope that's not too confusing for everybody. Let me see, I'm going to put that up. All right. So let me share this screen for everybody to have. All righty, so we're coming back at 12. For nursing care for the stroke patient, remain in this room. Bruce, thank you for a great morning session. We will disconnect, but the meeting will stay on, so you guys feel free to stay. I will be sending in the chat function the 2 options for the other 2 meetings. Thank you, Bruce.
Thank you, Kimon. This was excellent.
All right, you guys stay on. Thank you. Hey guys, we are connecting with Karen for her presentation. All righty, I'm just gonna pull up Karen's presentation.
Do you hear me?
Hold on, Karen. I'm going to share my screen. Here we go. All righty. Give us another 2 seconds to get the technology part for Karen all squared away. All right. Hello, everybody again. Small technical difficulties here. Hold on a second. All right. Perfect. So we have a little bit of a technical problem with Karen's computer, but that's okay. We will have her present. You will hear her. You're not going to be able to see her though, and I'll run her slides. All righty. So for those of you here for the nursing care for the stroke patient presentation, if you have any questions, if you have any issues with you cannot hear well or anything else, just respond to the chat section. Without further ado, I want to present our stroke coordinator at Good Samaritan Hospital and powerhouse when it comes to comprehensive stroke, Karen Antaki. She works day and night to make us better than what we are. And she's going to talk to you now. Her former role in the hospital before she became the stroke coordinator was a nursing educator in the neuro ICU. So she's very familiar, obviously, with this topic. And she's still doing a lot of education. She's going to talk to you about the care of the stroke patient. Karen, when you want me to go to next slide, just say next slide. Thank you.
Okay, thank you, Dr. Beckowitz. Hi, everybody. You can go ahead well, you know, I'll tell you a little bit about myself and my prior background. Prior to coming to Good Samaritan Hospital, I had worked as a stroke nurse at the bedside for several years before becoming a nurse manager of the neuro ICU. And then moving on to be a nurse practitioner with the acute stroke team, evaluating and managing stroke patients in the hospital, as well as follow up with neurology and stroke patients in the office setting. I did that before I joined the Good Sam team here, and been lucky enough to work with some fabulous people here at Good Sam. So I'm going to go over just in general care of the stroke patients, and due to essence of time, I'm going to focus on one particular thing that I think is very important, that we have a lot of new advances coming out in the care of the stroke patient. It's a continuously changing environment, and lots of things for the nurses to keep track of at the bedside. But one thing that remains consistent and will remain consistent throughout the care of the stroke patient, next slide please, is something that I consider probably the most important part in caring for the stroke patient. This is what I'm going to focus on today, and that's neuroassessment. I can't tell you and reinforce hard enough how important that neuroassessment is. And as a nurse at the bedside, you have probably the most important role in managing that stroke patient. So that neuroassessment is extremely important. And anyone that knows me that I'm a bit of a stickler as far as the neuroassessment and documenting that neuroassessment. Next page, please. So nurses really need to be kind of like an investigator. The brain is your perp. You're watching to see if they're getting worse. You're keeping tabs on all that it's doing, and you're intervening when necessary. Your exams need to be accurate, and neuro changes, they're not like vital signs or lab changes. Patients, you have to stay engaged with these patients. They seem fine, but unfortunately, patients can permanently lose neurological functions and die because of this. So increases in intracranial pressure or neurological deterioration, they're evident through the neuroassessments, not necessarily the vital signs. Pupillary and vital sign alterations, they're late signs. So if you're waiting for these to occur, or become concerned, you're missing crucial and possibly preventable items. When brain cells die, ultimately, they die, and unfortunately, we can't get them back. Next slide. Okay, so the overall neuroassessment is basically to see the best the patient can do with as little stimulation as possible. You need to look at how the patient acts, how they move, noticing what their hemodynamics are doing before you stimulate them. And we want to see the best they can do with the least amount of stimulation as possible. Observing spontaneous movement will provide us incredible insights into their neurological functioning. You want to know, is the patient awake? Do they open their eyes when you walk into the room? Are they speaking to their visitors? And if so, is the speech clear? Are they speaking in full sentences? Oftentimes we want to let them sleep because they seem like they're resting. You cannot let them sleep, and you can't defer your assessment because they seem to be resting. Patients that seem to be sleeping, they may be experiencing neurological decline, so we need to move quickly on these patients and stay on top of them, especially TIA patients, ischemic stroke, hemorrhagic strokes. All these patients, their neurological status can change quickly and in a very short period of time. Okay. So you want to go in, can you go to the next slide? Oh, back up a little bit. Back up. Sorry, you're going ahead. So your assessment really begins as soon as you walk in the room. You want to check their hemodynamics. Obviously, this is applicable if the patient's on a bedside monitor. Most of our patients here in Good Samaritan Hospital are on a bedside monitor, so you want to take note of their heart rate, their blood pressure, monitor those values before you begin your interaction. Obviously, you want to check their level of alertness. Are they already awake? Where you need to stimulate them verbally or tactily to get them to open their eyes. And then ongoing interactions. Is the patient able to sustain the interaction? notice their speech pattern, fluency, and abilities. Okay. Some of the first questions, obviously, when you go in to see a patient, you want to ask them, person, can you tell me your name? What's your full name? If there's people in the room, who are these people that are in the room with you? Location, we ask where you are right now. And sometimes patients have some speech difficulties, so we can offer them suggestions. Are you at home? Are you at work? Or you're at the grocery store? And then situation. I'll ask the patient, tell me what happened. How did you end up here at the hospital? Open-ended questions are best way to gauge patients' orientation and to gauge their speech. You don't want to ask close-ended questions where they can answer yes or no. And then time. You ask them, what year is it? What month it is? Lately, I've been trying to avoid who the president is. For some people are very passionate about that issue, and it can kind of deviate the neurological exam a little bit. So I avoid asking that question sometimes. Next slide, please. And obviously the pupils, the size, the shape, the reactivity, we can't avoid checking those as well. Also, extraocular movement. So you want to check for things like gaze deviation, if that gaze crosses the midline, if there's any type of visual field deficits. One thing I always recommend to nurses to really get to know what's going on with your patient, join in those neurological neurointensivist rounds, speak with the neurologist, find out by reading the CAT scan where exactly is the stroke. And sometimes I find it's helpful if you have time, open that imaging, take a look at the imaging and see where in the brain that stroke is. It'll help guide your neurological exam. One of the other tricks that I've learned along the way, especially with gaze deviation. The gaze deviation is usually the gaze in a stroke patient is deviated to the opposite side of the lesion in the brain. And for a seizure patient, the gaze deviation tends to be towards the lesion in the brain. I have Dr. Beckles on the line. Can you confirm that, Dr. Beckles?
I confirm it.
All right. I don't know. But one of the other things, if you extraocular movements are intact, the next thing that you don't have to do this, if they're able to move their eyes from side to side, follow your finger from side to side. If they do have a gaze deviation, you can do the blink to threat reflex. You can it's almost like you're going to poke the patient in the eye, but you don't. To see if they have any type of blink on the opposite side of the gaze. If they don't have a blink, you can assume that there's a visual field loss on that side. Obviously, facial assessment is a very important piece of the neuro exam. You want to look for symmetry in the face as well. Next slide, please. Motor assessment. The motor assessment, just a quick safety tip. When you're asking patients to squeeze your hand and then push and pull, just offer them 2 fingers to squeeze. If you offer your whole hand, you have a very strong patient, very strong grip. You'll get hurt in the process. And that's not fun for anybody. So you want to assess, obviously, arm drift. You ask the patient to raise their arms up, and you're looking, usually I ask both ways. You can ask the patient to raise their arms both out in front of them like they're holding a pizza pie. See if the arm drifts down. And then you might want to ask them, you can hold it straight out in front of you with your hand up. Holding them up with the palms up will also, you'll also catch a subtle pronator drift, subtle drift with the hand as well by doing that. Finger to nose assessment. So this one, we're really looking for that dysmetria, that discoordination. So you can have a patient who actually has very subtle discoordination, might be their only symptom that they're complaining of. They might have a very good, strong grasp and strong musculature, but when you ask them, and they'll tell you, you know, I'm having a very hard time picking up that glass of water or trying to get my hand to do what I want it to do. And then you ask them to do this finger to nose assessment, and you change the location of your finger each time they reach out for it. And sometimes you can pick up that subtle discoordination. Same thing with the legs. Oftentimes the patients will be laying in bed and we don't necessarily capture the discoordination until we get them up and walking. So this is something to be very mindful of with your cerebellar strokes. They might seem just fine when they're laying in bed, but when we get them up and walking, that's when we really see that discoordination when they get up and walk. And sensation. Sometimes sensation can be the only sign or symptom that the patient has, and that also can be very subtle. You know, you can ask the patient with their eyes open, you feel this, you feel this, you feel this, and they'll say yes, yes, yes. And then when you ask them to close their eyes, that's when you realize, you ask them to touch the left, you touch the left side, where am I touching you? They'll say left. And then you touch the right side, where am I touching you? And then you'll touch both sides, maybe both legs, and they'll only recognize only one side. And sometimes that can be very subtle. So don't skip checking the sensation side. And then Babinski, obviously, with adults, you're gonna take a non-sharp object and rub it up across the ball of the foot. The toes should point down. In an adult, if the toes fan upward, obviously this is an abnormal sign. Next slide, please.
Karen, 10 minutes.
Okay. And so, you know, I always get the question, do I really need to do all that? Yes, if you're working in the neuro ICU, yes. Okay. And take into account some of the things that may cloud the neuro exam. Fever, even a small rise in temperature can make someone's assessment look worse. Increased temperature increases the cerebral oxygen demand. So it's often common to see orders for physicians to treat a fever starting at 99 degrees. We want to keep that temperature low. Sodium, low sodium, hyponatremia can make people confused, lethargic, can certainly skew the neuro assessments. So if it's been over 24 hours since their last BMP and their sodium was borderline low when they came in, it's very possible now they have a neuro change, and it might very well be due to sodium. Blood pressure, obviously neuro patients are more sensitive to low blood pressure, especially in the setting of ischemic strokes. So know what your patient's normal blood pressure is. And also be aware of any sudden drop in blood pressure, especially following medication administration. Okay, oftentimes in elderly patients that have atherosclerotic disease that come in with stroke-like symptoms, they're very sensitive to the slightest drop in blood pressure. And as soon as we increase that blood pressure, you can see the neurological assessment improve in some of those patients. Hypoglycemia. Never underestimate the impact that a low blood sugar can have on level of consciousness. As we know, that can mimic stroke symptoms. All right, and seizure medications. Seizure medications, those anti-epileptic drugs, they can cause drowsiness, especially following a loading dose. So know which anti-epileptic drugs your patients are on, and know if this is the first time that the patient's on them. Pain medication. Pain medications, obviously they can cause the patient to be more sedated and obviously cloud the exam. So you'll find that neurosurgeons and neurologists, they're pretty stingy with pain meds, and rightfully so, because it can cloud the neuro exam and make it difficult to find out what's really going on with the patient. Next slide, please. So noticing subtle neuro changes. So you need to communicate to the provider what's going on with the patient when you notice neuro changes. So, for instance, early in the shift, patient would wake up and follow every single command you asked. Now, when you walk in, you have to shake the patient. He's following some commands, but it takes more encouragement from you, and he won't do everything you ask. Do you need to call the provider? Next slide. So ask yourself, is this a new finding? If you've been doing your neuro checks religiously, then you know if this is a new finding. Know if the patient's given any pain medications lately. Does the patient have a fever? What are the latest labs? And when was that last CAT scan or MRI done on these patients? All those things will help you determine really what's going on neurologically with the patient. Next slide, please. So this is just an example of some of the communication that you should provide to the provider. Mrs. Smith seems sleepier than earlier, really doesn't provide too much information. You want to give as much detail as possible when you're speaking to someone about the neurological exam. You know, what is it that's sleepier than earlier? What was the patient doing earlier? Well, she was responding to tactile stimulation earlier, or verbally responsive earlier, but now it's much more difficult to arouse her. I have to do tactile stimulation and she falls asleep right in the middle of me speaking with her. It gives a little bit more detail and urgency to the nature of the change. Next slide. And then last known well, extremely important. So if you're doing your neuro assessments in a timely manner and you're staying on top of them, you will know the last known well on these patients, especially that change of shift. I always reinforce TIAs, ischemic stroke, hemorrhagic stroke. You need to do that neuro assessment and change of shift at the bedside with the outgoing nurse and the ongoing nurse. You need to do the neuro check together so you know what's going on with that patient. And make sure you document your assessment findings. Ultimately, someone reading your charting should be able to recreate the patient's exam. They should be able to know what was the intervention that was done when you went in, if there was neurological change, and how did that patient respond to that intervention. Next slide. Ensure that your documentation reflects the change and exactly when the assessment was performed and when you notified that physician. I do legal reviews on the side for many malpractice attorneys, and I can tell you it does come down to documentation in those charts. You can be the best nurse out there, but if you're not documenting those neuro assessments and really determining what's going on with the patient, if it's not documented, it's not done. So, you know, you need to be able to see what's going on with the patient, and we should be able to see that when we open that chart and we look at those neuro assessments. Next slide.
I think that's it, Karen.
Yep, that's it.
Excellent. That was a spectacular talk, right on time. Do we have any questions from the audience, maybe especially the nurses that are logged in? I know a lot of the nurses. So what is the what do you have in terms of nursing education right now, Karen? You have is it the neuro component? Is it done in the hospital every time we have nursing orientation? These issues being addressed?
As far as nursing education, we have general nursing education, and Barbara Timpog is the neuro ICU educator. She's involved with general nursing orientation when the nurses go to the neuro ICU. They receive a whole neuro refresher course. That's done every year, actually. There's a neuro refresher course that the nurses can attend.
Gotcha.
I'm involved with the critical care orientation I do a whole lecture on our acute stroke code process.
Right.
And then also with the emergency room nursing residency program, there's a whole section on caring for the neurological patient with all the different neurological diseases and how the patient can present with those neurological diseases. So we have a lot of different offerings as far as educational opportunities. And I usually, I do in-services frequently as well with the emergency room nurses, the nurses on our stroke unit and our ICU as well.
So Karen, two quick questions. One from Susan Borelli. Hey, Susan, it says, please elaborate on assessing a patient who's mentally challenged or confused for the nursing side.
So again, that goes back to what is the patient's baseline. So if you have a patient who comes in that's mentally challenged, that's something you want to try and find out from the emergency room, the initial assessment that the patient arrived with. If possible, if there's family members in the room, oftentimes with these mentally challenged patients or extremely confused patients, there's oftentimes family members that are requested to be in the room. And those family members can definitely offer insight into what is going on with the patient. I know during acute stroke codes in the emergency room, oftentimes we're on the phone with family members asking to see, speaking to family members, please tell us what is the neurological baseline on patient. And that is very helpful to determine if there's any new change.
Right. That's great. And also Susan Fogarty made a comment. She says, great presentation. Would we be able to use this on the Catholic Health Academy for our staff?
Absolutely.
All right, good. So you can be in touch with her. All right, great. So as people are coming back in from the other seminars, I know that the Dr. Bramante seminar is over, so people will be trickling in, and Dr. McCannon's should be over very shortly. So I'm gonna do a few introductions. So this, so in the morning, as you know, we spoke about ischemic stroke. This kind of the lunch seminars addressed a couple of idiosyncrasies in stroke care, either in rehab or nursing side, or also the EMS side. And now we're gonna kick off our afternoon session on hemorrhagic stroke. We will, the whole session will be moderated by Dr. Ahmad and myself. Dr. Ahmad is the co-director of the Neuro ICU at Good Samaritan Hospital and expert neurointensivist. He will be speaking later today. Javad, thank you for joining. I want to introduce our first speaker who's going to kick off this part of the meeting today, and somebody who is a close friend, and we've known, and a friend of our program, I think, and we've known each other for over 5 years now, and that's Todd Crawford. So Todd, thank you again for coming. He's a busy man. He travels the country, and I'm not sure exactly where we're finding him, but certainly I'm happy that we're able to have him join us. Todd, a lot of you have heard me talk about the Lisa Colagrossi Foundation and the work that they've been doing, but Todd is a remarkable human being. He took a inconceivable personal tragedy and turned it into the power to change the life of others, and really to change the way we do things on the brain aneurysm side of neurointervention, because none of us is really good at marketing, but Todd really distilled it all down to what matters and created very powerful messages that have received a lot of awards and a lot of recognition, and certainly a tremendous job in this field. And his foundation's events have been one of the most talked about event of the year, when we had the ability to get together as human beings and celebrate And so unfortunately, that hasn't happened in a couple of years, but we're certainly optimistic looking into the future. We tried to go in person this year, Todd, but unfortunately, the 200 to 300 people attendance was something that scared a few. But I'm sure that next year we will be back into normal mode. Anyway, long-winded introduction, but again, Todd is one of those forces of nature when it comes to getting the message through, when it comes to brain aneurysms. He's very passionate about it. He's lived it. And I'm going to let him talk a little bit about his story and also all the new and exciting things that the Lisa Foundation is working on into the future. Thank you, Todd.
Sure. How are you?
Good.
You can hear me? Everybody can see me?
You're good.
Okay, good. You'll find me, I'm actually in very exciting Cleveland, Ohio right now. Very exciting. Mistake by the lake. I'll be here for the next few months, but in way of background for those of you who may not know, the foundation is we turned 6 years old this month. The foundation was founded after the passing of my wife, Lisa Colagrassi, who was a very well-known media television personality for ABC News and People Magazine and Us Weekly, and those magazines named her one of the top 50 most famous people to die in 2015. So 6 months after her passing, I decided to leverage all the media hype, and her passing made news headlines around the world, and she had experienced a couple of the major warning signs for weeks leading up to her catastrophic rupture, and we had no idea. And so in the weeks and months after her passing, I just basically sat and thought and asked myself, how is it in today's world with social media and, marketing and public relations and everything out there, I can turn on the TV or the radio and I can, run into ads for Tunnel to Towers Foundation or the, Park and Michael J. Fox Foundation or St. Jude's or whatever it may be. And I've never heard of a brain aneurysm, let alone what some of the, warning signs and symptoms of an impending rupture might be. So it was with that I kind of set out and was the catalyst, served as the catalyst for the forming of the foundation. And in the last 6 years, we've had, as Kimon said, we've had a number of accolades and awards, which are great, but that's not why we exist. And we're proud to say that, we've had more impact in the space and improving lives and saving lives than anybody else over the last 6 years. And that's why we're here. So the mission of the foundation is to basically create a national dialogue around the country between people, families, mothers, fathers, about brain aneurysms. And the way that we do that is through mass marketing and promotional campaigns. So we have been very engaged. We've, created and implemented, launched a number of industry firsts that had never been done before. We've created the very first set of signs and symptoms icons to represent the warning signs that people can use and that, we promote and people have borrowed from us to put on their websites and help market, hemorrhagic stroke and brain aneurysms specifically. We have launched 2 national public service announcements on national television in the first 5 years, the most recent of which was with Whoopi Goldberg, who lost her brother about 4 months after my wife passed away, but she also lost her mother to a brain aneurysm. And so the foundation is very near and dear to her heart. And she was gracious with her time and to help us produce that public service announcement. We, as Kimon said, we've had an annual gala in New York City that has been, the talk of, the town and has really been given a lot of praise and compliments from even the most seasoned, gala fundraiser goer in terms of the event that we put on and the quality of our, event and entertainment and everything that happens that evening. So hopefully we can get back to that someday. We've been involved with, we have a number of ambassadors, from professional sports and other areas who have either have personally been impacted by brain aneurysms, either, survived one themselves or have lost a loved one to brain aneurysm. So people from the NFL, from the NBA, from entertainment, who have endorsed and embraced the efforts of the foundation. Joey Gase, who is with NASCAR, for example, comes to mind because he lost his mother 7 or 8 years ago. He's a really great kid and spokesperson for the foundation. And we just a few weeks ago sponsored his car at a race at Michigan International Speedway, and have experienced a lot of on-track success with him by doing that, and as well as some other a lot of other media interviews and opportunities that come along with that. So he's just a really terrific ambassador for us. So those are some of the things that we have done in the past, Kimon. I mean, the thing that, we're excited about that comes to mind right now that we're working on is in terms of public service announcements. We're in the very early stages of development of our third public service announcement, which will be aired on national television across the country. And this one, we have taken a very different approach. The first two focused on signs and symptoms broadly. This one is really different in the sense that we've decided to, with the advice of and consultation of our medical advisory board, have really decided to exclusively focus on worst headache of life. And we want to enter the headache conversation nationally, just headaches in general. So as people experience headaches, whether it's just a regular daily headache, from the stress of life or whatever it may be, or a migraine, worst headache of life needs to be involved in that conversation. And so that people begin to understand what that means and how different it really is from any other type of headache. And we've chosen to do this public service announcement also in a different way because we are actually going to use, we haven't identified them yet, but are in the early stages process of doing so. We're going to actually use testimonials from actual brain aneurysm survivors who experienced worst headache of life, who will be on camera using their own words in terms of, how it felt to them. So we think that this is going to be a really exciting and a game changer in a sense in terms of awareness and education for brain aneurysms in this country. And we are proud to and honored to be leading the way.
That's fantastic, Todd. And for those of you who haven't seen the public service announcements from the Lisa Foundation, they are spectacular, and they're very powerful in terms of message. They're simple but powerful in their simplicity. And it's interesting that, for medical fields that have been around for a very long time, we haven't been able to communicate those messages with such clarity. So I think what you're describing is definitely going to be extremely impactful and definitely engage all of us. Maybe you want to share a little bit about the work that you've done and that you're continuing to do with survivors and support groups, because I know that that's obviously the message is important, but the healing component, if there is such a thing, and obviously you know it yourself, in terms of the impact to the families and the impact to the patients themselves, even if they look great clinically, right? There's still a significant amount of healing that happens that probably never really stops for them. And I know that you're very passionate about survivor groups and support groups and things like that. If you want to tell us a little bit more about it.
We are. It's honestly not our main focus right now, Kimon, because we are very relatively new, foundation, still in our infancy, just turning 6 years old, and the crux of our focus, because of limited resources and staff, is awareness and education. And we would love to get into some of these other areas in a bigger way, because we know how critical they are, and support, being one of them. So we have an online Facebook support group, which we have found to be very successful, and one of the easiest ways to communicate, with survivors and help them address, whatever, ongoing debilitative issues, they're facing from, during their recovery from their rupture. We're affiliated with a handful, or a little more, probably 10 or so groups around the country that have reached out to us and asked to align themselves, with us. But we really, our focus is in terms of the best way that we can help these people, honestly, and we'll get there. It's just a matter of time, is through our medical advisory team. And I just stepped away from running the day-to-day of the foundation within the last few months. My goal, from day one, was to establish and create this foundation that was independent, fully transparent, very, the most credible in the space. No family members, no friends, no, nothing like that involved. And one of the people that I ran into early on through my, networking and just, kind of chumming the waters for people out there who might, have an interest in getting involved, was a young lady who was a survivor, who runs United Way in the state of Illinois, named Debbie Bogle, and she is absolutely terrific. And I remember my first phone conversation with her, and we're talking about, what she was still dealing with in terms of, her neurological issues, even though she's beautiful and looks, like she's just fine, and, goes to work every single day for United Way. We were talking about, the fatigue and the, PTSD and the other neurological issues that she struggles with, memory loss, and, on a daily basis. And so, I hung up the phone, we had, I think, a 3-hour introductory phone call with one another, which was really amazing. And I was on a road trip out in Irvine, California, to meet with the medical device companies. And I hung up the phone and I sat back in my chair and said, I think I've found my replacement, which was the goal from day one, to, at the right time, to kind of pass the baton to somebody who could help take the foundation and ratchet things up, so in a meaningful way. So we're thankful and blessed to have Debbie run this organization. She's the only brain aneurysm, it's now the foundation is the only foundation that is run by an actual brain aneurysm survivor, which we think is really important. But we are, in speaking with Debbie the last few months, she really wants to add and grow our medical advisory board team to include specialists that, deal and work in that field on a routine basis. So we're in the process of adding, people right now, and searching for people. We just added someone who is on the administrative side at Robert Wood Johnson Hospital in New Jersey, but she is a nurse, by trade, and runs the entire neurological or neurovascular team, I should say, at RWJUH, Judith Lane. And so she has joined our medical advisory board and board of directors to, and is going to be somebody that we will consult and have a lot of input in terms of the growth and focus, increased focus on survivors and dealing with those issues as a foundation going forward.
Yep, that's absolutely fantastic. I mean, it's remarkable that you were, as a foundation, you're so focused on the mission that even the leader of the foundation now is a survivor, a brain aneurysm survivor. And the other thing that maybe we want to share with the audience and that we're doing and you gracefully have endorsed is the screening that's organized. Obviously, it's September. It's Brain Aneurysm Awareness Month. This was the month where the foundation used to have their your gala, to honor that month, we've developed this program of free screenings for the 4 weekends of the month, where people get pre-screened through the office. They call, they express interest, and we, based on some risk factors and family history and other stuff, we screen them then with MRAs, which is obviously a simple tool to identify brain aneurysms. The yield on the general population may be low, but if you are able to discover one person before there is fatal rupture, obviously you've made a difference. So this program started for the first year this year, and we've had tremendous participation from the community. There's a lot of interest. A lot of folks have been screened already, and it's ongoing. So I maybe circle back with the results, but we very much appreciate the support of the Lisa Foundation in that initiative.
And we need more people to join, the efforts of you and Good Samaritan, Kimon, across the country to do this. I honestly, and I'll just speak off very frankly and off the cuff here for a minute, stepping into this space and my background as a former executive in sports and entertainment with the Walt Disney Company and ESPN and ABC Sports and many other sports properties. This was all new to me, but it's all common sense. It really is. It doesn't matter what background or what industry you come from. Stepping into, you can apply my skills and experience to any industry, any space. And this was really eye-opening to me in the months and weeks, in evaluating what I wanted to do and launch the foundation after Lisa's passing. And in the last, several years, because there's so many things that need to change. There really are. Right. And I think in terms of hemorrhagic stroke, we're at a little bit of a disadvantage because this is lumped in with ischemic stroke in terms of category. And right. This is very different. And even the way that we talk about this, we've had this condition and brain aneurysms have not been properly and aggressively addressed and marketed throughout the country like other conditions. And so we've taken a completely different, stance on that with the help and consultation from our medical advisory board. For example, I just give you one, the 1 in 50. It's not 1 in 50. I'm telling you right now, for anybody who is on this call right now, it is closer to 1 in 20. My wife, for Lisa, undeniably had a catastrophic category 5 rupture, which has changed our lives forever. Okay. Her death certificate says cause unknown. So she's not included in the 1 in 50 number, right? And we've heard from so many other people across the country, and we've had some really good dialogue with the NIH, people at NINDS over the last couple of years. And they used to market on their website the condition as affecting between 2 and 5% of the US population. Well, the 2% is 1 in 50, the 5% is 1 in 20, which is what we've gone with from day one. That's a very big difference. Right. So through our efforts and conversations with them in the last couple of years, they have gone back and consulted their advisory board of neurosurgeons and neurologists, and they have upgraded it as a result of our efforts and dialogue with them, to now 3 to 5%. So it's a big thing. It may seem like it's a small thing. It's not. It's a big thing, you know, because these other conditions out there, whether it be breast cancer or Parkinson's disease or diabetes, they all aggregate the numbers, and it's how you project and market it to, you know, mom and pop and families across the country as to whether or not they're going to heed the warning, you know, and the message that you're projecting to them and listen. Because if you downplay it, they're just gonna tune it out, because they're gonna say, why should I care? It doesn't affect that many people. It's not going to affect me. So anyway, I just, you know, we've got a lot more work to do in this industry across the board, from hospitals to emergency room, you know, to EMTs, to medical device companies. Everyone needs to become more engaged and more proactive and more involved in this effort, including the societies, you know, AANS, SNIS. Things need to change, and we're trying to bring about and foster that change, and could use, you know, everybody's help.
Great, thank you, Todd. Todd and I can go on and on and on for hours, but in respect of the time and the time allotment, I want to thank him now. Again, Todd, thank you for all the hard work you've done and you continue to do, and for all the inspiration that you offered to all of us. And thank you for endorsing a lot of the activities we're doing. I'm sure we'll be in touch, and I'm looking forward to some more in-person stuff as we're going back into the normal world, hopefully.
Absolutely. My pleasure, Kimon. Thank you.
Take care, Todd. My pleasure. All right. So back into more boring stuff now. Let's see. Now, the next presentation actually does not fall under that category. Dr. Ahmad introduced him a little earlier. He's the co-director of the Neuro ICU. He's a neurointensivist, neurologist by training, very much an expert in critical care, and a resource for all of us when it comes to the decisions on stroke patients. He's going to be talking more on the critical care management of the hemorrhagic stroke patient, which is the most challenging patient when it comes to critical care management. And I'm going to turn it over to him. First, Javad, do you want to share your screen, or do you want me to run your slides?
Do you want to run my slides for me?
No problem with that. 2 seconds. Very good. Here we go. All right, take it home.
All right, so my name is Dr. Javad Ahmad. Kimon introduced me. I'm the co-director of the Neuro ICU at Good Samaritan Hospital. We'll be speaking today about the critical care of hemorrhagic stroke patients. We'll start with the outline first. So go to the next slide. Just a quick outline of what we'll be speaking on. We'll be speaking about the definition, risk factors, etiologies, how to diagnose an ICH or intracerebral hemorrhage, management, and we'll touch upon a few trials as we go along. Next slide. So this is a picture on the right showing an intracranial hemorrhage, and there are different types of hemorrhages that we find. The two hemorrhages that you see in the front is an epidural hemorrhage and a subdural hemorrhage, respectively. Those types of hemorrhages are usually caused by trauma. Today, we'll be speaking more in detail about the hemorrhage in the back of the brain. Kimon can point that out, and that's intracerebral hemorrhage or interparenchymal hemorrhage, and the management of. We also have, been speaking extensively about subarachnoid hemorrhages as well. And those most common causes of those types of hemorrhages are trauma, and of course, as we spoke about, aneurysms. So we'll forego that, and we'll speak about the interparenchymal hemorrhages for this talk. Next slide. So the incidence of ICH, even though ICH represent only 10 to 15% of 700 strokes annually in the US, that percentage continues to grow. So approximately 50 to maybe 80,000 strokes or intracerebral hemorrhages at this point. It's projected by the year 2050 that incidence will increase to maybe 100 to 150,000 patients. So the incidents are definitely increasing, and that likely is due to the fact of more increased risk factors, which we'll touch upon as well. And that probably is the next slide. Now, the risk factors of ICH. The two most important risk factors that we do touch upon quite often in the neuro ICU are hypertension and cerebral amyloid angiopathy. And that's just the fancy way of saying proteins that are placed in the media adventitia of blood vessels, causing your blood vessels to be, I guess you can say, weakened and compromised. Other risk factors that we take into consideration when we see a patient in the neuro ICU are if they're on anticoagulant therapy, antiplatelet therapy, especially age. As you grow older, your vessels are a little bit weaker in your brain as well. Race also takes a part of the conversation. Male, gender, some genetic factors, as we know, of ApoE2 and A4, which are associated with increased dementia risks, and as a result, increased beta amyloid in your brain as well, and liver pathology. But again, it's important to know that the two most important risk factors that we most likely will be touching on today's presentation will be high blood pressure and this amyloid protein. Again, the etiologies of ICH, there's different etiologies. There's primary etiologies, which are spontaneous hemorrhages in the brain. And again, the two most common causes are high blood pressure and cerebral amyloid angiopathy. And we'll touch upon that. Other causes, primary and secondary, are acquired coagulopathies when patients are on anticoagulants or any type of thrombolytic therapies. Drugs can also be cause of ICH, cocaine, amphetamines in particular. Underlying neoplasms that can bleed are quite often seen as well. And those common neoplasms are usually melanoma, renal cancer, lung cancer. Like Kamon touched upon, vascular lesions are also cause of intracerebral hemorrhages. Again, aneurysms, AV malformations, which are an abnormal connection between arteries and veins in the brain, fistulas in the brain, small little cavernous venous malformations in the brain can also bleed as well. And other rare causes of ICH, which we won't touch upon, are vasculitis, which is inflammation of the blood vessels, other types of aneurysms, and other vasculopathies like RCVS and PRESS as well. Can go to the next slide. So it's important to realize this slide is important because this shows you the mortality of this stroke subtype. Again, it's this type of stroke subtype seen in 10 to 15% of the population, but the mortality is quite high if you compare it to the ischemic strokes. The 6-month mortality is 30 to 50%, while the 1-year mortality in these hemorrhagic patients is 50%. It's important to know that 20% of these ICH patients are independent at 6 months as compared to 60% for ischemic strokes. The graphs on the right side also delineate that as well, that majority of strokes are, again, ischemic strokes, and only 12% are hemorrhagic strokes in this slide from the AHA, but majority of the mortality is from the hemorrhagic strokes. Again, it's very important to realize that. Now, in particular for hypertensive ICHs, there are common locations for these ICHs, and the most common locations are shown. The basal ganglia is one of the most common locations. 50% of patients can have a hemorrhage in basal ganglia area, more specifically the globus pallidus or the putamen. And that's the first slide. That's A. B shows the thalamus, with thalamic bleed. C shows subcortical type of stroke with IVH, with intraventricular hemorrhage. And the other hemorrhages are shown in D, which is pontine hemorrhage, which is in the brainstem. A cerebellar hemorrhage, which is E, and F is a lobar hemorrhage. Each of these hemorrhages usually around 10 to 15% of all intracerebral hemorrhages except for the basal ganglia hemorrhage, which is the most common, around 50 to 60% of times. Next slide.
Javad, there's a question. Can a subdural hematoma from Susan Borelli? Can a subdural hematoma potentiate an ICH? I assume it's whether it can turn into an ICH or the other way around.
You can have a subdural hematoma with an ICH. Usually if there's some type of trauma, or if there's a big aneurysm, you can absolutely have not only subarachnoid blood, you can have ICH with a subdural as well. It's all about the mechanism of action at that point.
Great, thank you. Sorry.
Absolutely. Second most common cause of ICHs that we do see in ICU is cerebral amyloid angiopathy. Like I explained earlier, amyloid angiopathy just speaks of these proteins that are seen in the adventitia media of the blood vessels in the brain. It's seen in patients that are usually older than 70 years old. It's associated with dementia, and the recurrence risk is quite high in these patients as well, around 5 to 15%. The MRI on the left and the CAT scan on the left show that these hemorrhages are usually more cortical and bleeds, more cortical. They have a decent amount of edema around the hemorrhage. Kamon can outline that as well on the left. And then if you check the right picture, which is an MRI, these type of bleeds also incur microbleeds, small little bleeds on the right side of the brain. They're throughout, and as you grow older, if there's a high propensity of developing these bleeds, you'll develop more and more microbleeds as time goes by. Next. So the diagnosis of ICH, the two ways of diagnosing ICH besides neurological exam, it's important to make sure that you see the ICH. So CAT scan or MRI are both first choices for diagnosing an ICH. Again, however, CAT scans, of course, quicker to get and quicker to perform. The good thing about doing an MRI in some of these patients, more specifically lobar hemorrhages, is to elucidate underlying or secondary cause, like a malformation or underlying mass, if there's suspicion. This just speaks the same thing as before, that the rapid neuroimaging with a CT or MRI is recommended to distinguish an ischemic stroke or an ICH. Next slide. So now it's also important to figure out predictors of outcome. What places patients at increased risk of mortality and morbidity? And these are the important predictors of outcome: the volume of the hematoma, the Glasgow Coma Scale, which we'll touch upon in the next slide. If there is IVH or not, intraventricular hemorrhage, the age of the patient greater than 80, ICH location as well, and if there's global cerebral edema. Sometimes hemorrhages are so big that they can cause edema throughout the whole brain, not just one particular side. So if we go to the next slide shows okay, the next slide. So this is the ICH score. This is a scale that we use in ICU that predicts the mortality, a 30 mortality in patients with ICH. The higher the score, or the closer it is to 6, the higher the chance of mortality. Once you get to 6, it's almost a 97 to 99% chance of mortality. So if you add these scores up, the higher the score, the higher mortality. Again, like we said, age greater than 80, you get 1 point. Infantitoid origin, meaning if it's lower in the brainstem area, you get 1 point. IVH, you get 1 point as well. The greater size of the volume, greater than 30 ml, you get a point. And based on your GCS or the Glasgow Coma Scale, the worse the GCS, you'll get a couple of points as well, 1 to 2 points. So that's fine. The Graves score we can forego. That's just a score for an IVH itself. Again, like we said, IVH, intraventricular hemorrhage, is its own independent risk factor for worsening morbidity and mortality. So we can skip that for right now. Next point. Next slide. So importance of these scores. Yeah. These scores are important because they help us as doctors and nurses to prognosticate these patients and discuss important life-saving or life-changing discussions with their family members. And they also help guide us in how aggressive we'll be with treatment or no treatment. In 2010, the AHA guidelines recommended that aggressive full care early after ICH onset be established, and postponement of a DNR wait for 1 to 2 days at least before approaching family for prognostication and such. So now we'll go into therapy, and the goals of therapy are important to understand as well. The goals of therapy being supportive therapy in the management of complications in these patients with ICH, prevention of hematoma expansion or the prevention of the bleed itself, hematoma removal if need be, ICP control or intracranial pressure control if we feel like that's necessary, and long-term care and prevention. So now if we go to the next slide. This slide just shows and delineates the fact that the ICH mortality rate is reduced in patients who are admitted into neuro-ICUs. As you can see, that aqua line shows that the cumulative survival rate in these patients who are taken into a neuro-ICU is higher than, say, a regular general intensive care unit. So it speaks to the fact that we have, I guess, good knowledge and understanding ICH as well as our intensivist counterparts. Now, the management of ICH in the emergency department is important because that's when someone's diagnosed with an ICH usually, right? So if you suspect an ICH, patient has a neurological exam, patient's lethargic, comatose, or if there is any question about that, a brain attack activation or code stroke is called. At that same time, the provider will see the patient, check the ABCs, airway, breathing, circulation. Patient will have IVs placed, oxygen will be placed, or the patient, if need be, will be intubated at that time. At that time, a CAT scan will be done, and if there is CT evidence of an ICH, the goal is to decrease the blood pressure. We'll be focusing on that in the next few slides. The different ways that we can do so are by giving injection of medications like labetal or hydralazine, or we can start a drip to decrease the blood pressure like Cardia as well. It's also important to reverse any coagulopathy, and if there's surgical indications, then neurosurgery will be involved at that point. Ultimately, most of these patients will be admitted into our neuro-ICU. Next slide. Again, like we touched upon earlier, just the slide before, it's important to prevent hematoma expansion or the expansion of the blood itself. And in order to do so, the first and foremost important aspect is blood pressure control. Second, if the patient is on any type of thrombotic therapy or antithrombotic therapy, it's important to reverse that medication. And plus or minus, if patient has increased cerebral edema or if there seems to be an ICP crisis, we usually give mannitol or hypertonic saline. So now for the blood pressure management in ICH, these are two trials that speak of the blood pressure parameters that we employ in the neuro-ICU, the INTERACT-2 trial and the ATAC-2 trial. You can probably go to the next slide, come on. This is a trial, this is the ATAC-2 trial that shows that 1,000 people were randomized to 2 arms, an intensive systolic blood pressure group, systolic blood pressure point of less than 140, and the standard systolic blood pressure reading of 140 to 180. And the ways that they continue to manage those patients and see the morbidity and mortality in those patients. If you want to go, you can go to the next slide so we can see the guideline statement. So given the finding from the INTERACT-2 and the ATAC-2 trial, the 2015 update to the guidelines for managing spontaneous ICH recommends that any patient that presents with blood pressure between 150 and 200, acute lowering of SBP to less than 140 is safe. Now, if a patient presents with systolic blood pressure greater than 220, the acute lowering is less clear, although aggressive blood pressure reduction with intravenous infusion is reasonable. Now, the question is to how low. Usually in our practice, we attempt to get to the blood pressure around 140s as well in patients with blood pressure greater than 220. Again, risk factor being acute ischemia and issues with kidneys as well for AKI. Again, acute lowering of blood pressure must be done early, must be done quickly, and must be done definitively as well. This is just a slide showing the reversal of coagulopathies and what antidotes we use. So we can go to the next slide as well. The PATCH trial is about patients who take antiplatelet medication, and it was a trial done around in 2015 or so for patients who take antiplatelet medications and then develop an ICH. We can go to the next slide to show exactly how the trial was done. So there were 190 patients enrolled in the trial, 190 were randomized, 97 who received platelet transfusion to reverse the antiplatelet effect of aspirin or Plavix, and then there were also 93 patients who were randomly assigned to the standard of care. So at the end of the day, the guideline statement, the next slide, we can go there as well. Again, so this is what I just explained as well about the 180 enrollment of patients, and the conclusion of the trial show that platelet transfusion was actually inferior to standard of care for people taking antiplatelet therapy before intracerebral hemorrhage. So therefore, patients who have a big ICH and are taking some type of antiplatelet, it may be less beneficial to give these patients reversal, secondary to the fact that there's an acute inflammatory response due to the platelet reversal. Now we're at the best management for best outcomes, management of perihematomal edema. Data from several clinical studies indicate that the increase in the edema around the hemorrhage itself during the first 24 to 72 hours was associated with worse functional outcomes at 90 days. And the goal is to decrease that edema as best as possible. And the next slide will show us what we can employ. So it's important to decrease this perihematomal edema development. And the way that we do so is by decreasing possible ICP elevations and maintaining adequate cerebral perfusion pressure or pressure to the brain. So the way that we decrease ICP in a lot of these patients is that we do the simple things. We enhance venous drainage. We keep the head of the bed up. We make sure that their neck is midline. If they are in a cervical collar, we check if it fits correctly. And then we'll touch upon hyperosmolar therapy in the next slide and any type of drainage. It's important to know that patients with asymptomatic edema around the hemorrhage require no specific treatment. All they really need is a normal sodium goal, and if there's no indication or routine use for mannitol, they don't need it. So now if the patient's hemorrhage is quite big and the edema around it's quite big and it's causing worsening symptoms, or the practitioner feels like it's causing worsening symptoms, or if there's elevated pressure in the brain from, say, an EVD, and we're monitoring the pressure, then we can use first-line therapies like mannitol and high concentrated saline. So in real world practice, the patient's medical history and side effect profiles of mannitol and hypertonic saline are the major factors of why we choose one drug over the other. There has always been conversation between mannitol versus hypertonic saline. At the end of the day, it's individualized. If the patient's blood pressure is quite high, say in systolics of 180s, you may want to choose mannitol as mannitol is an osmotic diuretic, and it may work quickly to decrease the blood pressure, as opposed to hypertonic saline, which in fact actually increases the plasma osmolarity, which increases the blood volume. As a result, someone who's hypotensive may benefit from hypertonic saline. And then when it comes to external ventricular drains, interventricular hemorrhages occur in up to 45% of these ICH patients. So it's associated with lower GCS and an independent predictor of poor outcome. As a result, our neurosurgeon colleagues will place EVDs or external ventricular drains in patients who they consider need it, who have big IVHs, who have hydrocephalus or increased growth of their ventricles in their brain, or if their GCS, if their Glasgow Coma Scale is less than an 8, it would definitely benefit the patient in having a drain in the brain. Next slide. Now, as for surgical necessities, cerebellar ICHs are considered a neurosurgical emergency. Evacuation is recommended per current guidelines given the high morbidity and mortality of this type of intracerebral hemorrhage. The reason it's considered a surgical emergency is because the back of the brain is a very tight place. As a result, even if a small hemorrhage is there, the associated edema with the hemorrhage can have disastrous effects on the brainstem. So surgical indications may be hematoma size greater than 3 centimeters, if there is any type of brainstem compression, which is right in front of the cerebellum, or worsening hydrocephalus. Next slide. Now for seizure management in these patients, we don't actually find much support for routine prophylactic anti-epileptic drug use in ICHs, especially for subcortical hemorrhages deep within the brain. Now, if the hemorrhage is quite big and is cortical, and there may be some IVH associated with the hemorrhage, we may start the patient on anti-epileptics for 3 days, up to 7 days at the max, as long as there's no seizures. If the patient does come in with a seizure or develops a seizure during the hospital stay, then we definitely employ anti-epileptics at that time. It's also important to understand that continuous EEG monitoring should be considered for all patients with ICH and a depressed mental status out of proportion to degree of brain injury. In other words, if the ICH is a small size, but the patient is comatose, then those patients should be on a continuous EEG, as there may be another cause as to why their mental status is depressed. And it's also important to realize the small things, but the important things as well. It's important to control the glucose, make sure the finger sticks are between 140 and 180. It's important to also realize, and if you don't get anything out of this lecture, the most important thing to realize is steroids are not a treatment for cytotoxic cerebral edema. We do not give steroids to these patients. Again, it's always important to start nutrition early, and we can start chemical DVT prophylaxis with heparin sulfate or Lovenox within 48 hours after a stability scan of the hemorrhage. I think that's it for me.
That's fantastic. Thank you, Javad. That's a really spectacular lecture outlining the neurocritical care management of intracerebral hemorrhage. Now, I know that there's a lot of discussion, as you said, on mannitol versus hypertonic, and we generally use mannitol. I don't think that we've used hypertonic a lot in our neuro ICU. in regards to the way you practice, do you prefer mannitol for one particular reason, or it's just for ease of use in our institution?
I think there's multiple reasons of its ease of use and side effect profile.
Okay.
Yeah, the side effect profile of, I guess, mannitol is less so as compared to hypertonic saline. There's more incidence of pulmonary edema with hypertonic saline and quick flash pulmonary edema, which we see in our patients if we do employ hypertonic saline.
Right. Perfect. Thank you. All righty, perfect. So Javad, I'm going to ask you to stay on to moderate with me the next couple of talks. And with that, I'm going to move to the next speaker. Perfect. So I'll introduce the next speaker. Dr. Palumbo is the new chairman of neurosurgery at Mearson Hospital. So the boss of us all. And he is, oh, hold on, maybe there's a, great. So his talk is going to be a bit of a little different than what he spoke about last year and what we had him speaking on our program. I think a little bit more interesting, definitely, and a little bit more cutting edge with a lot of new data. Sal, do you want me to run your slides?
Yes, please, Dr. Bekeles, if you would. Can you hear me okay?
We can hear you great. All righty, give me 2 seconds to share this screen. Share this here, share. All right, and that tags nicely into what Dr. Ahmad was talking about the neurocritical management. And this is a question we get in neurosurgery very frequently about antithrombotics after intracerebral hemorrhage. So Dr. Palumbo, the floor is yours.
Thank you, Dr. Bekeles. And again, thank you for putting this wonderful conference together again for the 3rd year. I wanted to speak a little bit about today with most of us in as being healthcare providers in either neurosurgery or neurology. We run into this frequently, at least once or twice a week, is when is it safe to begin to anticoagulate patients who have a fresh intracranial hemorrhage and are now at risk for some type of thrombotic event, mainly DVT followed by catastrophic PE, or they have stents in, or they have mechanical valves. They have other histories of some type of carotid disease where they were on anticoagulants prior to the hemorrhage. When is it safe to restart these chemotherapeutics? Next slide, come on. Again, that is the fundamental challenge when we're faced with that dilemma. Some of the things we will consider when making these decisions, mainly what anticoagulant was the patient on? Why was it on it? How is he taking it? Is there a higher risk with certain anticoagulants than others? And if there is, which thrombotic events is the patient specifically at risk for? Next slide. Just to briefly recap, I'm sure this data was already hashed on. Approximately 5 to 12% of intracranial hemorrhage in the United States is indeed related to the use of anticoagulants. The most common bleeding because of blood thinners is GI. However, the most fatal, obviously, is an intracranial bleed. The rate of intracranial hemorrhage due to anticoagulants is about just under, somewhere between 5 and 10 per 100,000. The rate of intracranial hemorrhage due to antithrombotics is about 10 times higher than it would be in the general population if they were not on antithrombotics. Next. And which patients who are on antithrombotics, or things like Coumadin, Plavix, and all the new anti-37910s are at risk. Of course, people who are older, especially over 75, those with hypertension, specifically who live at a systolic greater than 160, a history of cerebral vascular disease already, or obviously how badly they're already anticoagulated, especially if they're running around with an INR greater than 4. Next. in the past 15 to 20 years, there have been a lot of studies, mainly retrospective, that, of course, we know this because we, stand in the battle against this all day. Patients who incur or bleed while taking antithrombotics, their outcome is far worse than those who do not. And we have learned in the last 25 years that one of the most important things is to normalize their INR within the first 24 hours. This has a tremendous impact on their prognosis. Next. Retrospective studies also show a better long-term outcome. If a patient had been on an anticoagulant before their bleed, they have better outcomes if they're able to get put back on it after their bleed. Good study looking at about 160 patients was from Toronto. Patients who did not restart their Coumadin had a 3-time higher rate of some type of thromboembolic event than those people who were not on warfarin. And patients who did not restart their warfarin had 2 times higher mortality from all causes. Next. And in the last 25 years, we've learned, again, mainly through retrospective studies, that there is a safety in starting at least IV heparin within 3 days following a primary intracerebral bleed if the patient had been on an anticoagulant. Another good study was from Severa. He found that patients who were able to be restarted on Coumadin at about 1.5 to 2 times their INR, or I'm sorry, 2 times a normal PTT, had no rebleed, showing that restarting the heparin after a bleed was relatively safe. But again, he demonstrated that it was very dependent on their initial coagulopathy, meaning when they come in, they need their INR reversed to normal before starting the anticoagulant. You're going to see this theme in most all retrospective data, that it is imperative to normalize their INR from their initial Coumadin or other type of heparin derivative. Even if they're on a Plavix or an antiplatelet, you need to get their INRs back to normal before restarting anything. Next. This is another study out of Toronto. He looked at just less than 500 patients who had an intracranial hemorrhage who were on an anticoagulant. He demonstrated, of course, that having a rehemorrhage after the bleed, as well as the risk of having a significantly bad thromboembolic event, is directly related on how long it is before you're able to restart their anticoagulant, or at least some form of chemotherapeutic period. Next. You could skip that slide, come on. Yeah, skip that one too. Skip that. What some factors associated with rehemorrhage the study showed was he found that actually patients who were at a younger age were more at risk for rehemorrhaging. And he also found that a traumatic cause of the hemorrhage put them at risk for rebleeding. Subdural blood was a type of intracranial hemorrhage that tend to have rebled more so than other types of intracranial hemorrhages. Again, failure to reverse their initial coagulopathy before restarting anything. And what he did find was the intensity of the coagulopathy was not at all related to whether they rebled or not, meaning they didn't care if he had an INR of 2 or an INR of 20, as long as you normalized it before you restarted the anticoagulant, it had no impact on whether it changed your risk of rebleeding. Next slide. Now, that study also demonstrated that younger patients were also at risk for having their thromboembolic events, such as DVTs, PEs, multiple patients who also had multiple hemorrhages. Non-traumatic causes actually, they found retrospectively, had a higher risk of thromboembolic events. and restarting the anticoagulant at a lower rate than what they were taking before the bleed also put them at risk for having a thromboembolic event. What that means, and you're going to see that theme as well, people who had been on antithrombotics before their hemorrhage tend to be at higher risk for DVTs and other thromboembolisms than those who were not initially on antithrombotics. Next. What patients rebled after restarting their oral anticoagulant. Again, this is from the same study looking at about 500 retrospective cases. People who restarted on their Coumadin along with aspirin had a 2-time higher rate of rebleeding than those who did not. Failure to reverse, again, their initial coagulopathy had a 3-time higher rate of rebleeding after the restart. Interestingly, for spinal surgeons, no patients with spinal hemorrhage ever demonstrated further rebleeding from any of these studies, which is somewhat soothing because we tend to be aggressive with surgery with traumatic spinal cord injury. Next. What thromboembolic complications did this study identify? Most of their patients with these events, just under half of them had some type of stroke or stroke-related incident, such as carotid or embolism from a afib. Cardiac events such as reclotting of the stents, TIAs, which I believe should have been under stroke, even though it's a much different entity. 10% DVTs, 7% were PEs, and about 5 or 6% weren't specified what the thrombotic complications were. Next. The study also demonstrated that there's no statistical evidence of a relationship between why the patient was on the anticoagulant versus a risk of having a thromboembolic event. Meaning if they were on a blood thinner, either for a history of PE, if they were on blood thinners for AFib, or if they had carotid disease, it really didn't make any difference what they were on it for when they tried to see whether they put them at further risk for thromboembolism. They did find that mitral valve replacement patients had a 2-time higher thromboembolic complication than the aortic valve. No one really was able to offer a explanation as to why. Next. Hemorrhagic and thromboembolic complications, according to this study, did occur approximately at the same frequency, but at different times. They found that hemorrhagic complications were seen predominantly within the first 3 days of their presentation, where the thromboembolic events usually happen between 3 and 5 days. There are some that happen much later, but the vast majority they found retrospectively were between the 3rd and the 5th day. Next. This is another study from 2015. Of course, these are all retrospective. They found that DVT prophylaxis should not be started until day 3. Next. There's also several other studies that do review outcomes of starting anticoagulants. Norwood did a retrospective review of just north of 500 patients. They found that just having Lovenox twice a day, initiated 24 hours after the bleed, they had 3.4% progression of hemorrhage, but only 1% of these patients who did bleed required a change in their management, meaning ICP monitor placement or something surgical. We'll skip the next study. Next slide, come on. some more studies demonstrating outcomes of retrospective analysis. Next slide. This was a study, I believe, out of Houston Journal of Neurosurgery. They did actually, no, this is from Missouri. This is a prospective study of about 130 patients that came in with traumatic intracranial hemorrhage. They also had a couple of post-crani patients in there as well. They created an algorithm where they were going to start 30 milligrams of Lovenox twice a day, 24 hours after they demonstrated that their bleed was stable by examining CAT scans. Next. This is their algorithm. The patient would come in with a bleed. This algorithm starts from the top left and then progresses in a counterclockwise. You just follow the arrows. Someone would come in with a hemorrhage. They would get scanned. They would normalize the INR. The next day they would get scanned. If the head CT was stable, they would then restart their anticoagulant or some form of chemoprophylaxis. What's interesting is they shop for an INR of 1.4 or less. In our institution, we tend to look for an INR of about 1.2. We're a little more conservative with that. So as long as their head CTs were stable, their coagulopathy was at, or their INR was at 1.4 or less, they would then restart either the initial oral anticoagulant or Lovenox or heparin. Next slide. This is just a chart of the patients that they entered into the protocol versus their control group, who are those patients they retrospectively reviewed before their protocol. There is a statistically significant difference, mainly in the ISS. The patients that were in the treatment protocol had slightly less ISS, which is injury severity score. They had slightly less injury than those patients who were in the control cohort group. And in the study group, there was a little bit larger population of those patients who had subdural hematomas, which makes them a little bit higher risk. If you look at the retrospective data that I went over just before, people with subdurals tend to have a slightly higher incidence of rebleed. Next slide. So what the study did show was it was very effective in preventing DVTs. If you look at the columns on the left under DVT, they had 0 reports of DVT in 129 patients, which was statistically different than the cohort control group period. They also showed that the length of stay was shorter, but then again, the ISS was somewhat higher in the control group. So I would not put a lot of weight into that parameter. Next. Same study. Final recommendations is less than 1% had progression of the hemorrhage. Only 1 patient developed a thromboembolic event, which I'm not sure how that happened without having a DVT. I guess it's possible. Their conclusion was initiating chemoprophylaxis 24 hours after demonstrating a stable head CT was relatively safe. Next. Again, these are further studies which demonstrated safety and efficacy of using an anticoagulant for chemoprophylaxis as long as the head CTs remain stable. Next study, next slide. I wanted to talk briefly about chronic subdural hematomas, which is extremely prevalent. There's people walking around out there on the streets, driving in their cars that have chronic subdural hematomas and aren't even aware of it. We see it a lot, and it does become somewhat of a management problem because many of these patients are on anticoagulant. And the question then arises and always falls onto the lap of the neurologist or neurosurgeon: do we stop the anticoagulant or not? The incidence of chronic subdural hematomas in the general population is about 33 in 100,000 of patients greater than 65. The risk of having a chronic subdural is 40 times greater if the patient is on Coumadin. And if you ever take them for surgical drainage, they do have a slightly higher rate of rebleed as well. Next slide. Good study also from Canada. Canada gets to do all these big studies, just short of 500 patients, another retrospective review. They underwent surgical evacuation of chronic subdurals. They looked at the type of oral anticoagulant, why they were on it, and whether the patient was reversed prior to surgery. And they looked at the timing of restarting the oral anticoagulant after surgery. Next. Study found patients who were on any form of anticoagulant prior to the surgery had an overall twofold increase in major rehemorrhage, regardless of whether the anticoagulant was or was not restarted. So if you're going to operate on someone with a chronic subdural who is on an oral anticoagulant, they're going to have a 2 times higher rate of rebleeding whether you restart that medication or not. Patients on any form of oral anticoagulant, prior to surgery also had increased risk of developing a thromboembolic complication. Specifically, the speed at which they encountered the problem. They went from an average of 51 days to less than a week if they were on an oral anticoagulant prior to surgery. Again, I touched on this initially, that a common theme is patients who were on some type of anticoagulant are at higher risk for having some type of thromboembolic event than those who were never on an oral anticoagulant. Approximately 50% of thromboembolic complications were unrelated to the original indication. We had made a point of this before. Next. There was no significant difference in rehemorrhage between warfarin, aspirin, or Plavix when the drug was restarted. They did find, however, that no patient who waited a week to start the antiplatelet regimen experienced rehemorrhage. So medications like Plavix, as long as you waited a week, tended to be more on the safer side than the other oral anticoagulants. But what was also found about Plavix is it had probably the worst ability to protect from the thromboembolic events like DVTs and PEs. Again, this is retrospective data. This is not any form of class 1 evidence. This is the same study. Their final recommendation: there is evidence that waiting 3 days following craniotomy to start someone's oral anticoagulant is probably safe for chronic subdurals. Next. Without the retrospective data for the last 25 to 30 years, what the take-home messages are from all that data and what most studies basically consistently reproduce is basic IV heparin can likely be started safely 3 days after someone comes in with intracranial hemorrhage if they're on an oral anticoagulant. They recommend, or they can't recommend it, but having a PTT 1.5 to 2 times that of normal is relatively safe. But as we stated before, their initial coagulopathy has to be reversed and normalized prior to initiating that. Next. Further caveats: patients who had rapid reversal of their coagulopathy following their intracranial hemorrhage had better long-term outcomes than those who did not. again, the golden day or the golden 24 hours, it's kind of like, in trauma, they talk about that golden day or the golden hour with shock. We have the golden 24 hours with reversing the coagulopathy. Also, not only reversing the coagulopathy, but you want to try to get their anticoagulant restarted sometime following their hemorrhage. Those patients are found to have better long-term outcomes if you can, in fact, get them back on their anticoagulant. Patients who receive chemoprophylaxis have less incidence of thromboembolism and better long-term outcomes. Next. Just briefly on cardiac stents, they actually found to be the most resilient in the face of intracranial hemorrhage and having to stop an anticoagulant. They seem to be somewhat resilient to clotting, at least in retrospective analysis. Plavix has the least incidence of rehemorrhage if you wait at least 1 week to restart it, but it has the worst protection against thromboembolic events than any of the other anticoagulants. Next. Again, the retrospective evidence, if you wait about 72 hours to start their anticoagulant, they have both a low incidence of rehemorrhage as well as significant reduction of thromboembolic events. Again, the caveat, you got to stabilize, wait for them to have a stable bleed and completely reverse the initial coagulopathy before initiating anything. Large bodies of evidence, both retrospective and prospective, starting things like Lovenox, anything low molecular weight, after having a stable head CT, low incidence of rehemorrhage, and much lower incidence of DVT. Next. Because of the lack of any of these studies demonstrating level 1 evidence, no formal management guidelines are made by the AANS or the ABNS, but we're in the process of obtaining more, hopefully level 1 evidence, and there's currently studies being done that are prospective and randomized that can hopefully make more formal recommendations in the future. That's it.
Sal, great. Thank you so much. That was a very comprehensive presentation. One of the questions I had has to do with the patients where you have them on something like, say, aspirin or Plavix, an antiplatelet medication, and then they have a small basal ganglia ICH. What's the consensus on those? Because I see a lot more and more folks leave them on the antiplatelet because I would assume it's the it's not as high risk as the anticoagulants. Do you feel that these patients need to get platelets, need to be reversed, or just let them be? Do you stop the antiplatelet, or do you continue?
No, that's a good question. That's always the dilemma and the conundrum that we face. As you said, I see more and more physicians not stopping. I see them not reversing, but holding the medication, repeating the scan the next day, and if there's further bleeding, then they'll go ahead and try to reverse the coagulopathy. And if there's certainly hypertension, they'll treat the hypertension, get them down into normal parameters. But I agree. I see this in my preferred management is to hold the medication, not reverse them, rescan in 12 to 24 hours. If the bleed is stable, hold the medication for a week, but don't do any reversing. Restart the medication in 5 to 7 days. That's the management I've seen. I think that's a solid algorithm.
And are you more hesitant to restart, for example, baby aspirin? Are you more willing to restart it versus Plavix? I would assume so, right?
Yeah, I mean, I think baby aspirin is a lot easier to reverse. Again, I'm certainly not a hematologist, but from what I've seen, I think baby aspirin's a lot easier to reverse in an emergent situation than the Plavix is. So if they get into trouble, I mean, what I'm saying is I'd feel more comfortable with the baby aspirin because I think I can get a better handle on it than I could get a handle on Plavix if the patient gets into an emergent situation.
Right, right. Great. Thank you so much. Thank you for your time and for joining the conference.
My pleasure.
All righty. So I'm going to stop this share and oh, great. So we will get on a 10-minute break now, and then we will come back for two more presentations by myself and Dr. Jabour from Jefferson. So everybody take a little bit of a breather, and we will be back very shortly. All right. See you all. You can stay logged in, by the way. See you all very shortly. All right, we're almost there. We're gonna start the second part of our afternoon session shortly. Thank you for sticking with it. All right, I will get out of this screen. Go back here, skip from that. All right, so all right, perfect. So as we discussed, this morning, we talked about ischemic stroke and all the new stuff when it comes to treatment, medical and endovascular and open surgical treatment. Then we moved into the hemorrhagic part of the day. We discussed a little bit about the medical management of and the surgical management of hemorrhagic stroke. And now we're going to move a little bit more specifically into brain aneurysms. I want to talk a little bit about kind of the evolution of the cerebrovascular neurosurgeon with all the tools that we have available. And then Dr. Jabbour will talk a little bit about more advanced stuff when it comes to treatment of cerebral aneurysm, the new options that are available in our tool kit. And for those of you who have heard him speak in the past, you know that he is a phenomenal speaker, and certainly we are very excited to have him. So I'm going to start with my part, talking about cerebral aneurysms in the era of dually trained neurosurgeons. So, we've evolved a lot when it comes to the treatment of brain aneurysms. And, initially, the only treatment available was open surgical repair of these lesions. You do surgery, you remove a piece of the bone, you go deep in the brain, put a clip on the neck of the aneurysm, and that was the only thing that we had. Nowadays, we have a lot more tools, and neurosurgeons that have trained in most recent years, I would say in the last 15 years, have the ability to offer both treatment options. And that's certainly very exciting and adds a component of equipoise when we are making these decisions and we're offering these treatments to patients. So the goals of this talk would be to describe the national variation of the treatment of cerebral aneurysms, identify the different treatment options available, and then discuss the impact of the dually trained neurosurgeons on outcomes, and certainly show you some of the decision aids that we've been using with patients. So one of the big questions is, why don't we have one unified treatment for everything, right? Everybody has their own way when it comes to that, but that's very common across diseases. So if you look at the country and see the percentage of interventions that are done for several different pathologies that you have listed here, and that's from the Dartmouth Atlas work that we've done in the past, you see this different percentages of these procedures. So despite the fact that the population is in these cases treated in a way that is equivalent between different areas, statistically, you see different percentages of these procedures being performed. So we always think, why is this utilization? Why are the choices different across the country? And then we also have a changing landscape because of a lot more a call for less invasive interventions. And certainly we have that in the brain and with endovascular for sure. And also we know a lot more about data management. So now we can look at our results, we can benchmark our results, and everybody's looking at what we do. So there's a lot more accountability and there's a lot more public reporting. So how do you reconcile these differences with this push for public reporting? Well, we're shifting largely from authority to accountability. In the past, it was whatever we would recommend would be the way, and that would be all. Now there is a lot more input from guidelines and from patients themselves into the decision-making process. So in the small field that we work in, which is obviously the treatment of brain aneurysms, that boils down to the type of treatment we choose to treat these patients. And as I discussed before, that can be either an open surgical repair or an endovascular repair. On the endovascular side, you see coiling of a brain aneurysm in this picture, but obviously there's a lot of different devices and different tools and ways to treat these aneurysms. And really, one of the big drivers of the decision for the type of treatment is randomized control trials. So from our work at the Dartmouth Atlas several years ago, you can see how there is the endovascular treatment for unruptured aneurysms and ruptured aneurysms has gained popularity, and not so much when we're looking at further down the line after the publication of the landmark clinical trial that demonstrated that subarachnoid hemorrhage patients are treated, have a better outcome with endovascular treatment, then that trend plateaued kind of in the most near future. And we didn't see much change after that. And then same thing kind of applies here. But across the country, looking across the country, you see tremendous differences in the rate of endovascular versus open surgical repair of unruptured and ruptured aneurysms. Again, it is really intriguing that you would have areas of the country where you would have 35% of unruptured aneurysms treated with coiling, and other areas of the country where you'd have almost 100% of the aneurysms treated with coiling. And why is that? So we can make a couple of speculations. One is training, right? And as we discussed before, this idea of the dually trained neurosurgeons, which was novel 10 years ago, now it becomes the norm, is important. If you have an area where the majority of treatment is provided by somebody who only coils aneurysm or somebody who only does open surgical procedures, then you'll get that for the majority of the patients. Then, we get into this idea from econometrics and economics of limited diffusion of innovation, where you don't have necessarily the knowledge in the community to refer to the appropriate providers, and then you have the predominant provider offering that one treatment. And then the market dynamics. Obviously, there's interactions between neurosurgeons, neurologists, radiologists, and what have you, and that can create its own microenvironment for the decision. Patient preferences, not so much. They would not really explain those vast differences across the country. Now, on what are these options, right? On the coiling side, like we've discussed before, coiling is really getting into the aneurysm with a tiny catheter and feeding the aneurysm with platinum coils. This is a large aneurysm, obviously, and in this case, treated with coiling. Stent-assisted coiling. So, if the neck of the aneurysm is too broad, cannot sustain those little squigglies inside, then what you would do is you would place a stent on one side to support the coils in the aneurysm, and then place the coils in the aneurysm, and that stent would keep the vessel open. And that's kind of what it would look if you use two stents and the coils inside the aneurysm. There's a lot of obviously artifact in this special CT. Another option is flow diversion, more recent, but certainly extremely powerful. It's a way to place a stent on the neck of the aneurysm. This stent is different than the stent you use to coil an aneurysm. It looks more like a screen door versus chicken wire, which is kind of what the regular stent looks like. And that allows the flow to move forward, more stagnant in the aneurysm, and eventually over 6 months, that results in complete resolution of the aneurysm. And this is what a stent would look like in that location. Clipping, like we discussed before, would involve surgery and placing a pin at the neck of the aneurysm to prevent it from bleeding. Sometimes we combine approaches, and that involves us, say, accessing the carotid artery directly, like in this case, and then stent coiling an aneurysm in this particular case. And that involves both open and endovascular approaches combined. And I'm intentionally not mentioning cellular devices because Dr. Jabbour is going to elaborate on those. He's probably, at this point, one of the world experts in those new treatments of brain aneurysms. So what outcomes, how do the outcomes compare in these different types of treatments for brain aneurysms? When we look at those, and I'm going to go through some studies that we've done on the matter, when we look at those outcomes, we see that there's significant regional variation in resource utilization. People use different techniques, like we've discussed before, to treat similar pathologies. One fundamental question is, do randomized control trials really correlate with real world practice? Are we keeping up with the data out there? And really, we know that there's one study, large study on ruptured aneurysm, what's going on with unruptured aneurysms. We don't have any studies. So starting with those unruptured aneurysms, and again, there's a lot of numbers on the slide. I'm going to walk you through it. No need to read it, but really what we've been able to demonstrate in multiple actually papers that we've published in the Journal of Neurosurgery, Journal of Neurointerventional Surgery, Journal of the American Heart Association, there is no significant difference in mortality between clipping and endovascular care for brain aneurysms, long-term or short-term mortality. There was a higher rate of discharge to rehabilitation from open surgery, which makes sense, and also longer length of stay when it comes to open surgery. All these obviously make sense. Bigger surgery, likely bigger need to end up in a rehab place or needing to stay in the hospital longer, since most of the endovascular treatment for ruptured aneurysm results in discharge of the patient the next day from the hospital. Same thing here, like we've discussed. And this is kind of in a Kaplan-Meier curve where you can see these thoughts. And this is on ruptured aneurysms further down, and similar results of ruptured aneurysms too, actually. And this is based on Sparks data from New York State, so real world experience on the outcomes of these interventions when you're comparing clipping and coiling or endovascular and open care. Now, there is no ability for us to identify if these surgeons were dually trained or single trained in that particular study. Another question that comes up is, okay, well, you know, you're having similar outcomes. Now, the question is, does it matter how experienced the surgeon is in those outcomes? And also if somebody's a hybrid neurosurgeon, meaning this dually trained model, or not. And so we looked at this question again in Sparks data, and you can see here that there was no difference in the outcomes based on whether somebody was a dually trained neurosurgeon or did only coiling or did only clipping. The only thing that made a difference was their experience in that particular procedure. So you see that we see a bit of a plateauing of your outcomes based on your annual volume of coiling. So if you did more than 10 to 20 coilings a year, you ended up having very similar outcomes as the rest of the folks that did more. But if you did less, your mortality or your complications were a lot higher. And the same applied to clipping. Actually, clipping was a lower volume to achieve your steady state. And sure, there is obviously a correlation of volume with outcomes, and dual training doesn't seem to matter as long as you're capable in both. Does it matter though what hospital you go to? It seems to be the case. So in a study we published in JAMA, we showed that centers of excellence actually had a mortality or a survival benefit when it came to the treatment of stroke patients, meaning ischemic and hemorrhagic stroke, including brain aneurysms, and that survival benefit was most significant at the 30-day mark. And so obviously there's definitely from the data that we see, your training is not so much important in terms of if you're single trained, dual trained, whatever have you. What matters is the ability to be in a hospital that can provide these excellent services, but also your volume and your ability to perform these procedures. And you know, when we're looking at the surgical side so intensely, we also want to know if there's anything on the medical side that can help these brain aneurysm patients. And in a study we did in the past, we couldn't really find, we looked at aspirin, we looked at statins, there was no real medical treatment. So the medical side didn't really affect the trend in the different treatment options available for these patients. Now, how would you be able to bring these generalized outcomes to the individual? How can you make these predictions significant for the individual patient? I think that's very important for patients to make decisions, especially in the setting of multiple treatment options available. And we try to do that by utilizing large data sets, validating the results, and trying to facilitate shared decision making. And this is the predictive model that we discussed earlier in my first presentation on carotid disease, and multiple other studies. And this creates these predictive tools that then we can use to extrapolate and make decisions on the individual. We have a lot of national work being done right now through the NeuroPoint Alliance and the Quality Outcomes Database for Neurosurgery, and that can facilitate these studies even further and give us even better data to come up with individualized predictions. And this is from a study we did back in the day based on the NTQOD, and it was talking about spine and other outcomes in neurosurgery. But at the end of the day, what we want to do is take individualized data, put it into our data sets that obviously can make predictions and offer the patients meaningful measures for possibilities of mortality, neurological compromise, durability of treatment, very important when it comes to clipping and coiling, patient satisfaction, and quality of life. One of the clinical trials we have ongoing here at Good Sam has to do with shared decision-making and participation in the decision-making process, especially when it comes to deciding between open and endovascular treatments. And this is an ongoing clinical trial that I've spoken about to earlier in the day today. And that is the goal of this trial, is to integrate those ideas and try to get the patient into the decision making process. Now, in conclusion, I think the question of endovascular versus open repair is not a relevant question anymore. What really is important is that providers have the ability to offer all available treatments. And if you don't have that ability, probably you shouldn't be treating brain aneurysms. And you know, the dually trained neurosurgeon of today should utilize all their tools at their disposal to minimize the impact of the disease with the lowest morbidity and mortality. So whatever makes sense in your hands, and obviously consult with your community and your fellow surgeons. So obviously we don't want to be in that situation as neurosurgeons. We want to be more in this situation. And that's why I think the impact of dually trained neurosurgeons has been dramatic. And a lot of us that have trained under folks like Dr. Jabbour appreciate that a lot. With that, I wanted to finish a little early so that I give Dr. Jabbour a little extra time, because his presentations are always very enjoyable, and I feel that we're always short on time. But if you guys have any questions, I'll take them. Otherwise, I will move on to the next speaker. Excellent. I will get Dr. Jabbour up and running in a second, and we will enjoy his presentation. There he is. He's the man, the myth, the legend. All right. So Dr. Jabbour is a professor of neurosurgery at Thomas Jefferson University. He has a lot of titles. I guess the most important title that he'll tell you is that he's working to become a master sommelier. And one day I'll enjoy a dinner organized by him. But really, he is one of the pioneers in the treatment of cerebral aneurysms, both open and endovascularly. He's revolutionized techniques both in access issues when it comes to radial access and bringing radial access to the neurointerventional suite, and also in new device development and use of new devices and clinical trial participation, answering questions, especially in the middle of the pandemic. And so really one of those folks that we all look to get advice from time to time. And so it's with great pleasure to welcome him to our conference to talk about saccular devices. Pascal, feel free to share your screen and take it home. Thank you.
All right, can you guys see my screen? Okay, thank you for the invitation, Kimon. You know, what you've built in up there is something really phenomenal with all the team that you have. You have an outstanding team, and I'm really happy to see year after year follow your success and everything you're doing. Again, thank you for the nice introductions. Thank you for having me to lecture this year. I thought after last year's lecture I'll be banned, but I guess I wasn't. Okay, I'm going to be talking about intrasaccular devices. Practically, it's intrasaccular device, not devices, because there's only one that's FDA approved now. But I'll tell you a little bit about some others. Those are my disclosures. So it's with all the evolution and the technological advancements that's happening, I think it's very important for us to remain focused and to stay disease oriented. It's very easy to fall in the trap and start, you know, advertising for a tool and forget about the disease, but that's not the right thing to do. We should always remember, like what Kimon said earlier, that we are here to treat the disease regardless of the tool. It's not a competition of tools, it's just all the tools that you have against the disease. So I think we should stop advertising for a tool, and we should always make sure that we're being objective in choosing the best for the patients. So what's disruptive innovation? And we are seeing more and more disruptive innovation, not only in neurovascular, not only in medicine, also in all different aspects of modern life. So disruptive innovation is a term that was used first by a Harvard Business School professor, and it's the process by which a product emerges into an existing market and then relentlessly displaces established competitors. And if you think about so many examples of that, and in neurovascular, we've seen a lot of that. So even Homer evolved. Unfortunately, Homer's brain didn't. His body evolved, but not his brain. I hope that, our brains are evolving while we're using all those new devices, because it's very important to choose what device to use and how to use them and how to choose the best patient for the best device. So practically, sometimes we play matchmakers because we're going to match the best device to the best patient. It's not all size fits all. One size fits all, I mean. So what I'm going to be talking about is this device. So this is the web device. That's the only intrasaccular device that's approved in the US. And like what you're seeing in the movie, the only difference is it's not 2 layers anymore. It's only 1 layer. You're going in, you're deploying the cage in the aneurysm, and then you're getting out of there. So as compared to coiling, where you need to go coil after coil after coil, and detach the coil and worry about herniation and things like that, this is just one device. You detach it, you're done. It's fast. And this was the WEBIT trial. This led to the FDA approval of the web device. We were part of the web trial. And then what the web showed is that the web device in 147 patients had good safety profile and good efficacy in treating brain aneurysms. If you see here, the risk of major stroke at 30 days was 0.6%, no death. And at 31 to a year, it was also good. So at angiographic follow-up at 1 year, now we introduced a new, something new that we haven't been used to, which is having a little bit of neck remnant. We're all used to having a complete occlusion of an aneurysm. Of course, when we clip, that's the ultimate treatment of an aneurysm. You clip it, it's gone, that's it. And then when we coil, you can keep on packing, and then until you don't see it anymore. Here, you see that they included into a new subset of patients that they called adequate occlusion. So we need to start from a standpoint here that we all agree that adequate occlusion is acceptable. We still don't know yet. It's still too early. But we're saying that this equals this equals this. That's what we are saying. this equals this equals this in protecting from a brain hemorrhage. Of course, from an aesthetic standpoint, it's not equal, because from an aesthetic standpoint, while you're looking at the picture, of course, I want to see something perfect like that. I don't want to see a neck like this or a neck like that. But if we are able to demonstrate that all those are equivalent in protecting from an aneurysm rupture, I guess this would be good. Anyway, so the trial show, and this is still up, for the jury, and it's still controversial. So, so the trial showed that we can have adequate occlusion in 84.6% of the times. Progression and stability. So it showed also that 91.5% of the aneurysms got better occlusion between the time of treatment until 6 months. 9.2% got better from 6 months to 12 months. Then 3.5% stayed the same the first 6 months. And then 79% stayed the same from 6 months to 12 months. And those are the important category here. 5% got worse first 6 months. 11.5% got worse 6 to 12 months. Got worse, it means we have a recurrence. So we're not at the point where we're talking flow diversion technology, because we all know with flow diversion, once an aneurysm is gone, that's it, it's gone. And rare are the devices where you can say that once an aneurysm is gone, it's never coming back. So we know that this is not a device where we can say if at 6 months it's gone, it's not going to recur. It will recur, but maybe at a lower rate as a coiling or stent-assisted coiling. Again, so overall, those numbers are acceptable. Retreatment, so 5.6% retreatment rate within 12 months. How did they retreat them? Either coiling, stent coiling, or flow diversion. And then additional 6 patients underwent retreatment beyond 12 months, bringing up the overall retreatment rate to 9.8%, which is not a really high number if you consider all endovascular. So as you know, endovascular is a trade-off, right? You cannot compare it to clipping. With clipping, it's more invasive, but once you clip, that's it. You don't have a recurrence. In endovascular, regardless of the technique you use, you're going to have a risk of recurrence. That's why I tell my patient with endovascular, it's a package. It's treatment with follow-up with possible retreatment. With clipping, that's it. You clip, you're done. So, and those are some cases, old cases from the WEBIT trial that I enrolled in WEBIT 5 years ago. You see an MCA aneurysm here before and after, here on 3D, really nice results. Another large aneurysm, an MCA aneurysm, you see before and after, completely gone. Another MCA aneurysm, you see here before and after, and so on. I can show you so many pictures. And also you can follow them with MRAs with no artifacts. So this is an MRA of an ACOM aneurysm treated with WEB, showing that you can follow those with an MRA, which is also good. So this was the first paper on ruptured aneurysms treated with WEB after FDA approval. We published it in Neurosurgery, and we looked at cases of aneurysms that ruptured that we treated with WEB. And we wanted to make sure that we didn't have any re-rupture, because at the end of the day, when you're treating a ruptured aneurysm, you don't want to have any re-rupture. Then to have a perfect result, well, you can wait until the patient recovers. If they do well, then you can bring them back and reclip them or do whatever you need to do. But acutely, you need to make sure you're safe and you don't have a re-rupture. And in this series, we showed that there was no re-rupture. Those are the cases that we've treated: VB junction, PCOM, basilar tip aneurysm, ACOM, pica, ophthalmic, etc. And we didn't have any re-rupture of those aneurysms. Then after that, we had a big collaboration in the country about treating ruptured aneurysms in WEB. Those are the cases that were treated. So in general, bifurcating aneurysms, ACOM, middle cerebral artery, basilar tip, and then some off-label, as I showed you earlier. Those are the sizes. So 94 ruptured intracranial aneurysms, successful deployment 97.8%. 13.9% death. Again, those are ruptured aneurysms. We're talking overall death, not specifically related to the device. 1 patient had to be clipped, 3 stented, no rebleed or delayed rupture, 80% adequate occlusion, 87.8% favorable outcome at 90 days, and 4 had to be retreated during the follow-up, which we do it in coiling or in other stuff where you have a high-grade patient, you treat the aneurysm, maybe 80%, you protect it, let the patient recover, you do a 6-month follow-up angiogram. At that time, you can clip the patient. This would be an elective procedure as compared to clipping it acutely with ruptured aneurysms. Those are the complications that we had in this series. So then we collaborated with Iowa on publishing the off-label use of web. As you know, in every device that's FDA approved, it's used also off-label. So we treated VB junction, PCOM, ophthalmic, pica, pericallosal, cavernous aneurysms with web device, and it is feasible to do that. So this is a PCOM aneurysm. As you know, simple coiling wouldn't be good here because there's a big PCOM. It's a fetal PCA. You see the vessel coming out of the neck, and you see here after treatment how the vessel is still patent and the aneurysm is gone. A carotid ophthalmic aneurysm with the ophthalmic artery coming off the neck of the aneurysm with the web device also gone with the ophthalmic artery open. Another PCOM aneurysm, ugly PCOM here, treated with the web device with a good result. As you know, the web device is limited with the sizes. So what if it's a bigger aneurysm? Well, you can use 2 web devices. This is another case discussion, multiple aneurysmal web devices that we talked about that. Web assisted stenting or any other technique. As you see here, this is a pipeline assisted web device, and or coiling the dome if the aneurysm is too big, then placing a web and corking the neck with the web. So everything is feasible as long as you're safe. This is our series of aneurysms treated with web. It's gonna come on in Journal of Neurosurgery. It's in press right now. So from February 2019 until January 2021, we treated 115 aneurysms with web. 34 of them were subarachnoid hemorrhages, 81 unruptured, 92.2% were treated successfully, 1 complication, 5.5%, 1 death in this series. And then contrast clearance, I'll show you later on what I'm talking about. So once you deploy the web, you're not expecting the aneurysm to go away right away, like in flow diversion, but having contrast stasis is important. And we published a paper showing that this is correlating with the occlusion later on. So 52.6% had follow-up angiogram. We had complete occlusion in 63.3%, neck remnant in 23%. If we want to talk the language of WEBIT, adequate occlusion is around 86%, aneurysm remnant in 13.3%, and 6 required retreatment for persistent aneurysm residual on follow-up angiogram. We also published a paper, we're publishing a paper showing how we do the retreatment of WEB. Those are the characteristics of our series. I'm not going to bore you with that. But something important, this is from our paper, the sizing. The sizing is very important. At the beginning, we didn't know that. Then we learned it. So the way you're going to size web is you're going to take it and then you're going to oversize the width. You can oversize by 1, 2, as much as you want. If you oversize a lot, you need to shorten a lot. Because if you are oversizing, you're going to place the web, it's going to elongate because it's compressed. At that time, you need to shorten much more than the aneurysm length. And then this is the idea of corking the neck. As Kimon told you, the word corking is dear to me. I like the word corking or the word cork. So corking the neck is regardless of the shape of the aneurysm, you're gonna deploy the web proximal to the neck. So block the inflow in the aneurysm and you don't care about the rest, it's gonna thrombose. I'll show you some cases of that. Why we should oversize the web? Because it will prevent compression. Because in the recurrences that we've seen, we look at the device, it's compressed. So if you oversize the web device, for example, this tube diameter is 8 millimeter. Here we placed an 8x6 web. It's not oversized. If you put pressure on it, what's this weight here, the pressure? It's the pounding of blood. It's gonna compress, so there is a recurrence. But if you have an oversized device, here we placed 9x5 on an 8 millimeter diameter. At that time, it's oversized. It's not gonna get compressed easily. You won't have a recurrence. Here, another picture showing you what's the best way of deploying it. It should be neutral. If you're pushing too much, it's not good. If you're pulling too much elongated, it's not good. So that's the best position. Corking the neck. So look at this aneurysm here. Look how it looks like. What I did is I put a web here and it corked it. And the way I placed that, so if you see here, I'm placing the web, then I'm gonna pull it toward the neck. So you see here, right upper corner, I'm pulling the web to cork the neck. Here it is, I pulled it. And this is immediate occlusion. As you see here, complete occlusion right away. So this is corking the neck. Another PCOM corking the neck. If you look here, the web ends here. That's it. And the aneurysm is as big as here. So you see all the stasis of contrast here and the web ending here. We don't worry about sizing it to the rest of the aneurysm. Another cork the neck. You see here the shape. What I did is I placed a web just there, just here. And this will cork the neck. This is one of the most recent papers we've published, predictors of aneurysm occlusion following the web device. And then when we looked at that, we showed that the stasis of contrast is the most important predictor. What I'm talking about is this. Look at that. So when you have stasis of contrast until the venous phase, that's the best predictor of occlusion. Negative predictor of occlusion is hypertension, large aneurysms, wide neck. Those are negative predictors. So in this paper, we looked at our series and the literature, 358 aneurysms treated with web. And as I said, contrast stasis on the post-deployment angiogram was a significant predictor of aneurysm occlusion. Wider neck, irregular shape, smoking, hypertension are negatively impact occlusion rate, like in general other endovascular treatment. How does the web look like in the OR? This is one of the first pictures of web in live in the OR. This was a patient that had multiple aneurysms. They webbed the first one. They couldn't treat the others, so I had to take the patient, clip the rest just right away after the web was placed. This is how it looks like. Retreatment strategies. This is from our paper that's going to come out in operative neurosurgery about how to treat web recurrences, because this is something where some people were saying, how are you going to treat the recurrence? It may be difficult, it may be complicated. Well, there are different ways of dealing with this, but from our experience so far, it depends on where the recurrence is occurring. It can be manageable. So this is a case of a patient that presented with a ruptured aneurysm. As you see here, the patient had an aneurysm pointing down. I treated the patient with a web device, then COVID hit. 6 months, in 6 months, I called the patient to get an angiogram. Patient refused because of the COVID. So we did an MRA. MRA showed complete occlusion at 6 months. Then the patient got lost to follow up because of COVID. Then the patient presents with a intraparenchymal hemorrhage, another rupture. When we did the angiogram, if you look at it first, I said, oh, wow, look at this. But then if you look at it, the aneurysm is 100% occluded, the one that we treated with web. It was pointing downwards. There's a new aneurysm pointing up. So practically what it is, so this patient had a diseased bifurcation more toward the M2. And we were able to treat the aneurysm, but the patient formed a new aneurysm from the diseased bifurcation that's pointing up. What we did is we coiled it, and then the patient, did okay. Another patient from the WebIT had this ACOM aneurysm that was treated, was doing well, stasis of contrast, then had a compression. At 5 years, we had a recurrence that got worse. As you see here, how the web is compressed, it's completely compressed. We were following a small neck, which was fine, but then recently it got bigger. At that time, we said that, no, we need to treat that. She was a young patient. She did not want any clip. So I did an Y stenting and coiled her in here. A case of an aneurysm, an MCA aneurysm treated with web. We had a very good stasis of contrast, but then big recurrence, see the compression of the web. In this case, we did also Y stenting. The patient wasn't a good candidate for clipping. As you see here, we coiled it, we Y stented it and did well. I've clipped now 4 web recurrences. This is one of them. So practically web recurrence is clippable. The web is crushable. You can crush the web with your clipping, with your clip, which is not a big deal, as compared to coils where sometimes you need to open the aneurysm and pull the coils. Here you can go and clip and crush the web. This is the web. This is the recurrence. It's a PCOM. And then even if you don't have a big neck, you're able to crush it and clip it. And that's the aneurysm clipped. This is initially when I treat the aneurysm treated it with the web. This is the 6 months follow-up, and this is the neck that I clipped, and this is the intra-op angiogram showing 100% occlusion. Comparing the web with other techniques for bifurcating aneurysm, this is a manuscript that we're just submitting about a web device versus stent-assisted coiling in bifurcating aneurysms. We looked at our stenting of bifurcating aneurysms compared to web, and comparing both, they are comparable at 6 months with complete occlusion rate. Web appeared to be associated with lower rate of neck remnant at 6 months compared to stent-assisted coiling, and it was associated with fewer complications compared to stent-assisted coiling. Of course, we need more prospective randomized trial to confirm that, but this is a retrospective study on this big series that showed this. Complications, it's very important to understand the 3 phases of the web device when you're deploying the web. The first phase, when the web is still coming out of the catheter, this is a spear. This is very, hard, it's not soft, and you can rupture the aneurysm, so you need to pay attention. Once you have this, you need to unsheath, and then once you have this device opening, at that time, this becomes soft, and then you can push it. This is unfortunately a case where we had a ruptured aneurysm with the web device here, all the way you see the extravasation. What about Web 17? Web 17 is the new web that's low profile. You can put it in 17 microcatheter. We have now around 10 cases. It just got approved in the US. It's a lower profile. It's much easier to go and treat distal aneurysms. Much smaller microcatheter. It makes a big difference. Here, it's an ACOM treated with the Web 17. The only thing is, I think the Web 17, you can deform it much easier. It's softer, so when you're manipulating it, it can get compressed much easier. And it's very stable. As you see, we're coming up with the web device. It's not moving the microcatheter. Usually with the other one, it's bulky. It can move the microcatheter. And here, we're showing the deployment. I'm gonna keep another ACOM aneurysm treated with the web device, Web 17. Etc. So it's a low profile, does not need much support, more stable while pushing the device, but again, maybe it's more unstable, and we need to wait and see the recurrences if there are more recurrence. If the recurrence rate is higher with the web. A new device, the contour device, this is half a web. Okay, this is a device, as you see here, this is like a wine glass. See, everything goes around wine, revolves around wine, either cork the neck or wine glass. So what you do here is you're deploying it at the neck of the aneurysm. You don't have to worry about sizing it. So you think of it as a half a web. The trial already started. I'm the national PI for the trial, and we have good European data so far, but we're gonna do the trial in the US. So if you see here, this is the device getting deployed in vitro. And it will catch the wall, and then you would detach it. And here's the contrast being injected, and you see the stasis of contrast in the aneurysm. You can do it with coils. The trial is without coils, but you can do it also with coils. Those are some examples of from Europe of a contour device showing a complete occlusion. Another device, there's a trial now, the Citadel device. And what's interesting and important, it's the first in human US feasibility study. Usually those devices, first in human, is done outside the US. It's always in Europe or other places. This is the first time we do a first in human. And this is, it's like a fat, it's like a big coil that would go and create a 3D shape. It's like the Medina coil, that it's leaflet, a coil with leaflet. You see the picture here. And it's between 6 and 12 millimeters where you would go and deploy it. And then once you deploy it, it will cover the neck. At that time, you can deploy regular coils in it. We're going to start enrolling at Jefferson very soon. The PI is Ansar Rai from West Virginia University. And we're going to take a look at this device and see. So this is the case, courtesy of Ansar. You see this, Citadel device getting deployed first, then the coils, and this is mainly for bifurcating wide neck aneurysms. So you and the web, or you and the new devices, it's like Match.com. You get to know each other, you and the device. You get to anticipate the reaction to your action, exactly like dating. You get to learn to avoid embarrassing situation. You get to know how to ask, what to ask, how much to ask, and what to expect. And you should avoid pushing to a nervous breakdown like you do with a partner. Remember, some wounds are not repairable, and you should stay open-minded and don't be judgmental, exactly like in dating. Try to listen to your device. This is very important. Here, unfortunately, the tragic, really, he died because no one knew his blood type. And the wife said, I'll never forget the last inspirational words he whispered to me. He said, be positive. Well, the poor guy, he was telling them his blood type. And then, you know, in everything we do, we should try to learn from our mistakes. Very important to do that. So this sheep got rescued, but what's next? Boom, the same thing, you know, didn't learn from the mistake. And again, you know, we're playing always with new devices, so don't let the tool control you. Try to control the tool.
Toyota and Lexus luxury models will come with Amazon Alexa.
Alexa, turn on the AC.
Turning on AC.
Finally, a virtual assistant to help you navigate.
Alexa, where's the nearest gas station?
Nearest gas station in 1.5 miles.
And to help maintain your vehicle.
Alexa, order more brake pads.
Ordering new brake pads. Although maybe if you didn't stop so close to the car in front of you.
I left plenty of room.
You drive too aggressively.
If you were just quiet for 2 seconds, 2 seconds.
She'll talk to you literally the entire time you're driving.
I think you should have turned back there.
I know where I'm going.
You know why I pulled you over?
No, officer,
Because we were driving 72 miles per hour in a 45-mile-per-hour zone.
Anything else I should know?
2 miles back, we rolled through a stop sign without coming to a complete stop.